Hello and welcome to day 2 of the Cleveland Clinic Critical Care Conference, Views from the SARS-CoV-2 Frontline. I'm sure quite a few of you were here yesterday for a very successful day 1. So I'd like to say a big welcome to all the audience and to the faculty. And I'm going to hand you over to my colleagues Luigi Camporota and Georg Auzinger, who are very much the architects of this conference.
Thank you very much, Nick, and hi everyone. As Nick said, we had a great day yesterday, and if you were not here with us yesterday, I strongly urge you to watch it again, because there will be a recording available after the second day. And just briefly, yesterday we touched upon several important topics that we all lived through during COVID pandemics. So we looked around the public policies and the impacts on response to pandemic. We looked at the roles and the limitations of prediction modeling, and then we went around the table to think about how each country got ready in terms of testing, containment, mitigation around the US, UK, and Middle East. And then again, we had a session on the pharmaceutical therapeutic options. And there was a great session reviewing all the evidence around steroids, immunomodulation, and anticoagulation. We learned about what to use, when to use it, how to monitor anticoagulation. And then after a short break, we went to the clinical data session, and we looked in detail on the phenotype, the stratification in terms of patient level data to think about outcomes and how these outcomes change around the world. And we had a focus obviously around London and the UK, the US and the Middle East. And then finally, in the last part of the day, having looked at the patient level outcome factors, we had a final round table looking at the structural and organizational effects on outcome, particularly the effect of ICU strains and hospital strain on patient outcome. And that was the end of the day 1. And obviously I'll pass it over to Georg, and we'll tell you what we'll do today. Georg, over to you.
Thank you, Luigi and Nick. Again, good afternoon, good morning, and probably good evening, almost. I think we are looking forward again to a quite exciting day, I hope. We will hear, to start off with, all matters ventilation, starting off with non-invasive ventilation, and then, if you want, to the most advanced treatment options we've got at our disposal, which clearly also in COVID have been used increasingly, that is extracorporeal support methods. I'm looking really also forward to hear some early experience and maybe a bit of a review of what's happening in the field of transplantation around this disease process. And then at the end of the day, we will concentrate on human factors. And I think we're all aware of how much strain this disease has put on the workforce, especially our nursing colleagues. So I think we're really looking forward to a number of very exciting talks, finishing off at the end with long-term sequelae of the disease, and we probably will be presented with some early data around long COVID and follow-up of these patients now almost 18 months plus into the pandemic, or pandemics, if we want to call it that. A few housekeeping things again. Hopefully we won't have too many troubles from an IT perspective. There may at times still be some delays. We've had some audio issues earlier, which hopefully we have resolved. If you have got animations in your presentations, please do give Maria a prompt and she will forward accordingly. And I think that is really it. And I'm really looking forward to the first session, which is a roundtable discussion. And we have got on this session Dr. Hatipoglu and Iqbal, both from Cleveland Clinic, Ohio, John Aaron from St. George's Hospital, who'll be joining us here at Cleveland Clinic London, and Luigi, who all of you have already met a lot yesterday, and you'll hear a lot from him again today. Over to you.
Right, shall I go, Luigi?
Yes, please, Umar. Looking forward to your talk.
Okay, perfect. Well, I'm delighted to be here. I'm Umar Hatipoğlu. I'm staff intensivist at the main campus of Cleveland Clinic. I also serve the role of Enterprise Medical Director for Respiratory Therapy and oversee our activities in our 17 hospitals in the US. So my task today is to talk to you, provide an introduction for NIV for the management of COVID and non-COVID ARDS. Next slide, please. So as you know, non-invasive ventilation refers to application of positive pressure through an interface placed outside of the airway. And these interfaces may be in the form of face masks or a hood or helmet. And the applied pressure could be constant, i.e. CPAP, or could be increased during inspiration to provide ventilatory support, i.e. bi-level positive airway pressure. Now, these two are conflated in the literature, so you actually need to read into the paper before you figure out what is being applied. But we are pretty much resolved on what they do. They reduce work, these interventions reduce work of breathing by improving functional residual capacity and respiratory system compliance during which tidal breathing occurs, and by directly unloading respiratory muscles. NIV also has the beneficial hemodynamic effect of reducing cardiac afterload and preload. The efficacy in reducing intubation and mortality is well established in the setting of heart failure and ventilatory failure of COPD. Next slide, please. Now, the same could not be said, however, when you think about acute hypoxemic respiratory failure. In this study from 20 years ago, Antonelli and colleagues looked for risk factors for NIV failure among 354 patients with hypoxemic respiratory failure. As you can see, NIV failure risk was highest among patients with ARDS or community-acquired pneumonia. In essence, use of NIV was considered a risk factor for poor outcomes for the very condition which we're considering it today. Next slide, please. More recently, similar insight was gained from the LungSafe study, large observational multi-center study on ARDS. In a sample of over 2,800 patients with ARDS, 15% of whom received NIV, use was associated with increased ICU mortality. And the mortality risk was increased for those patients with more severe oxygenation impairment. High risk of mortality, although not statistically significant, persisted with propensity match samples of patients with more severe oxygenation deficit. Next slide, please. Now, this is, I think, an important study, I'm assuming most of you are familiar with, by Ferrero and colleagues, who conducted a network meta-analysis using 25 randomized controlled studies comparing high flow oxygen, face mask NIV, and helmet NIV with standard oxygen therapy. A network meta-analysis draws indirect conclusions about two interventions which are not compared head-to-head, but with a common comparator, in this case, standard oxygen therapy. These studies did not include COPD, CHF, immediate post-extubation patients, because these are patients for whom NIV use is established. The primary outcome was all-cause mortality, and endotracheal intubation was, I think, the most interesting outcome they looked at. Next slide, please. So this analysis revealed a reduction in mortality compared to standard oxygen therapy when NIV was used. High flow oxygen did not have a statistically significant event. If you can click one more time. In pairwise comparisons, helmet NIV was superior to high flow oxygen and face mask, but there was no difference between face mask and high flow. Next slide, please. For the secondary outcome of endotracheal intubation, all modalities resulted in a reduction compared to standard oxygen therapy. Again, there was no difference. Can you click one more time? Again, there was no difference between face mask and high flow, but better outcomes when using helmet interface in pairwise comparisons. Next slide, please. Now, I would say until recently, NIV studies in COVID-19 were unfortunately limited to uncontrolled retrospective observational case series where there was no standardization of care or delivery settings due to resource limitation mostly. Reporting was incomplete in earlier reports with a wide range of hospital survival ranging from 14 to 95%. Next slide, please. Now, I think you get the flavor that helmet interface shows promise in the treatment of ARDS. Helmet NIV could be used in pressure control CSV mode or CPAP mode and requires continuous flow to facilitate washout of carbon dioxide. A clear advantage is the ability to apply higher positive and expiratory pressures without the notorious problem of a leak that would occur with a face mask. However, tidal volume measurement is not readily available, and although facial pressure ulcers are prevented, upper limb edema and injury can occur. Next slide, please. Now, to my knowledge, there are only 2 randomized controlled trials of NIV in COVID-19 associated respiratory failure, and only the study by Grieco and colleagues has been peer-reviewed and published. This is a small but well-done randomized controlled trial comparing helmet NIV and high flow. This study revealed no difference in days free of respiratory support, which was the primary outcome, or hospital mortality between the 2 modalities. However, as you can see in the graphic to your right, the rate of intubation and invasive mechanical ventilation use were lower in the helmet group. Next slide, please. Now, a concern for NIV use in COVID-19 is the potential for higher risk for disease transmission. This is largely based on a systemic review, which was performed pre-COVID. The data during COVID has been contradictory, with some suggesting increased risk and others finding none. Next slide, please. So in light of these observations pre-COVID and during COVID, we suggested reserving the use of NIV for patients who had concomitant COPD or CHF who had better oxygenation. Next slide, please. So in conclusion, on this side of the pond, we felt that NIV was feasible but hesitated to use it liberally due to potential high risk of disease transmission and no clear evidence for superiority over high flow. We did not have the helmet interface for our use due to supply chain issues, but clearly this interface shows great promise. Next click, please. While there was no proven benefit for non-invasive modalities in preventing mortality, there is a role for sparing invasive ventilators, which is of value in the setting of a pandemic. And we do recommend, of course, when applying NIV, early and frequent monitoring of clinical status, particularly paying attention to exhale tidal volume, respiratory rate, and oxygenation to optimize outcomes. So that's my opening spiel, Luigi.
That is great. Thank you so much for reviewing all the very important literature around the subject, being so sort of very good. So I'm going to move towards the ventilation side now. So Maria, please. So I'm going to show you this busy algorithm just to say that there are essentially 3 or 4 things I think would be quite useful to consider when we have a patient, particularly whether the patient is on high flow nasal cannulae or is on non-invasive ventilation, as we have heard. And one of the things is clearly the concentration on the PF ratio, the carbon dioxide, so the gas exchange. But obviously, one of the things that's come very strong in the COVID-19 was the high respiratory drive that some of these patients had. And as respiratory drive increased, the respiratory effort increases. And as the respiratory effort increases, obviously the transpulmonary pressure and the total lung strain increases. And we have seen lots of reports in COVID-19 of spontaneous pneumothoraces, spontaneous barotrauma. And that is what has been named previously as patient self-inflicted lung injury. So the first thing we need to think about once we've discussed about gas exchange is what is the risk of this patient in terms of PCL. So one of the useful things would be to think about work of breathing and respiratory drive. Now, which is quite difficult sometimes, because one of the things that we can do, if you go next, Maria, please, we can start for some of the clinical assessment. Now, clinical assessment can be done just by looking at respiratory rate, but I'll show you later on that respiratory rate is a very late sign of increase in inspiratory effort. So one of the things that's been developed, and I found it quite interesting, we are starting using in our hospital, is look at this qualitative a scale of worker breathing. So you look at the respiratory rate and you monitor the rate and you assign a point. You inspect the nasal flarings of whether they are present or not, and you assign a point. Then you palpation of the sternocleidomastoid, which is an accessory inspiratory muscle, and then look at the abdomen and palpate the abdominal muscles, and that will be in recruitment of expiratory muscles, and that will give you an indication whether or not the patient, regardless of the gas exchange, whether this patient is struggling with non-invasive ventilation. Now, we don't have space in terms of time to discuss all the evidence around there that has been accumulated in COVID-19, but essentially a very high inspiratory effort has been associated with a failure of non-invasive ventilation and more intubation. And there is some data coming out from our group indicating that these patients will have a longer length of stay if they fail, and possibly worse outcome. But again, if you go next, please. This is one of our studies that basically shows that when we want to incorporate something that is almost an indication, a proxy indication of inspiratory drive, and we said is a late indicator, which is the respiratory rate. So when we look at ROX index, for example, in COVID-19, which is essentially SpO2 divided by FiO2 divided by the respiratory rate, you can see here how the SpO2, the PF ratio, they are very late indicator of failure, and the hemodynamics doesn't really help. But what it does change is the ROC index, and the ROC index can change up to 10 hours before an unpredicted event. If you go next, please. So then we move to the second part, is that what I'm trying to say with the first part is just think about the gas exchange, but also think of the respiratory effort, because that is important. Now, once we establish the patient on mechanical ventilation, then we start normally with a sort of a medium PEEP, which is basically 5 to 8 centimeters of water. We start with a medium, moderate tidal volume of 8 mils per kilo, and I'll show you why we start with that pressure. And the first thing we do is we look at the driving pressure. And with that tidal volume, is the driving pressure greater than 15? And if that is the case, we reduce the tidal volume until the driving pressure is less than 15. But if with 8 mils per kilo, the driving pressure is still very, very low, we avoid inducing hypoventilation by decreasing the tidal volume. And there is demonstration, we've done some sort of computer modeling using CT scan data, that you can see that actually if we use a lot of hypoventilation, we can increase the shunt fraction and worsen the hypoxemia. If you go next, please, Maria. So this is just an interesting study, which obviously from the LungSafe group, we've discussed yesterday about the L and F and NH phenotype in the COVID-19. So they've done the same study using ARDS from all causes. So what you can see, if you go next, please, Maria, you can see that the L phenotype, the one with a high compliance, those were about 12% of the patients with all-cause ARDS. They were ventilated with 8.5 mils per kilo of ideal body weight, tidal volume, which, if you look at the guidelines, would be considered above what is considered to be protective. But also look at the driving pressure. The driving pressure was only 7.6 centimeters of water. Now, if you compare it, next please, Maria. If you compare it with the H phenotype, so the patients had a very small lung volume and therefore a low compliance, then superficially you can say that they were ventilated in a much more protective way if we look just at the tidal volume, because it was lower, 7.5, but the driving pressure was 17.3 centimeters of water. And I think that's quite important. Next, please, because when we look at all the studies, and this is Ewan Gallagher data from Toronto, when looked at the high versus low tidal volume, and it's quite interesting because that will depend on the elastance of the patient. If the patient has got very low elastance, so i.e. very high compliance, then it doesn't really matter whether the high or the low tidal volume is used, because the driving pressure is very low, the lung volume is preserved, and this is what happens early in COVID-19, particularly in the first wave. Next, please, and next again, please. Whereas in patients who've got a very small lung gas volume, then the driving pressure increases almost exponentially with the increase in tidal volume, and that's when we need to pay a lot of attention to ensure minimization of driving pressure. So I assume what I'm trying to say is pay attention to the driving pressure more so than the absolute number of tidal volume. Next, please. And this is something that I'm going to touch upon in the next talk, in the next session. So for sake of time, I'm going to be very brief to say that sometimes when we need to choose between increasing the respiratory rate, so that allows us to decrease the tidal volume, or whether we can be more generous with tidal volume and decrease the respiratory rate. And I will go through this slide a little bit more in detail in the next session. So if you can go next, please, Maria, that would be great. And so this is my summary slide. So when we think about the changing phenotypes that we've seen yesterday, we can think about the way we would optimize mechanical ventilation depending on the timing and the phenotype, which also depends from the time from symptoms to intubation and hospitalization. So at the beginning, patients will have low edema, will have almost normal lung volumes, and therefore we can use more liberal tidal volume based on the driving pressure, and the level of PEEP required, and John will tell us about this in a second, is very low because the amount of recruitable lung is small. So here we need to be careful about perfusion defects. So we think about vasodilation and shunt fraction. We think about immunothrombosis, as we've seen yesterday, and VQ dysregulation. But as the time goes on, the lung volumes can become smaller and smaller. Initially because of edema, and so that's a recruitable condition where higher PEEP might be beneficial. And obviously later on, as the edema resolves, but there is more organizing pneumonia or lung fibrosis, then the tidal volume needs to be dropped. But at later stages, the recruitability goes down, so the level of PEEP must be dropped again. So we think about prone positioning all the way through from awake proning the very late, and we pay a lot of attention around the perfusion, so pulmonary vasodilators if required, and think about immunothrombosis. And that's my last slide, and I would like to thank you for your attention. And I think these are just some idea general. And Abby, I think you're next with high flow. Thank you for your attention.
Thanks, Luigi. Morning, everyone. So I'm going to keep it very brief. I think Umar has already touched upon a lot of things in terms of comparisons around high flow nasal cannula use and non-invasive ventilation, which kind of touches upon the limited data that we have to really kind of hang our hat on this modality. I think it's a really good tool for us in our armamentarium, but we need to be very mindful of what we don't know as we move forward with things. Next slide. So I think certain things that we've known about even before the COVID pandemic started was that patients tend to tolerate high flow nasal cannulas better than other non-invasive modalities. There's no flow limitation, and usually the nasal cannula is well fitted enough where like patients who are going to do well tolerate this decently appropriately. Now, most of this data is indirect, and kind of Umar already touched on a lot of those things in terms of how it's comparisons that usually are looked at indirectly. And acute hypoxemic respiratory failure per se has very limited like randomized control trials that show that it potentially is something that is beneficial than usual non-invasive ventilation. Now, one thing that I really want to focus on is that most of these trials, when they look at response rates, they look at response rates in a very limited time period, and then usually it's within the first 2 to 6 hours that you will really define how a patient is responsive or not. And any overall long-term outcomes need to be looked at with some degree of scrutiny, because those are not really the primary endpoints for a lot of these studies. Next slide. I think even before COVID came about, like ROC score was something that was being looked at, and Luigi mentioned about that already. Essentially, it is really like how the oxygenation for these patients is changing in terms of their FiO2 requirements and their respiratory rate in terms of how distressed they are, and gives us a pretty good idea about whether someone is responding or not responding to this high flow oxygen support. But again, like I said, I think like the key thing here is the endpoints for most of these studies were in hours, and then this is something that is not being seen in clinical medicine. We see this a lot, especially for patients being transferred, where these patients are being left on high flow systems for days, and decisions are not being made because of data that's perhaps not translatable for longer periods of time. In the context of cutoff scores, there's a number of studies that have looked at different cutoff points as being predictors for mechanical ventilation or for better outcomes. I think it's easy for us to remember, like if it's higher, the higher it is, the better off you are. If it's dropping, like you're not going to be doing very well. But again, I don't know if there's a magic number that we should really hang our hat on. It really should be a subjective assessment that is looked at again and again. I think the bigger question for us to remember is that, especially looking at the early data, the rates of failure were very high when you look at the longer, like people who were exposed to this for longer times. So anywhere between 20 to 80% of these patients did fail and required higher support because of not responding to high flow systems. Next slide. This is the key question. I've already mentioned that duration of high flow systems is something that we really don't know. If you look at the existing data right now, the average use for high flow systems is between 3 to 6 days. But what is the right time to really trigger therapy to be advanced is not something that has really been looked at. Based on limited data, what we know is that patients who are coming in with severe hypoxemia, PF ratios of less than 200, patients who are not responding in terms of their work of breathing are always going to be high risk for failure, and then we need to be more watchful for them. The other big thing is that patients who do fail, like you usually have your answer pretty early on, and utilization of this modality in a longer period of time perhaps does not make sense, because you should have your answers pretty early on. Next slide. I've modified this table that was developed by Amy Adaway and Umar Hatipoglu from our group here. But I think the only big point that I really want to focus on here is that when you look at the studies that have looked at the use of high flow nasal cannula in COVID, the studies were mostly very small. Then triggers that were used for its use were completely variable. And then the way the outcomes were looked at perhaps is the bigger factor, because we, like most of these studies, looked at either the need for mechanical ventilation or looked at outcomes, which I don't think any of them were really designed to really answer. And I think we have to be very mindful of how we utilize this data. Next slide, please. So I think as we think about high flow systems, I think there's a lot of unanswered questions that we need to be considering. I think it's a really useful modality early on. We need to make sure that we assess these patients very closely when we put them on. But I think there's a few things that we really need to think about. Like, how does high flow nasal cannula really fit in the ARDS COVID paradigm when we make it a prolonged duration of exposure to our patients? Because we are hearing this a lot out here, that the patient's been on high flow for 2 weeks and now they've failed. And somehow it feels that people think that the progression of disease was not happening when they were on high flow. And I think that's one of the big questions that really needs to be put out there. What is the optimal duration of high flow nasal cannulas? Is it really hours, a day, 2 days? Is it longer? I think that's an unanswered question, and we need to be mindful of that. How do we define failure? Because I think it is really important for us to have that common language so that like these variability in practices don't exist. And I think the last question really is that what is the impact of work of breathing and patient effort on injury to these lungs when they're on high flow systems? Because we talk about PEEP-DILI in the context of everything else, but no one's really talked about, like, if someone's really got a high work of breathing, are they still injuring their lungs significantly when they're on these systems? And I don't think like we have answers for that. So I'll stop here. I think this is, like I said, this is a useful modality. It's a modality to be used, but I think there is many unanswered questions that we need to think about in terms of safety for our patients. Thank you.
Abhi, that was fantastic summary and very, very good points. That I hope there is time for discussion, but I think, John, is over to you now because you've got a very, very difficult topic, but I'm sure you will deal with that really, really well, which is positive end expiratory pressure in COVID-19. Thank you, John.
Thank you all. Yes, I'll move straight on to the next slide if that's possible. My name is John Aaron, and I work at St. George's. And there are a number of principles which I'd like to reiterate my colleagues have addressed. The question around whether COVID-19 ARDS can be considered the atypical subgroup. And I think, because if we can, as you say, that it is not an atypical subgroup, then actually we have 20 years worth of evidence and experience on how to manage ARDS. But I think the key thing is that's been discussed is that it's not one condition. It changes over time and individuals, and we got to work out where an individual patient is on their journey. Hypoxia and compliance aren't linearly related, and therefore if you're looking for reversal of hypoxia as a marker of improved compliance and recruitment, that could be misleading. And it changes throughout the disease process, and therefore so do PEEP requirements. It is also a disease of the pulmonary circulation, this vasocentric model which other authors have described. And actually PEEP can worsen some of the negative effects on pulmonary vascular resistance in the right ventricle. And in particular, it is a long game. Once a patient is ventilated, it's not a quick turnaround. It's not a weaning surgical patient. Be prepared for them to be intubated for weeks. And therefore, you've got to assess them daily to look for changes, but kind of rapid swings in approach their ventilation shouldn't be undertaken lightly, and definitely not weaning at night. I think a lot of harm can come from that. Next slide, please. And this is just to demonstrate how this, the treatment for these 3 or 2 images can't be the same, and this is of course the same patient. So as they present day 3, it's not the same ventilator management or PEEP settings as day 15. Next slide, please. And there's actually a balance to be had between the heart and the lungs, and I think it's important when choosing the right PEEP that you consider both. We set PEEP with a very lung-centric view, but we've got to check for tolerance when it comes to the heart. And next slide, please. In most cases, a happy lungs equals happy heart, and actually recruiting collapsed alveoli or edematous alveoli reduces pulmonary vascular resistance, reduces right ventricular afterload, and therefore the right ventricle functions without having to have an increase in right ventricular filling pressure. That, of course, causes venous congestion and multi-organ dysfunction, of which we're trying to all prevent. And of course, RV dysfunction is an independent risk factor for mortality in ITU. So some PEEP is obviously good because as you recruit alveoli that have collapsed, you actually reduce RV afterload and improve RV function. But it's a bell-shaped curve, and you've got to have an idea in your head what a happy lung and an unhappy lung looks like, and at the same time a happy heart and an unhappy heart, in particular the right ventricle. Next slide, please. Let's focus on the lungs. And we have now 20+ years of work trying to work out what clinical endpoints are best to identify ideal or optimum PEEP. And these are some of them, and it's really beyond the scope of this talk to talk about them all. So I'm going to say overall, I think as a general comment, that one, in isolation, all of these are relatively useless, and you've got to use a lot of them together in conjunction with what's at the bedside to make a best judgment call. But we'll talk about what evidence there is out there, and maybe specifically for COVID. Next slide, please. So the question is, next slide, please. Thank you very much. The question is whether our existing knowledge base and evidence base is actually useful and directly copy and paste applicable to managing COVID-19 ARDS. And there's been some work in this and some discussion in literature about it. And colleagues such as Luigi and Gattinoni have discussed the different phenotypes. And Camillo's done their analysis and have identified that overall, when matching COVID patients with non-COVID ARDS patients, there does appear to be a difference. When you match them for compliance, they appear to be more hypoxic, and when you match them in terms of their PF ratio, they tend to be more compliant. And they have concluded that this means that there is another mechanism for their hypoxia. And of course, this is where the vasocentric immune-generated thrombi affecting the microcirculation, the pulmonary circulation has come into it, and clearly there's something in that. However, it is a small population size, and other authors have pointed out that ARDS in itself is a highly heterogeneous group of people, and of course, microthrombi in the pulmonary circulation is a feature of traditional, if you want to use that word, ARDS itself. So clearly, and just to go back to this data set, is that their compliance on their group of patients was extremely high, over 50, and other studies with larger numbers have identified COVID-19 patients with a large variation of compliance, but some very low, such as 20, and some in the region of 40. So their cohort seems to be a very compliant subset of COVID-19 ARDS, which again adds weight to the argument that it is a very diverse condition that probably changes from early to late as the patient progresses along their own pathway. Next slide, please. So let's go back to some of the well-known trials, and the ARC trial is very well known to us all, and they've obviously concluded pretty accepted data that high PEEP and a titrated PEEP, which resulted in a higher PEEP and lung recruitment strategy in non-COVID ARDS, increased mortality, increased the incidence of barotrauma, reduced ventilator-free days, and was overall in an unfiltered group a relatively dangerous thing to do. They've obviously done a subgroup analysis, which we'll talk about specifically. Next slide, please. And this meta-analysis done by Ball has obviously said, has also said that overall, if you consider an unselected patient cohort with ARDS, that the use of higher PEEP and or recruitment maneuvers does not result in a mortality reduction. So I think that strategy for ARDS is it has to be thought about carefully. Now, clearly, again, there is a cohort of patients that may benefit, but in an unselected group, on a population basis, it doesn't. So if we go to the next slide, please. So the question is, if we, and this is obviously barotrauma, a nice picture of a patient we looked after who has developed barotrauma, a complication of very high PEEP. Next slide, please. So the question becomes, if we accept that an unselected cohort of patients, recruitment maneuvers and a high-ish PEEP, which is perhaps chosen on the basis of the patient's compliance, is not the best thing, how do we, but there is a cohort that may benefit from this strategy, how do we correctly identify that cohort? And many clinicians listening, including myself, would use compliance, would use PF ratio, would use ventilator efficiency, and other bedside markers, and also look at the imaging and lung ultrasound at the bedside to help try and identify the best approach. Now, this is all well and good, but unfortunately, in various kind of small cohorts of studies looking specifically at COVID-19, and this particular group have matched COVID patients with non-COVID patients and looked at kind of ventilator and patient mechanics at the bedside. You can see that on the whole, they're matched. So for most things on a population level, then there is very little difference in terms of ventilator efficiency or compliance or driving pressure that identifies COVID from non-COVID. The big difference is, next slide please, is the response to the PF ratio in terms of PEEP. And I'm sure most clinicians who've looked after COVID patients will recognize that as soon as PEEP is applied to these patients, when they fail their NIV and they go onto the ventilator, they're suddenly gone from 80 or 90% oxygen down to 40 or 50 in a very rapid sense. And this is borne out in this data set as well, where the PF ratio has gone up irrespective of the compliance. So the compliance improvement does not identify an improvement in PF ratio, but the PF ratio improves more so than the matched ARDS cohort from before, and that implies a different mechanism. Next slide, please. And again, please. And again, so there are ways to try and identify a cohort of patients who would therefore benefit from recruitment maneuvers or a personalized PEEP strategy. And just before COVID came out, a group of authors has suggested the high-low strategy, where you compare the compliance at high PEEP versus low PEEP. And using this, they've identified that a portion of patients are highly recruitable and a proportion of patients are not highly recruitable. And this does not use PF ratio to guide this judgment. It's using the compliance of a recruited lung versus a non-recruited lung. And obviously, if there's no difference, then there is no point applying high PEEP to that lung. You risk the overdistension and barotrauma. Next slide, please. So overall, once you've identified that the patient may need a certain level of PEEP, you've got to then assess whether the patient is tolerant of that PEEP. So that becomes the important question. So if we settle on a set of PEEP that seems to be beneficial for the patient, and the patient is deemed recruitable, does the patient actually respond to that in terms of safety? Does the pulmonary circulation, is that safe for the pulmonary circulation and for the heart as well? Next slide, please. And again. And of course, the ART trial had something to say about this as well. So they demonstrated an increase in mortality using this strategy of personalized PEEP and recruitment maneuvers in a cohort of patients who are cardiovascularly unstable with pneumonia and on vasopressors. And you could argue that COVID-19 fits that description accurately, although of course more evidence is needed, that all of these patients are on vasopressors as soon as they're intubated. So they are, by some definitions, cardiovascular unstable, and therefore recruitment maneuvers and higher PEEP strategy would be thought to potentially increase their mortality if used indiscriminately. Next slide, please. And again, please. And this is some echoes of the right ventricle in particular in different patients with COVID-19. You can see how, without looking, you wouldn't be able to necessarily see the differences in these hearts. And of course, the last of the three is with PE negative, a huge right ventricle, and this patient is going to be an enormous venous congestion, enormous risk of dying. Next slide, please. And this is a single patient who was put on APRV overnight, who developed anuric renal failure and a high lactate, and over the course of 3 hours was transitioned off APRV to a lower PEEP strategy. Actually, their PF ratio improved, the vasoactive substance requirement reduced, and they started peeing and the lactate cleared again. So overall, you can induce harm with high PEEP strategies. Next slide, please. So a proposed algorithm, and this is very much for discussion if we have time, is that there's got to be two thoughts to this process. What's good for the lungs, what's good for the heart, and hopefully you find the strategy that's good for both. And you need to gather information on how this patient would respond to different maneuvers. And this would include imaging and also compliance assessment at the bedside. And then if the patient is early disease compliant, then using a lower PEEP strategy, aiming for normal carbia and reducing hypoxia, may be beneficial. As they get less compliant and become edematous, then you may need a higher PEEP. And once you settle on a higher PEEP strategy, always check the right ventricle to make sure they're tolerant of that, because if not, you've got to think about alternative strategies. I'm sorry for rushing through it. There's a lot to go through, but I look forward to our discussion based on this. I think I have a final slide. I apologize. Next. So some take-home messages, if that's okay. It's a heterogeneous disease where ARDS is in itself a heterogeneous disease, but COVID-19 goes through its own journey, and it's highly variable depending on when the patient presents and what that patient is like. Understanding that allows you to look for evidence to see where they lie on that journey. It's important to understand that the vascular centric view is important in early COVID. It probably becomes less important later on, but in early COVID, your PF ratio improves, which is independent from recruiting alveoli. And that's so you could therefore, with high PEEP strategies, cause barotrauma and damage to the lungs if you don't appreciate that. Gather as much information as possible and make a judgment, and understand that it's not going to stay like that over the course of the patient's stay. You've got to continue to assess and continue to adapt over time. Thank you very much.
Fantastic, John. Thank you so much for really pointing out very clearly in your talk how PEEP or oxygenation is not just about gas volume, but the relationship between gas volume and hemodynamics, or ventilation perfusion inequalities. So I think Eduardo's got a very, very important question. I don't know, Eduardo, whether you would like to just share it with us all, and then we can try very briefly to answer, because obviously time is we need to move to the session. So one question, but very important one.
Thank you all for a really exciting presentation. John, the question, and actually it also touches on you, Luigi, is we know that the phenotypes change through time, and that it's not the same day 1, day 2, day 3. So you touched a little bit on this, but what are the markers that you follow that change to change the strategy? And is there one that you follow that is stronger than the other to decide what to do?
John, do you want to go first? Or?
Yes, I can. So I think it's very difficult. There's some operational aspects to this, which I think are important, whereas ventilator changes should be consultant-led, daytime, hours, as a kind of starting principle, because what we found was that the changes were done at night without proper understanding of what happened. So one of the first institutional things we did was make it very clear that unless there's an emergency, these assessments should happen on a consultant ward round during the day, and any changes would therefore have daylight hours to assess effect. But overall, I think it's clear. I don't think PF ratio is the be all and end all, but I think compliance will change on a given setting if everything else stays the same. Tidal volumes go down and the patient starts de-recruiting, at which point we did serial monitoring, lung ultrasound and cardiac ultrasound, and you can watch the right ventricle kind of dilate over the course of a few days. The TRV max, which is a surrogate marker for pulmonary systolic arterial pressure, goes up, and the lung ultrasound will demonstrate increasing basal consolidation atelectatic changes. A CT scan will therefore identify the development of more focal disease, which would then imply the need for potential assessments now at this stage of how recruitable a patient is in terms of alveolar lung volume. And if they would benefit from recruitment maneuver, at that point you can then go on to an incremental decremental PEEP trial to identify the optimum PEEP. At which point, once you've settled on it, it's important to re-echo them to make sure their RV strain hasn't got worse with that strategy.
Thank you, John. Umar, do you have any things to share what you do on a regular, day to day to adapt the PEEP to the changing mechanics of the patient?
Yeah, so that's a good question and a holy grail, isn't it? We've been working at this problem for a long time. I'm reminded of the study by Chumello, who looked at driving pressure, the PEEP titration with our ARDS net, esophageal pressure measurement, and found that really they did not matter. They were not different by much, but probably the ARDS net protocol worked the best among the three in terms of its correlation with recruitability as determined by CT scan. So I go with that. We actually place patients on PEEP FiO2 tables. In the beginning, what we do is determine recruitability. And as you know, that's very controversial. Some of us do the RI ratio, so recruitment inflation ratio. Some of us are going to look at recruited volume, if they have access to it, to Hamilton ventilators through the recruitability during PV curve measurement. And we don't have Hamiltons yet at the main campus. We're getting them next year. So RI ratio is probably the way to go in the beginning. So once we determine the patient is recruitable, then we might choose the high PEEP FiO2 table, and there is actually some opinion difference in our group in that some of our folks will just go to the high PEEP table, and some will start with the lower, decide on recruitability. But day to day, I think we really have operationalized this, and we look at the PEEP FiO2 ARDS net, probably high more than low in terms of selection.
It's very pragmatic. Thank you. Abby, very quickly, any sort of final pearls of wisdom, so then we can, and I just one idea is how many people use dead space and capnography to ensure that we're not over distending.
Yeah, so we do use dead space and capnography in selected patients. Again, like John was saying, it's something that just requires a lot of thought process, standing in front of that patient room and then just going over. So basically, what we've realized is every day you have to come in and really look at all the sum total of information that you have and start looking at things. And I agree, we've done a lot of bedside echoes on these patients on an ongoing basis. And many times you find things where you will change your management based on that. But again, just keeping in mind of following your driving pressures on a daily basis, and then really looking at if you're not having a good answer to escalate things, is that perhaps the right thing for us to do.
Fantastic. Well, I'd like to thank you all for this fantastic and very informative session. And I'd like to move on to Eduardo Mireles and Simon Finney, that are the chairs for the next session. So over to you, Ed and Simon.
Thank you very much, Luigi. And we're very excited to chair this session on mechanical ventilation in COVID. And we're going to touch on three topics that are really intense for us. We're going to talk about optimizing invasive mechanical ventilation, prone positioning in COVID-19, and tracheostomy. And to do this, we have a wonderful panel with our three colleagues in London, our two directors of the symposium, Luigi Camporota and Georg Auzinger, and Carlos Corredor. And then from this side of the pond, we will have Colin Gillespie, Mohammed Iqbal, and myself talking about this. Simon, please, can you give us some words?
Welcome, and it's an amazing panel. I think as time's pressing, we should probably launch into the session. And I think our first topic is about optimizing mechanical ventilation, which is some of a lifetime's work. So somehow we'll manage to summarize this within 15 minutes. So over to you first, Eduardo, and you'll be followed up by Luigi afterwards. But we'll try and keep everyone to time. So
absolutely.
Over to you, Eduardo.
So I thought that we needed to talk a little bit about how to operationalize the change in the setting of a pandemic. Luigi, as our expert on physiology, will give a really nice overview of the theories that are coming and new insights that are being generated. But I wanted to talk a little bit about why we need to really focus on how to make it work. So next slide, please. The study LungSafe really is, to me, a in-your-face kind of study of saying, you know, all around the world, 50 countries, 435 hospitals, how do we deal with ARDS? Next, Maria, please. One of the things that just hits you is that only of those caregivers, only 51% recognized mild ARDS and 78% severe ARDS. So even though the definition is super sensitive, we were not using it under these circumstances. And this talks about operations. I don't think that any of the caregivers that were doing this did not know what ARDS was. It's how do you implement and how do you make it work. Next slide. Next, please. Only 65% received tidal volumes less than 8 mLs per kilo. And we can argue about if we should be using delta P or anything else, but this was, at the time of this study, the basic way that we should be the key factors of lung protection. And in only 40% of those, P-plat was measured. Actually, next, please. The graph that they show, in which in the x-axis you have the tidal volume, and on the Y, the plateau pressure. Next, please. You can see that only 66% were what we call safe ventilation, which would be standard of care at the time of this study. Next slide, next, please. Of those, there were some that had actually high plateau pressure, and we could argue that some patients, the contribution of the chest wall is higher, but they were staying within the low tidal volume, and you say, okay, that's fair, we can take that. Next, please. But the rest, next, the next of them had higher tidal volumes and higher plateaus. Those would be outside of the standard of care. So that means that in general, we cannot recognize in practice a large amount of patients with ARDS, and we cannot implement the standard of care for them. Next, please, Maria. So how to make it happen also when it's not a static condition? And I borrowed this from you, Luigi. I like this slide, because it talks about what you will present later about different strategies to ventilate according to where the physiology of the patient is. The compliance changes through time, all the way to having irreversible lung fibrosis. How do you actually ventilate these patients? In a study done by Xiaofeng Wang, who is one of our statisticians here, and we collaborated with him from the Wuhan series, they did a lot of CAT scans. And what you can see here is through time in the x-axis, and on the y-axis, a score that they use to score the intensity of disease. And you can see how it changes. I mean, it's not the same disease on day one. It goes through the amount of parenchymal involvement, it increases, and then it goes down for survivors. And for people that did not survive, you can see how it behaved. So it's not a static condition, and we need to adjust to how the patient is moving through time. Next. So in general, what we have now is too many pathways. I mean, a patient has COVID, and he can go through the asymptomatic line in which he goes home and infects others, or he's symptomatic and he goes to the hospital. And depending on where you are in the globe, or actually within the same city, you have different ways of where you're going to be treated. You will be treated with low flow oxygen or high flow oxygen. You may be in the ICU or other environment when you're receiving higher levels of care. You may be prone actually outside the ICU or a monitor environment. And then you're exposed to a series of pathways with steroids, remdesivir. I mean, you choose. And then obviously you have what I call Twitter treatments, which is whatever came out on the latest social media that you got pressure to deliver. So too many pathways to operationalize. Next, please. So what I would say here at Cleveland Clinic, what we started in a pandemic, we decided that there has to be a strong standard of care. You have to decide for your institution what are going to be the pathways and where are you going to treat these patients. And you can see that we essentially took out any of the gray areas, and we said if you're going to go in high flow nasal cannula, you are going to be on an intensive care environment. If you're going to be prone, you need to be on an intensive care environment. If you're going to be on non-invasive, you need to be an intensive care environment. And we put very clear, specific criteria for what we were going to give for these patients. And now we may disagree on what we are applying, on how it's being applied, but at least you know what you're applying and you can see how the outcomes of these patients are coming. I will highlight that actually, and I presume this is an experience of all of us, that many of these patients actually are having many issues because of the sedation that we're giving to them, of all the other things that are happening. It's not just the mechanical ventilation. And as we learned yesterday with Abby and Luigi talking about factors that affect mortality, it's not just how you set the ventilator that day. It has to do with performing a spontaneous awakening trial every day and letting them breathe on their own. Ensuring that they are negative fluid balance, because they gain a lot of fluid while they are with us. And I will say finally that when we are doing, and John, you mentioned on this, the challenge of going to the night and the night doesn't know what to do, and they change everything that you did during the day. And that's why, at least during a pandemic and during our practice here in our ICU, we decided to go with a standard table, with an ARDS table, so that the team at night knew where we were going, so we could move through time. Now, there's 20% of the patients that you cannot manage with that, and then you have to do more specific things. But in general, for the majority, that's how we behaved. Next, please. So again, all the resources that we have created are here available. They're for free for any of the attendees that want to register. They actually also give CMEs, so if you want to go there. Next slide, please. And so with that, I finish, and I pass on the baton to Luigi. Really interested in hearing you. Thank you.
Thank you very much, Ed. That was fantastic. So I'm just going to follow on some of the concept you already mentioned and maybe expand it from the sort of individualizing perspective. So next, please. So I just want to start with this idea that mechanical ventilation is like baking a cake. We've got different ingredients. We've got the eggs, we've got the flour, we've got chocolate, and we can get the right ingredients in the wrong proportion and we burn the cake. And that is the problem, because the ingredient that we have with mechanical ventilation are tidal volume, respiratory rate, PEEP, delta pressure, and the right proportion is what we can call is the energy that is delivered to the lung, which is the mechanical power. Next, please. Now, without being too scared about formula, this is the simplest formula that we can apply. And you can see it's very easy. We normally apply very quickly. Our nurses do it at the bedside. You just need a respiratory rate readily available on the ventilator, the tidal volume, you know the driving pressure, you know the PEEP, and you can add that, and that's the mechanical power during pressure controlled ventilation. Now, there are some other formula if you use volume controlled ventilation with square flow, with decremental flow, but we'll not go that into detail. But just to say, the one way of considering the entire energy of the mechanical ventilation that we give is to think now in terms of mechanical power. Next, please. And why do we want to do that? Because now, when we think about tidal volumes, we've said earlier on, you know, you can see this is a study that Pierpaolo Terragni did in 2007, so a long time ago. And you can see even when you're really, really strict in terms of tidal volume, you're really, really strict in terms of plateau pressure, the patients who have a very large lung, you can see that in blue, they are always going to be more protected compared to the more severe patients who have a less sort of large lung volume, you can see at the bottom. And what you can see also, the one in purple, indicates that because we're using a high amount of PEEP and tidal volume, then there is overdistension, and that over time can cause problems in terms of structural problem in gas exchange. Next, please. So we've been through this concept that now this was last month, Costa et al. They just reviewed a lot of trials, and they did some interesting sort of mediation analysis where you can see two things. One, when you look at standardized mortality ratio, which is on the y-axis, and you think of quintiles of driving pressure or respiratory rate or tidal volume, so the two factors, the two ingredients, let's call them, that are associated with mortality are the driving pressure and the respiratory rate. The tidal volume is not, and we've heard, and we know why, because it's related to the starting lung volume. If the lung volume is very high, you can achieve a large tidal volume with a low driving pressure, and vice versa. So next, please. And we've showed this slide before, so I'm not going to dwell on it, and we go next, please, and next again. Okay, this is the one I said earlier on I was going to spend a few seconds, because the problem is, obviously, if we need to drop the driving pressure, unless we tolerate high level of hypercapnia, we need to adapt the mean of ventilation through respiratory rate. Now, the problem we have is, what is the best ingredient? Do we increase the driving pressure and therefore the tidal volume, or we maintain a low driving pressure and tidal volume and increase the respiratory rate? And obviously, we can do that using the mechanical power equation, which obviously is a bit more time consuming, but also we can use this very simplified formula, which is you multiply 4 times the driving pressure and you add the respiratory rate. And this is quite interesting, because if you follow the two curves, one indicates a patient with very low compliance. You can see 14 milliliters per centimeter of water. Now, what happens? Let's say we try and increase the driving pressure from 21 to 27. Okay, and as a consequence of that, we decrease the respiratory rate. Now, you can see is that number, which I've just calculated for you there, actually increases from 129 to 138. And an increase in that particular number, it means increase in the odds ratio of death. So when a patient has got very stiff lung, or very small lungs to be more precise, with low compliance, actually the best strategy is to increase the respiratory rate. However, when the compliance is more preserved, you can see the one at the bottom is 35, actually increasing the driving pressure a little bit, and therefore the tidal volume, and reduce the respiratory rate, will give us a better, lower number, and therefore a reduced odds ratio of death. Now, this is certainly not the definitive solution, but it's a very easy formula to remember and apply at the bedside, just for a quick, rule of thumb measure of what to do when you want to optimize the two parameters. But also, I would encourage you to use a little bit more the mechanical power, because sometimes what you get is incredibly counterintuitive and is very, very helpful. Next, please. And this is what John has described earlier on. So the use of important use of recruitability indices, so that you can do that as a single breath. You don't have to go through the entire PEEP trial, because once we've done the entire PEEP trial, that's too late. The damage is done. And as John has clearly demonstrated with the ART trial, that increases the risk of death. If you go next, please. And this is a summary slide. You've seen that before, and I'll leave it there just as a reminder, a placeholder, or sort of a reminder that things change over time, and we need to adapt everything, all the elements and the proportion of this recipe based on the patient characteristics. So thank you so much for your attention.
Thank you very much, Brian. That takes us up to about the 15 minutes, but I think that was a very nice presentation about getting the basics right, which is what I seem to spend most of my life doing during the previous waves, and then how to finesse it thereafter. I think in the interest of time, we'll keep on progressing. So I'd like to introduce Carlos and Mohammed, who are going to talk a little bit about prone positioning in COVID-19 and whether it's different to normal ARDS, whatever normal ARDS being a heterogeneous condition itself. So I think is it Carlos going first?
It'll be me actually starting first, and Carlos will take over from me. Good morning, everyone, and good afternoon, everybody in London. Next slide. So prone position has been well recognized in patients with intubation and mechanical ventilation, but there's more and more interest in awake proning in COVID-19 patients. And In this slide, you can see on the left-hand side the picture that represents the changes that occur as a consequence of prone positioning compared with supine position. And as we know that the distending pressure of the lung is determined by the transpulmonary pressure. When the patient is supine, the ventral transpulmonary pressure is significantly higher than the dorsal pressures, resulting in greater expansion of the ventral alveoli than the dorsal alveoli. And this effect is exaggerated in ARDS patients. And prone positioning reduces the difference between the dorsal and the ventral transpulmonary pressures, making the ventilation more homogeneous, leading to a decrease in ventral alveolar overinflation, and dorsal alveolar collapse is reduced as well. And then it recruits the alveoli that had collapsed during the supine ventilation. Also in ARDS, there's substantial VQ mismatch because of lack of because the alveolar collapse in the dorsal parts of the lungs. And when we prone these patients, we see that the ventilation perfusion matching improves since the previously dependent lung continues to receive the majority of the blood flow as the alveoli reopen. So this is the physiology that we need to remember. Next slide, please. There's more interest in awake proning. It has been used previously in ICUs, but with the surge of COVID patients and the pandemic, there's limitation of resources. So we have recognized the importance of awake proning in these patients more and more. We also need to remember that we have to do it safely. So these patients should be prepared and explain the procedure. They need to recognize that they are going to be participating in this procedure, and they need to understand the procedure and the complications that can potentially happen with this. So we position the patient in prone position with the pillow underneath the chest or the abdomen and one pillow under the forehead, leaving enough space between the two pillows for the oxygen supplies, for the mask and high flow and so forth. And once we prone these patients, we continue to monitor them for improvement in saturations or worsening or hemodynamic compromise and so forth. So anybody who can follow the instructions and is on supplemental oxygen can be a candidate for awake proning. And the contraindications, the major contraindications would be a patient with morbid obesity and difficult airway, where you are worried about if you prone this patient and you lose the airway and the patient desaturates, it can be a disaster. Patients with accessory muscle use, anatomic concerns, injuries, spinal instability, any patient with cardiogenic edema and pulmonary edema from the heart failure, arrhythmias, hemodynamic instability, and once you prone these patients, and if you see signs of desaturation or hemodynamic compromise, that would be a contraindication, and supinate this patient immediately. Next slide, please. So the data is limited, and some of these slides, some of these studies have been shared. I think Dr. Dougal mentioned a chart which had quite a few of these studies. There was a multi-center prospective cohort study by Ferrando, a total 199 patients, compared high flow versus high flow and prone positioning. And the primary outcome was essentially looking at the PF ratio and intubation risk. We saw that PF ratio was improved significantly, and there was a trend towards delay in intubation, but eventually there was no difference in intubation rates between the two groups. The next two studies were essentially, single center prospective cohorts. They compared and looked at the difference in saturations and PF ratio pre and post, and there was an improvement in saturations and the PF ratio as well. And the last one at the bottom is by Al-Harar. It's a prospective before and after study, single center, a small number of patients, and they looked at the partial pressure of oxygen improvement. And 25% of the patients had more than 20% of improvement in partial pressure of oxygen, but the response was not persistent once these patients were supinated. So the data is limited, and of course more studies are needed to look at this in more detail. Next slide, please. So it's too early to say what effects of awake proning do we really have on prognosis of these patients, but I think Carlos has more slides on this. But there were a couple of early studies from last year, one in New York and one from Oxford Respiratory Group. And the one from New York was only 50 patients that looked at a proning and significant increase in saturations on proning. But if these patients did not respond with improvement in saturations initially on proning, there was a high risk of intubation. And the group from Oxford Respiratory Group, they looked at 48 patients. 11 patients tolerated proning for more than 2 hours for 2 consecutive days. And achievement of full proning was indicative of reduced mortality. So these are early trials, early data, and we definitely need to have more data on this. But it's important to remember that awake proning is a modality that can be used ideally in ICU, but on step-down units where you have at least some monitoring of these patients, that this can be implemented. We actually tried to do this study at one of our regional hospitals. The limitations are always the manpower and also monitoring of these patients and the comfort not only for the patient but also the staff that need to be comfortable doing this awake proning of these patients. So with this, I'll stop here and I'll pass it on to Carlos to explain the rest of the slides.
Thank you very much, and hello everyone. So the question is COVID very different effect on COVID. That's one of the questions, and the study on the left is a very interesting study that looks at respiratory parameters, compliance, system compliance, and FiO2 ratios, comparing them in COVID and non-COVID patients. Interestingly, at first glance, the COVID patients have a better response in terms of oxygenation as when compared to non-COVID ARDS patients. But actually,
Carlos, sorry to interrupt. There's a lot of echo. I think it's coming from Nick's microphone, Nick Fletcher. If you can mute that so that Carlos can present. Thank you.
Do you want to sit and rest?
There's your microphone.
There you go. Thank you.
I think we've sorted it out.
There, excellent. Thank you. So go ahead, Carlos.
The echo gone?
Yes.
Yeah, okay. Yeah, sorry. Yes, so the question was the effect of proning and compare when you compare COVID and non-COVID patients. And I was referring to the study on the left of this slide where they compare a cohort of patients compared the static respiratory system compliance and oxygenation with FiO2 ratios. And at first glance, it seemed that the COVID patients were responding better in terms of their oxygenation as compared to non-COVID patients. But then when they matched the baseline characteristics, actually there was not much difference, and the response, the positive response in terms of oxygenation seemed very similar between the two cohorts of patients. And what is the effect in terms of outcomes comparing COVID and non-COVID patients, the mortality, for instance? So pre-COVID, probably one of the sort of more important papers that kind of set the theme or the scene in the proning was the PROSEVA trial that showed a significant benefit of immortality. And on the right, we have this meta-analysis looking at lots of COVID quasi-experimental and observational studies. And yeah, there's actually a clear signal that proning it has a positive effect in mortality in COVID patients, and also awake proning seems to have a positive effect in terms of intubation rates. Next. Yeah, so pre-COVID again, probably the best data that we have from use of COVID and ARDS patients was from a study called the APRON study done by the European Society of Intensive Care Medicine, that they look at a snapshot of COVID proning usage in European ICUs, and of 743 patients, they showed a prevalence of proning of 32%. Again, proning was seemed to be so consigned to more severe cases and more rescue therapy. And in this slide, we have some studies from different cohorts. So on top left, a Spanish cohort looking at 742 ARDS patients with COVID. There was a high kind of prevalence of proning. 76 of these patients were prone, and again they looked at oxygenation, compliance characteristics, and compared them with a non-COVID cohort, and they were very similar. Basically, the proning conferred benefit in terms of oxygenation in a very similar way to non-COVID ARDS. The Italians, so the prona COVID group, they looked at 1,000 patients, more than 1,000 patients with COVID ARDS, mortality of about 41% on this cohort, and again, much higher than pre-COVID prevalence of proning, with 61% of the patients being prone. And they also interestingly showed that proning seemed to benefit more oxygenation, the PaO to FiO2 ratio, rather than compliance of the respiratory system. And some data from the UK on the right. So this is from mostly a first wave. About 600 patients that were prone in UK ICUs, 633 ARDS patients that were treating in UK ICUs. About 49% of them were prone, with a overall mortality of 43%. But the interesting signal here is that if you are responding to proning, meaning that if you are keeping your PaO to FiO2 ratio at more than 150 millimeters of mercury 7 days after your initial proning episode, you have very significant improvement in your mortality as compared to non-responders. So if you respond to proning early, it seems that your outcome is much better as a COVID patient. Next slide, please. And there are many factors and challenges that influence how prone patients and how well you do with proning. So first, proning alone will then confer you benefit if you don't use other try and test strategies like lung protection. So very old studies with proning, when they were using higher volumes, actually didn't confer any benefit because you probably have to link proning with other strategies as like lung protection. So the level of severity of ARDS pre-COVID, as discussed with this APRON study, seems that we were using more proning as a rescue therapy, and as many things in ICU, when you let the disease process go unchecked and patients go into a very severe state, then it's more difficult to rescue them. So the earlier use of proning, including awake proning, seems to change outcome in COVID patients. The timing again, so early versus late initiations. So if there's also clear signal that if you don't start proning within the first 48 hours of ARDS setting, then your outcome might be different. But there are many challenges with proning in terms of staff familiarity, and we saw that pre-COVID that was one of the main barriers to prone patients. So fear of staff about causing injury by proning, and the lack of familiarity. But with the high numbers of patients that we had in COVID in our group of hospitals ICU during the last peak, we had up to 150 patients, ICU patients in one building, and at the peak, up to 31 patients were being prone in one single day. So with simulation, with proning teams, with collaboration with other medical groups and nursing groups, we were able to deliver a very safe and proning, but nevertheless challenging. And so the duration, how long should you prone? So it seems, again, the early studies that try to prone for the duration of a nursing shift, 6 to 8 hours, didn't seem to have sort of good results in terms of outcomes of mortality and changes in oxygenation. So longer sessions of proning, 16 hours plus, seem to more benefits. So I will now open it to the floor, really. Thank you.
Thank you very much, Carlos. Appreciate yours and Mohammed's input. I think that in the sake of time, we're going to move on and then come back, if we have time at the end, have some questions. Now we move on to the next topic, which is tracheostomy. And it's a pro and con, which I'm very interested in see how is it going to end on this one. So we're going to start with the pro. Yeah, there, George is ready to battle Colin. So Colin, go ahead. Colin is one of our staff physicians, interventional pulmonology here at Cleveland Clinic, and he came to really change our practice in tracheostomy. So we're very grateful. Thank you, Colin. Tell us what's your pro.
All right, fast and furious here. Next slide, please. I think we all believe that there's lots of benefit to tracheostomy, and in classic human nature, when something is perceived to be a benefit, we want more of it faster. And so, lots of extrapolations here from in tracheostomy in the care of our patients, and that this idea that trachea are more comfortable than endotracheal intubation results in less sedation, and less sedation results in less delirium, that we've got an easier wean. And if we're weaning people faster, we have to be decreasing the incidence of pneumonia with shorter length of mechanical ventilation and length of stay, and then throw in the more secure airway and potential impacts on patient mobility. Early trach has to be the right answer. Next slide, please. This is the most recent of many meta-analyses that look at, the heterogeneity of our data to try to tell us what the right answers are. But in this paper, their assessments are that, early trach is associated with lower VAP rates, with shorter durations of mechanical ventilation, and therefore shorter ICU stays. But there was no reduction in all-cause short-term mortality. Meta-analyses are fraught with peril. And so we have to be very careful with how we interpret these things, because looking at the heterogeneity of data doesn't necessarily doesn't mean clinical benefits and results. Next slide, please. When we look at this question of early versus late in the COVID population, this was one of the first papers looking at this, and their goal really was not early versus late, but to see, when COVID first came out, there was this blanket perception that we wanted to protect caregivers and staff from high-risk procedures. And based on the early SARS coronavirus data from earlier in the century, we thought that the infectivity would increase for the first few weeks of their presentation. Whereas as time has gone on with us, with our novel coronavirus 19, we see that the primary peak infectivity is prior to symptom onset and in the early part of their stay. So this, potentially is not necessarily the risk that we all are worried about. When you looked at their population, their definition of early was 10 days or less, and they found that in their population that there was a decreased chance of discontinuing mechanical ventilation in the late trach group. There was a shorter length of stay in the early trach group, and only one single provider who had many other duties was affected by coronavirus personally, with a non-inferior performing trachs early. Looking at a large Italian study, their median time of early trach now approached 2 weeks. So this is a bit of a moving target, but they found that the early trach was was associated with a shorter ICU stay. And in this opinion piece that was published, there really has been no signal identified in transmission risk to provider groups done in a protocolized way. So, I think that, some of the things that drove us to want to delay trach and COVID patients have not borne out, and that we need to keep this in the front of our minds. Next slide, please. I don't know if you can, next slide, Eduardo, or if someone can play this. Does this play? This is just a short video. I'm not sure if it's going to play, but this is a video of someone's airway from a prolonged translaryngeal intubation. And what you can see here while it's playing, there's a pretty tremendous and profound injury here circumferentially to the mucosa. And we, I think, often underappreciate the impact of endotracheal tubes on our patients. And while these are rare, I think we're going to see more and more of them as we have more patients with critical illness and extracorporeal life support required, that this is something we need to think of. Next slide. So, I think that the COVID-19 patients are not exempt from this early versus late conundrum. It's very hard to think that one size and approach is correct for everyone. Making a protocol that we can apply to patients and try to get people the best care for them in as rapid and seamless a way as possible. And that's the end of my discussion.
Thank you, Colin, for your presentation. George, what's your standpoint here?
Well, after prolonged fisticuffs with Colin, I drew the short straw. I had to choose the con argument. Aside from that, I'm always starting with minus minutes for my talks. It's -1. Right, next slide, please. So there you go. No late harm. Next one, please. The rationale, I think, Colin quite nicely outlined, and unfortunately the video didn't play, but it looked horrendous. So clearly we are quite worried about laryngeal injury and dysfunction with prolonged intubation. Early weaning of sedation may be facilitated by tracheostomy and doing it as early as possible. Is that true? Reduced incidence of delirium, and especially in COVID patients? Question mark. Shorter ICU and hospital stay? I'm not so sure. And resource optimization? Well, I think there is a pro and con to that in itself. The next one, please. So look, I mean, this is much less dramatic than what Colin has shown us, but if you just press next, Maria. I'm always puzzled by how early you actually do see injuries of the glottic area. And often it is quite subtle, like these type of kissing ulcers. And often I certainly personally can't see any difference between 1, 2, 3, or 4 weeks sometimes. And as you know, in certain places, culturally, I guess, tracheostomies are performed late. I'd say in France, for example, I think patients usually don't get tracheostomized until they hit a month on the vent with a tube. So does it really make a difference? Next one, Maria. How about weaning of sedation and less delirium? Well, I've made a photo screenshot. I'm not sure how well this displays of a patient who had been on ECMO for 3 weeks. And we thought, well, great, we're gonna tracheostomize him very, very early, wake him up and get him mobilized. So he was in fact tracheostomized on day 3 on ECMO, 5 days after intubation. He was very, very delirious at that stage, 3 weeks later, had a persistently high respiratory drive like so many of our patients, I think, display, and I think that's come across already in previous talks. Desaturated as soon as he was waking up, probably due to increased oxygen consumption as well as an increase in his native cardiac output and therefore shunt, being ECMO dependent. And we went through cycles of resedating and bolus paralyzing the patient, and you can see the doses of sedatives and analgesia which were given at the time. So this is roughly 3 weeks after tracheostomy. And I don't think this is a unique example. We seem to be seeing this quite frequently. Next one, please, Maria. What about the evidence if we press forward 1, 2, 3? So Colin has already shown this most recent meta-analysis, and the last one, please. And I've just outlined here the 3 largest trials. Maria, one forward, please. Which the largest of which is the UK TrackMan trial, actually of 900 patients we took part in as well. And then there is an Italian trial, and I think it was a trial in Spain. As you can see, the odds ratios for decreasing ventilator-associated pneumonia and reduced time on the vent for these larger trials are actually confidence interval wise very wide. And if you look at the forest plot on the right hand side, certainly for the largest trial by a mile, which is the Duncan Young UK trial with 900 patients, we certainly seem to have equipoise. Besides that, one also has to point out that primary and secondary endpoints in all of these trials were different. So for the UK trial, it was mortality, ventilator days, or VAP was actually not included as an outcome parameter, and we actually haven't really got any results thereof. And also for the Italian trial and the Diaz trial, primary as well as secondary outcomes did include VAP and potentially days on the vent, but certainly in one of those not significant. So I would really question the value of these kind of meta-analyses where there's clearly huge heterogeneity of patient populations, numbers, and endpoints which are looked at. Besides that, early tracheostomy doesn't equate to early tracheostomy. In the UK trial, less than 4 days. In the other 2 trials, 7 to 8 days early. And in effect, I think most of you do know, for all of these trials in the late group, 45 to 55% of patients actually got extubated and never got tracheostomized. So that raises then the question also for COVID populations, how many of these patients would we tracheostomize without them actually needing that? And there are obviously also complications associated with the procedure, up to 5 to 10%, or patients would die regardless of being tracheostomized. And especially if we did that early, there is a futility question. Next slide, please. Next one. For me, another very important point is this one here, and this is from colleagues at GSTT, Guy St. Thomas's Hospital. And Maria, if you just press the button, another one, yeah, that's fine. I'm not sure if you can make this out, it's quite small print, but clearly from the bullet points and the various aspects of the table, you can make out that the procedure is actually quite complex, especially in COVID patients. And I would also argue that video laryngoscopy, bronchoscopy, and ultrasound may not be available in many places, and especially under pandemic conditions. So if we really want to do this in the safest possible way, and as per these guidelines, which I think are very good, we also have to keep in mind that this may not apply to all settings worldwide. Next slide, please. Additional concerns, well, clearly patients who undergo prolonged prone positioning, we all know, certainly trickier with the trachea in situ. Risk of bleeding, and we talked a lot about anticoagulation management and VTE and PEs in situ thromboses yesterday, and certainly an increased bleeding risk potentially associated with the procedure. If patients are on ECMO, the question around apnea tolerance, sorry, if they are not on ECMO, because if they're on ECMO, often it's actually quite easy to do. Risk of air embolus if they're on extracorporeal support, which clearly needs to be taken into account, especially if we run the patient's apneic during the procedure. And then the possibility of staff exposure risk. Although I have to admit, from my own experience and experience of many others, I would rate that as being really very low. And this is where I finish. Thank you very much for your attention.
Thank you very much, George. Really appreciate the input. Simon, closing statements for us. You're muted, Simon.
Sorry, schoolboy error again. I think all three groups talks are fantastic. I think we're very lucky to have had those, and particularly I enjoyed about proning, and actually whether the self-proning which we teach people to do on the wards here in the UK actually has a relevance at all, where we do it for such short periods of time. So no, I would just like to thank all 6 panelists very much for their contribution to the session.
Thank you very much, Simon. Thank you all for this exciting presentation. I know we're short on time, so in respect of our next roundtable, we'll move on. Thank you very much.
Thank you. I may introduce the next roundtable discussion, which I'm really looking forward to. It's ECMO and COVID and across the continents. And the panelists are Dr. Krishnan from, I think, Ohio. Correct me if I'm wrong. I do apologize. Simon, you've just met. Luigi, Vivek, who we've had dealings with yesterday, who's dialing in from Abu Dhabi, and Steve Minya, who I think is on the road. So thank you so much for trying to join and give us your impression from what has happened in Florida, I think. Over to the panel.
Well, thank you very much. And we've had a little bit of a discussion about how to run this beforehand. So thank you to all my compatriots who are all renowned authorities on ECMO, particularly in COVID-19. Before we move on to our slides, and we only have 6 slides, I suppose just to put a little bit of a context on it for anybody who's in the audience. I'd just like everybody just to give a 1-2 sentence answer about how much pressure ECMO services were under during the COVID periods, both locally and nationally. So if I just go everybody by turn, if you could just mention what it was like in London, Luigi.
Yes, thank you very much, Simon. Hello, everyone. Absolutely, Simon. Obviously ECMO was a very scarce resource, and if we think about what we were in terms of capacity pre-COVID-19, we had to increase our capacity nationally 5-fold. So I think that put a lot of strain not only in the ECMO centres, but also, as you know, in the UK we are network centres or few centres, but also in the non-ECMO population. So it's a zero-sum game, and obviously ECMO is a very resource intensive, so definitely it's a lot of strain on the resources.
And Vivek, about how much pressure was there in Abu Dhabi?
So I think we were during the pandemic designated as an ECMO facility for the Emirate at least, and our referrals went up many-fold even after discounting for the ones who were never going to be eligible. I think it was still a significant drain. And since our peak followed the one in the Europe, actually we struggled to then suddenly expand our resources, staffing aside. You couldn't suddenly buy more machines or the cannula actually, because we've then found that McKay had set country limits for how many cannulas they will, during the peak of the European pandemic, allow every country to have. So within the different emirates, actually, we were all grappling for the machines and cannulae and other disposables too. And of course, we were, the staffing we had to run course during the pandemic to expand our staffing capacity as well. So needless to say, we actually had a very tough time during the pandemic.
And then moving over to the United States, I suppose, if we start off in Cleveland with Sudhir.
So Simon, the clinic exists as an island unto itself, and our immediate goal was to take care of our enterprise and our community. The cashier circuits that we had was over 22 with investments in another 10. So we knew we could escalate if required to up to about 22 plus another 6 circuits. There are other competing healthcare systems that provide ECMO services here at the Cleveland, in the Cleveland area. At the highest that we had was about 11 patients continuously on circuit because of ECMO COVID-related issues, and another 5 for cardiothoracic from the cardiothoracic program. But our pressures were limited in the initial half of the pandemic solely because the cardiothoracic program, and this is the largest thoracic and cardiothoracic program in the country, took a step back. But towards November, December, as the pandemic was racing through its zenith, we realized we could get into problems with circuits, perfusers, and nurses, and we had to revise our selection criteria based on our operational stage. But at no point did I feel that we were under any amount of pressure, one, because of the nature of the clinic and the main campus and its resources. But going forward, there are talks about a moratorium on the number of circuits that are going to be available as we maintain a robust cardiothoracic program.
Sure. Thank you very much. And Steve down in Florida. I saw his video on a moment ago. But maybe he. We'll come back to Steve later on in the conversation. So, Maria, if we move forward a slide, there's been lots of discussions about this. I think everybody university across the continents have felt a lot of pressure within their services. And this led to PRACA producing this paper in 2020, which is an expert's opinion paper, really, or opinion piece about how we allocate ECMO during COVID-19. I've shaded in pink the slides, the conditions for which respond to cardiac type ECMO, and blue remains the respiratory ECMO. And it's split up according to duration of ECMO and the likelihood of survival. I suppose I put it back to the panelists really about, do they find this type of thing helpful to decide how we allocate ECMO during COVID-19? Any opinions about that? Maybe start off with Sudhir.
Yeah, so Simon, what we did was in the month of January, as we were getting together, we thought it would be prudent to have our strategy, listed in a manuscript. And then what we devised was triage criteria, and we had primary and secondary triage criteria. The primary criteria was the prospects of you surviving on the ventilator, prospects of you surviving on the circuit, how short the ECMO run would be. And there were ethical principles that guided us. You had to be fair, you had to be transparent. And then the selection criteria was specific, not so much as for the disease process, but for what the indications would be, pH ratio less than 7.2, or a PaO2, or a PCO2 value. But the idea initially was we had the circuits available. We thought we could offer the services to everybody and anybody who needed it. Our focus was entirely on managing the patients on the mechanical ventilator. Just to give you a perspective, Simon, we've taken care of 1,300 mechanically ventilated patients in the Cleveland Clinic systems, between the region and the main campus. And out of the 46 patients that we've currently, or the 56 patients that we've had on VV ECMO, on ECMO per se, only 10 of them or 12 of them are cannulated in the main campus. The business that we had was completely from hospitals outside of the Cleveland Clinic enterprise. So the investment into having 6 dedicated critical care pulmonologists following the COVID patients yielded rich benefits, and that translated into far fewer patients going on extracorporeal life support. So everything that we hold dear, high PEEP, low tidal volume recruitment maneuvers, volume depletion, prone position ventilation, sparse use of neuromuscular blockade, attending to ventilator dysynchrony, all that held very well. So for me, the success story is more so the fact that we prevented the transition of these patients from mechanical ventilation to ECMO. So the Cleveland main campus takes care of over 100 patients of ARDS per day, and this is going back H1N1 data. 30 patients will have severe ARDS. it's not unusual for the medical ICU to contribute 10 or 12 patients to the ECMO load every year. And that's what we prepared for. We prepared for 100 patients, and they never happened, and that never came.
Impressive. And it's impressive about how getting the basics right matters. I suppose, yeah. Luigi, any thoughts about this and the fact that patients with a slightly higher mortalities and conditions that we would have previously treated may suddenly start to get excluded from ECMO?
Thanks. I think it's a very interesting debate, and obviously we will touch upon these ethical principles later on in the next few minutes. But obviously, we pre-COVID-19, obviously we followed the EOLIA criteria. Which I think are very clear in terms of severity and duration of the severity of the disease. But also we had to think at population level. We had to think about maximizing benefits. And to maximize benefits, clearly duration of ECMO is a quite important factor. So we've done a modeling analysis, and we thought if a patient could stay 2 days shorter on ECMO, we would increase 25% the number of patients who could benefit from ECMO. So duration is certainly important. Also, we know the duration in COVID-19 is double compared to the non-COVID-19. So in our own institution is 10 days median duration for the non-COVID, and is about 20 days of ECMO in the COVID. And the other thing is clearly the chances of success is important. As George was saying earlier on about the tracheostomy, then patients who don't have any chances of recovering, then ECMO becomes futile and a bridge to nowhere. So I think those are useful, particularly if we're done at the beginning, and then we can ensure that there is transparency, as Sudhir was saying, but also there is equity, and we can certainly maximize the worse off, which is one of the very, very important ethical criteria we'll touch upon later on.
Thank you very much. So, yeah, I think it's true to say, I think it's led us to think about things slightly differently in the ECMO world. Maria, if we could go on to the next slide, please. I think what we've learned as ECMO physicians is it's not just about who can get better, which is traditionally how we think about what is reversible and not reversible, but we've been started to pressurize a little bit more into thinking about who can get better, particularly or the likelihood of people getting better, particularly in pressurized systems. So we summarized the candidacy criteria for ECMO across the globe in these slides with the UK, US and Emirates criteria there. I think taking it in turn and just speaking to the criteria, whether they think they're the right criteria, and any thoughts about that. So maybe if we start off with Vivek in the Emirates.
So Simon, I think we could, as opposed to Italy and some of the other countries in Europe, we could see it coming. So we had some time to prepare the criteria actually, and just fine-tune them for COVID. And we stayed objective as the other criteria also showed. We did put an upper limit to the age because, as I said in my other presentation, the concept of end of life in the Emirates is still evolving. And we wanted to leave patients above a certain age to a case-by-case discussion. And we did end up putting a few people above 60 on ECMO. And the only other curious thing, which is slightly different, is we realized that although we had our criteria, neither the patients nor the referring centers have read them, obviously. So there is no network or national referral framework for ECMO. So the management of patients pre-referral was highly heterogeneous in a variety of settings, and often the patients were referred to us quite late. And one of the things that less spoken of is, we all speak about intubation to ECMO thing. One of the things that we less spoken of is the duration of illness, actually, even prior to intubation. People were scared of intubating for a variety of reasons. I think the COVID patient got a significant hospitalization in ICU with high flow NIV prior to even intubation. And we burnt our fingers in the first wave when we realized actually, even though they were referred to as a day 6, day 7, they had a couple of weeks on an IV or 10 days on an IV. At that time, that actually played into how much already lung damage they had when they did the CT scan. Unlike at St. Thomas's, we didn't have the luxury of doing CT scan prior to putting them on ECMO, but we did put everyone through the scanner as soon as we put them on ECMO. The second wave onwards, we added this criteria. Those who have had 2 weeks or more of illness within the hospital or more than 7 days, we wouldn't accept a patient without CT scan being reviewed. And I think that was the only difference. Now, obviously, you can have the criteria, but when the patients are thrown at you, the younger they were, the more latitude we gave them, actually. We had a few patients who were referred to us when we were on our last machine. A 22-year-old who was pregnant and prone for 4 days, actually, waiting for our machine to be free to put her on. So by the time we got to her, it was day 9, and she had been prone for 96 hours, actually, with 22 weeks of pregnancy. But you can't say that they are day 9 or day 10 or day 12. We just had to take our chances. So I think a little bit of subjectivity, a lot more actually as the pandemic progressed. So the criteria were not always easy to follow.
I think it's a very interesting comment. I'd just like to pick up on that one thing about the duration of illness prior to intubation and those patients who are on high flow nasal oxygen and NIV. And you're feeling that it's a bad thing, and I think I concur. I suppose, what's your thoughts about that period of time prior to intubation, Sudhir? I think you might be on mute. Sorry.
Great question, Simon. So duration. So I hear Vivek talking about subjectivity, and I know where he's coming from. Day 7, day 8, day 9, who makes those rules? How do we go with, are we going to strictly stick by the earlier criteria? We did our best to do so, but have we made exceptions? Yes. The anxiety increases with the younger patients, but I also want you to know that, these 4 institutions that have come together to have this discussion work in completely different landscapes, clinical, financial, social, and ethical landscapes. Here at the clinic, we have a very robust transplant program. We have a very ambitious program. We have very passionate transplantologists and surgeons who do everything in their power to get a patient from point A to point B to be required to. So for us, it was not just about bridge to recovery, it was to select a set of patients, and if they deteriorate, to manage them long term as a bridge to transplant. And we'll hear about it from Ken McCurry and Marie Boudet very soon. So for us, there's an added pressure now. A 40-year-old patient who's been referred day 18 of ECMO, should I commit him to extracorporeal life support in the anticipation that he could be the one person who improves on ECMO? And if not, then we bridge him to the point where we decide to transplant him or withdraw care. So that's an added pressure that the main campus faces. And we found that we've had that situation arise more than once, and very recently, 3 days ago. So it is what it is. As of now, a bridge to decision, a bridge to recovery seems to be our primary modality. We have, as a rule, accepted patients up to 7 days. Non-invasive ventilation was not thrown into the mix till November, December, when we, reconceived our triage criteria. But then we started looking into that very closely. I'm aware that the NHS, I guess more than 1 day of non-invasive ventilation counts towards your total days of mechanical ventilation. No, Luigi, is that not true?
Open the floor to Luigi. And I'll clarify that point. But you're right, there is that clause in there. But you carry on. Sorry to interrupt by shaking my head.
So we've used an arbitrary value of about 72 hours plus to be counted into the non-invasive ventilation. But I also know anecdotally that our culture changed as the number of circuits started going up, and we started feeling the pressure of having 15 or 16 circuits. We started looking at non-invasive ventilation very closely. But what we realized was we had very little control on patient management prior to being committed to ECMO, and I believe those have serious implications on your outcomes. And we had very little control over those patients. So the patients that were managed by us and cannulated by us here in the main campus, I know for a fact have different outcomes.
That's fascinating, and I think it's fascinating also the larger scope to bridge to transplantation, which is possible within the United Kingdom. I don't think it's happened, but certainly isn't as freely available, I'm sure. So Luigi, would you like to comment, particularly I suppose about this period of non-invasive high flow nasal oxygen? So I think it's a conundrum that gets everybody a little bit, isn't it?
Yes, absolutely. Yeah, thank you. I mean, so if we go through some of the criteria, obviously earlier on during the first wave, we had to make a decision about modifying some of the criteria, both to be more specific. So referral rate went up tenfold compared to the pre-pandemic. So obviously we had sort of literally thousands of patients referred to the system, about 5,000 patients referred in the last 12 months. So it's quite a large number of patients. So obviously the first one is quite vague, isn't it? Potentially reversible disease. And if you think about that, that includes what Vivek was talking about, maybe a sort of gestalt idea about the severity of the disease, the CT scan when available. But in a way, if you think about that, when we think about strictly COVID-19, it would fit the first criteria. COVID-19 is a potentially reversible disease unless there are other factors. Now, some other things were just to ensure that all the basics were done right. We know that prone position, as Carlos said this morning, is sort of a positive response to prone position improves outcome. And we've got some data just coming out in CCM this month showing that in the UK population. But also the idea that we couldn't really give a threshold of age and other comorbidities. So we used the RESP score, knowing very well that it's not validated for COVID-19 and is not validated for decision making into going into ECMO, but just to ensure that we could discuss among centers and ensure that we would have equity of access within the ECMO service. Now, regarding the NIV, we realized in second wave that the number of patients who were on NIV for weeks before eventually getting intubated, and then maybe they were day 1 or day 2 ventilated invasively, but maybe 3 weeks non-invasively. And the question is the lung damage potentially different whether we change the interface? So we know that some patients had maybe 10 centimeters of water or pressure support over 10. So that's a 20 plus inspiratory effort. Is there any different non-invasive compared to invasive? So we took a view that if a patient was extremely NIV dependent, so requiring NIV 24 hours a day or thereabouts, and had high pressure and high FiO2, that day would be considered equivalent to a ventilated days. But if a patient was on, let's say, CPAP and was on and off CPAP with good rest, with high flow, for example, so not completely dependent, that would not be considered a day of invasive ventilation. So it's quite arbitrary, but just to say, are we essentially, you know, in a different institution, maybe that patient would have been intubated, and the fact that some clinicians opt to persist with a non-invasive ventilation is different to the lungs. So we took that view to say, yes, this is equivalent to the lung to invasive, that one not is appropriate CPAP. And we realized that nothing is perfect. That's why a discussion among centers was really encouraged through daily conversations. So I'm not sure whether I answered your question, but it's not as yes and no, is a little bit more considered.
And I think, to me, I think it's important that if people get intubated at a different time point in their illness, it all still counts. Oh, Steve was there transiently. I wondered if he could provide a flavour from Florida. Oh, gone. Sorry, if you come back, Steve, we'd love to have you. So, thank you very much. Yes. Oh, yes, Steve, yes. I suppose thoughts from Florida, whether it's the same across the US, about criteria for ECMO and the big things impacting on your selections.
Right. Thank you for including us down here in Florida. We're happy to be here. Yeah, we're at the epicenter of the pandemic, at least in America. So we've had an awful lot more, as everyone is talking. We have way more candidates than we have ability to take care of. So we are desperately trying to deploy our devices in a way that stewards our resources so that we can get the right patient. We select the right patient at the right time so we can have a reasonable degree of success. What we usually do here is we try to get them as early as earlier, usually being better. So we will count the non-invasive and the invasive support time as equivalent, whether they're intubated or not. If they're on BiPAP or high flow, that will count as a day of support. And if it's under 2 weeks, we count that as a very favorable part of the criteria process. Our criteria is in line with what you're describing with the EOLIA criteria. The other thing to consider is, age seems to make a big difference. We have sort of a luxury of being able to select it's sort of a weird luxury of selecting very, very young patients because we predict that they have a high degree of reversibility. So if they are quite young, if they're under 30 or even, in their 20s, even under than that, we are able to stretch our criteria quite a bit because we think the age plays a big difference.
Excellent. I suppose it's a nice thing to talk about age. It's a difficult thing to talk about in the UK sometimes. We're not actually, we've got to be very careful about putting age criteria on things. In the Emirates, Vivek, you were saying a maximum age of 60. Did you manage to always hold to that, or did you bend occasionally?
So no, as I said, we had to put a age there because once you have an open-ended policy, and I think that then becomes a very difficult issue to navigate. But we did put, we had a small cohort of only 29 patients that we put on ECMO actually, but we did put a few patients above 60. But they were actually in excellent health beforehand. They ticked off most of the other boxes, So we felt as if we had to make exception for them, and 2 out of two-thirds of those did extremely well, went home actually, not even through a rehab. So, but that just allowed us the freedom to choose the best above 60s that we felt was that best satisfied the remaining criteria, had the best of care prior to that point. So we took our chances with those.
Sure. And coming to you, Luigi, because we were talking even earlier today that age is a very easy thing to measure, isn't it? So it's easy to make a criterion about it. It's important if Maria, if we put the next slide up and we could talk about it in the context, or if we go forward to another slide as well.
Could I, Simon, while we wait for the slide, could I mention something about?
Yeah, sure.
Really, you're right. There are lots of things that they're very important decision making that we can't really capture in a metric that is easily, we can say above or below. So it's not dichotomizable as much. But actually, this problem, the problem of age or setting an upper limit, is become less and less of an issue with the second wave and third wave. So average age of our referral in second wave was 46-year-old, and the average median age in third wave is 36-year-old. So that criterion really doesn't really help us in decision making. And I think that is data, particularly the one you're showing now from Barbaro. It's mainly from the first wave, isn't it, Simon? I just want to point out that sometimes we think we are rationing or we're selecting criteria, but actually it doesn't fit the population that we are going to apply those criteria.
Yeah, I very much concur. We've seen younger patients, maybe because all the older ones died off in the first wave, if I'm being probably unfair. So yeah, this is links. Luigi is very correct. This is first wave data. This is ELSO data, Ryan Paparo and from the ELSO registry, and they just looked at what factors were associated in a multivariable analysis with survival. Few people have talked about age. That's the first top line. I suppose picking up on other factors that may have come out here. So we've had a lot of discussion so far about hours from intubation to ECMO or hours from illness start to ECMO, and that is probably it's the fifth line up from the bottom. But we all believe it impacts very significantly. I suppose I put it out to the panel. Why do we think that? This is just one study. I think if you took the Le Breton data from Paris, actually, it would slightly contradict this. So I suppose it's what other factors people, and I'll go through everybody in turn, really influence them in their decision making about patients' candidacy. We've talked about age, we've talked about duration. Anything else? I suppose maybe to Sudhir first.
Simon, if you go back one slide, I put my concerns in one table, and that kind of, not this one, going backwards, Maria. There you go. So we conceived this table looking at our own data, and this was conceived late November, December, like I said, as the pandemic over here was racing to its zenith. We had to look into all aspects of how we select our patients. So here at the main campus in 2018, when the group was conceived as the medical ECMO group, we partnered with our transplant surgeons to bring this group to fruition. And to Luigi's comment on the REST score, what we essentially we have for the last 3 years is a selection process. So being prospectively following every patient who's been committed to extracorporeal life support from the medical ICU for VV ECMO and around our region. And we're hoping to write our experience up very soon. But you're spot on with the REST score of more than 3. A REST score of more than 2. What we realize is there's a 50% plus survival benefit with ECMO. But then there were other aspects that we thought we'll bring into consideration, especially when we hit our operational stage. And the idea was to bring this into play as things evolve. As long as we had circuits, we thought, well, it's usual business. But we knew that patients over the age of 66, we would be mindful about that. But our ethicists warned us. We're concerned about our absolute denial to patients over the age of 65, and we said, you know what? If you have a single organ injury and you just climb down the Mount Everest and you've got COVID ECMO, well, you go on the circuit. And we also know from experience in the cardiothoracic ICU, we've had senior patients going on extracorporeal life support post CABG or post cardiac surgery who have been salvaged. So here at the main campus is all about pushing the boundary as much as we can, but we also realize that multi-organ injury truly would affect their outcomes, and we started looking at it way more seriously towards the second wave when things started taking a turn for the worse. But before that, if you had AKI and you were on severity and you were young, we would consider you. But what I want the group to be mindful about is this: in our situation, there's always an exit strategy, but we could consider you for transplant. And then we've seen patients with profound AKI recovering, over the course of time on extracorporeal life support. And we've been following our patients, and that's another piece of data that we're hoping to publish very soon is our experience with recovery, AKI recovery post ECMO. So this is long and short about what we tried to do. Obesity was an issue with us because a third of Ohio is obese, it's classified as obese. But we know we had surgical challenges with cannulating obese patients and maintaining them on the circuit.
Sorry to interrupt, but we've got questions coming up, and I don't know whether you can see them, but
I can't see those.
Yeah, well, they are, Nick very kindly put in the chat, but essentially, maybe I can start.
Yes, please do.
About whether we would consider the value or experience with proning assume on ECMO. And I can start saying that we do use proning on ECMO, and there is clearly a value in it. That there is a current randomized controlled trial. Matthew Smith from Paris is the primary investigator. We use it. I mean, we know from small study there's one in Italy. I think, if I'm not wrong, about 230 patients shows a potential improvement in survival, but a prolongation in ECMO duration, which is obvious, but I don't know what other people think. And then I'll just read you the second one is about awake ECMO. I can just briefly say my experience and I'll leave it to you. We had only 2 awake ECMO in the COVID-19, mostly their work of breathing and inspiratory drive is so much that it's very difficult to get them awake. As George was saying earlier on, we had only 2. And I think the best selection is to have them awake from the beginning rather than put him on ECMO and extubate. That's my very short questions to this answer to those 2 questions. Simon, over to you. Sorry.
I might take the liberty of talking about PEEP. Yeah, I agree entirely about PEEP. We've got good data that, prone positioning, sorry, that prone positioning works very well. It always seemed very nonsensical to put the ECMO cannula in somebody and then stop proning them at that point in time. My only caveat is that we have had many patients who've gone down to 30, 40 mil tidal volumes. And I'm not quite so sure of the benefits of PEEP prone positioning, sorry, in that context. Passing prone on to everyone else. Steve?
As a general rule, when we're on ECMO, we do try to prone. Now that depends on your cannulation sites, and it depends on your surgical factors and how obese you are. There's a lot of things, even though in an ideal world we would prone on ECMO, I have to say that's a huge challenge for us. What our main consideration is not keeping them is not proning them. Our main consideration is waking them up as quickly as possible to mobilize them. That's really our end result. If you're proning, that can get in the way with that. If you're trying to battle with a patient who's difficult to sedate on ECMO, I'd rather spend the effort waking them up and getting them compliant on their circuit, complying with the ventilator, and even getting up. If I had to delay that process to keep proning them, I would consider that a reasonable trade. But it's as you say, there is good reasons to prone patients, and in the ideal world, that should be done, and it should be a consideration, because you have to balance the sedation regimen on ECMO. I'm not sure if this was discussed, but we are finding that these patients are quite difficult to sedate relative to the normal ECMO run. Our normal ECMO run, our normal respiratory failure, these patients are very difficult and take. I don't have data to support this, but just our anecdotal experience has been a tremendous amount of sedation relative to other patients. We would struggle with that. I would rather spend the effort waking them up carefully and slowly than I would proning. That's been the Florida experience, but I think that time will tell when we start to get with bigger numbers, where the differences really lie.
I posed that one to Vivek then, out of the blue, about how he's found sedating patients on ECMO. Have they been more problematic in people with COVID-19 or not?
So we proned a fair number of patients actually, and we found that proning early on in combination with APR, we were able to recruit them much quicker. We didn't find so much struggle because we had early tracheostomy rehabilitation, intensive rehabilitation. So first wave, we did not struggle with that actually. But the second wave, we found that we have at least a third of the population that was incredibly difficult to sedate. And even after 7 to 10 days, it was just not possible to have them awake. And we tried to look for it. There was a variant specific, tried to check the genomic, they were all Delta variants in our second wave, and yet, and they were all females. Interestingly, a third of our patients in the second wave were peripartum ladies. So, but except those, everyone else, we had them, prone. Well, even those who were prone, we had them awake early. We had no struggle. 20% we did have a significant struggle with sedation.
And Sadir, your thoughts about proning and ECMO and sedation?
Yeah, Simon. So a huge fan of proning. I see no reason for us not to extend that therapy to our patients committed to ECMO, especially in the first 7 days per protocol. Why should the physiology change just because you got 2 cannulas in someone's groin? It makes no sense to me. Huge fan. I've seen it work in the medical ICU. There's no reason it should not work in a cardiothoracic ICU. For that effect, we created a prone protocol. We proned 4 patients, 1 with a tracheostomy, 2 chest tubes, and the cannulas in. It takes about 1 minute 36 seconds to get a patient from supine to prone for us, and it takes about 48 seconds to put them back into the position. It requires a village to do it. I actually have videos of that, but it can imminently be done. So to that effect, we had actually had a pro-con debate. Me and Abhi had some discussions. We have a protocol in place. My hope is, assuming that it has the blessings of all my colleagues, is to implement this actively starting the month of November. Now, I reached out to Marco Gianni, the paper Luigi speaks about. I actually reached out to Marco and his group, shown at least in the observational data, some exceptional results. And here's what Marco said. So I said, Marco, when you prone patients, to what end do you prone the patients to? At least with the Perceiver study, we had clear endpoints. You prone the patients till you get to a PF ratio of more than 150 and a PF is more than 60% and a PEEP is less than 10, and then you stop proning. So how do you decide when to stop proning on a patient on ECMO? And he says, so we prone them till such time that they're on pressure support ventilation. There's a significant commitment by his group. And when I spoke to him 3 months ago, he said he had 19 patients who he has prone consecutively. But albeit they were younger patients, and he's got a 90+ survival in his group. But I know that the group was challenged with a lot of cases, and the case mix was probably different. But that encouraged me. And then we know we can do it safely. And then it has been my anecdotal experience, and I'm keen to hear what you have to say. But the first 3 days post ECMO cannulation, patients are reasonably sedated, and we face the same issues like Stephen mentioned, and that's true the world over. I've been in touch with colleagues from around Northeast Ohio, Columbia, and everybody said the one consistent thing: hey man, this has been difficult. Sedating these patients have been very, very difficult. But then it doesn't surprise me, you see, I mean, think in terms of the degree of valvulitis that you have. You've got mechanoreceptors, J receptors, all your receptors are on complete firing. You're bound to breathe hard and heavy. And then you breathe hard and heavy, you're desynchronous with the ventilator, you're chugging, the problems on the ECMO circuit, and your default mode is to sedate the patient. So that doesn't come as a surprise to me. The endothelialitis, the alveolitis with COVID pneumonia may be more profound, and we know viral pneumonias are worse off than bacterial pneumonias. So as the patient wakes up and his tachypnea, well, that is real. And if you have a patient committed to a ventilator with a PEEP of 16 trying to breathe against it, is going to be a problem. And then you have a patient on extracorporeal life support whose volume is euvolemic. He starts coughing and straining. Then you're chugging. And then your stats are down to 80%, and then by default you go up on the sedation. So that doesn't come as a surprise to me, and that's true the world over.
Excellent. Thank you. We are actually running out of time. We could probably talk for days and days and days. But to be fair to the next session, I suppose if we go forward to the outcome slide, that one slide, we might just a final sentence each. Just about thoughts. Obviously, quoted mortality varies across the continents. This is all about case selection and the different types of patients that are being considered for ECMO. It's no reflection of quality. But people were quoting of the orders of some 50, and as Adair said, up to 90% survival. In patients on ECMO. Final thoughts about ECMO and COVID-19. I'll just give you all a minute each, and then we'll close. So Luigi.
Thank you, Simon. I think one clearly thing is patient selection. But I think if we have learned something about volume outcome relationship from the ELSO data, from the Greater Paris data, we know that probably the volume outcome relationship plays a part. And I would say, based on what we know now, so if we think about the single patient meta-analysis of the CESAR trial and the OLIA trial, they show a survival of about 36%, sorry, mortality of 36%. And if we look at the meta-analysis, the recent meta-analysis of all COVID-19 patients is a mortality of 37%. So I think taking everything equal in terms of patient selection, volume outcome data, I don't see huge amount of difference between COVID and non-COVID patients, and I don't see why the inclusion criteria should be very different, with all the differences we've highlighted yesterday and today. But I think I want to end on a note of optimism, and that's what I'm trying to say based on the data we've got available so far. Thank you.
Final words from Vivek.
I agree with Luigi, Simon, that I think our experience with COVID, especially the second wave on, which has been very similar to non-COVID ARDS patients. And as you know, obviously we haven't spoken about the role of steroids. The second wave onwards, you know, that has definitely made a difference in outcomes from our own experience. But I see no reason not to put patients on ECMO with COVID, severe COVID ARDS to fit the positioning earlier criteria. I mean, we still have some way to go about prone positioning prior to putting on ECMO. I think we know prone positioning works, and I think one of the things that we struggle, and I think others may struggle too, is what is the endpoint for prone positioning before putting people on ECMO, and that's something I think we'll be looking at ourselves here going forward.
Thank you very much. And final thought from you, Sudhir?
Simon, so for me, the one takeaway from COVID was looking and caring for these patients for the better part of the last 20 months as one of the designated COVID ICU attendings is keeping it simple. You get your basics right, patients don't need to go on ECMO. And that's coming from 1,300 patients. You work with a select group of colleagues who take the ball and run thereafter with you. Write up protocols, stick to the guidelines, be committed to that, and your patients don't go on ECMO. My mortality rates in my center do not reflect the care that the patient has received because 3/4 of the patients have come from somewhere else, either on ECMO or days on mechanical ventilation. But despite that, we still have a 50% mortality outcome. So if you were to commit a patient, 2 days into mechanical ventilation and say, you know what, look, I salvaged this patient, well, then I would ask myself, hey, listen, now you selected the patients too early. I've looked at the data, North American data, and the patients have been committed to extracorporeal life support 3 days into mechanical ventilation, as opposed to us 6 days out. And the only way you're going to get on extracorporeal life support is after having exhausted conventional therapy. And that was a promise to our surgeons, who've been very, very supportive of this program. So for that person there was a question about awake intubation. No, you cannot do an awake ECMO. The resources required to commit a patient to ECMO are tremendous, and you have to fail mechanical ventilation before you commit the patient to ECMO. Matthew Schmidt reported a case report, but the patient declined mechanical ventilation and opted out to. Till such time as ECMO becomes economically viable, I don't think that should be the first option.
Thank you. And then just to close, Steve, your final thought?
I want to echo most of what Sudhir said. I really appreciate the viewpoint and keeping it simple. In the setting of COVID, there was such a blast of news and small case reports and small trials. We might have lost sight at some point about how to take care of somebody in viral pneumonia with respiratory failure, and our old protocols still apply. We have to keep pushing forward with oxygen delivery over time. What has been very clear for us is that no matter what you do with a COVID patient, it takes a sustained amount of effort over time to get them better. So all of the bells and whistles and the ECMO and the waking them up and proning them, they're all very helpful, but what it really takes is a thoughtful care team over a very long time to get them better.
Brilliant. Thank you very much. Thank you all. You're an amazing panel, and I think some very interesting conversation there. I think we kept to our 45, George, but we didn't gain you any time. Sorry.
Right, we're going to have a day of ECMO next time round. I can see eyebrows going up. Yeah, I've got a few people sitting around here. Anyway, thanks so much. I think it was really great to hear all your opinions. I would have had a difficult question for all of you, but I won't ask it. It would take us too long. So we will regroup at 20 to 4. I hope that is acceptable. As in, obviously, I need to think about time differences. 20 minutes to the hour. I think that should make it clear for everybody. Thanks so much and have a nice day.
Okay, so welcome back. So this session is very specific, and it kind of takes us back where we started when our Chief of Staff introduced us to the conference yesterday in London, because Tommaso Falcone, as I'm sure some of you know from Ohio, he specializes in uterine transplants. But we're going to talk here about transplant, and the two chairs for this session are Kenneth McCurry from Cleveland Clinic Foundation, and Chris Villars from Cleveland Clinic London. So take it away, guys.
So thank you very much, Nick. And I guess before we proceed, and just on behalf of our group, just like to commend the speakers who've come before us, and also to compliment George, Luigi, and yourself on a fantastic conference so far. And I think there's a real sense now that these topics are coming together, and we're getting a sense of commonalities, both in terms of practice and pressures across centres. So it's my pleasure now to hand over to Ken. He's going to lead the first half of this session and shepherd us through the difficult topic of lung transplantation for COVID-19. Ken's pedigree is of over 200 lung transplants under his belt at Cleveland Clinic. And his status is also elevated because he has some additional qualifications in critical care. So, Ken.
Oh, thank you, Chris. Very kind of you. I'm certainly happy to be here this morning with what we consider just an outstanding group to try to address, as Chris alluded to, the very difficult topic of lung transplantation and COVID. So this will be a pro-con debate with Dr. Marie Boudev, Dr. Boudev is the medical director of lung transplantation, heart lung transplantation at the Cleveland Clinic in Cleveland, Ohio. She will take the pro, and then Steve Manier. Steve is the director of research and anesthesia for the Florida region and a intensivist heavily involved in ECMO treatment of patients with COVID. So I think Marie will lead us off with the argument to offer lung transplantation to patients with COVID. Marie?
Good morning and good afternoon, everyone. I'd like to thank the organizers and the moderators for the kind introduction and the invitation. So this morning, I'll be discussing the pro part of this discussion, that lung transplantation is a solution for COVID-induced fibrotic lung disease. Next slide, please. I have no conflicts of interest or financial disclosures in relation to this discussion. Next slide, please. Over the last 2 days, many of you have heard about that COVID-19 infection, and patients that are infected have really a mild or asymptomatic disease course. But there is a small part of the population that will get very ill and have severe disease. That's about 10 to 20% of the population, and they may require an ICU admission for ARDS. The mortality within this subgroup that develops ARDS is considerably high, up to about 65%. But there's also another subgroup that develops fibrotic lung disease. And the patients that develop fibrotic lung disease generally are older, that end up having more of a severity of their disease course, and also may be on mechanical ventilation. And we think about 1/3 of these patients will end up developing fibrotic lung disease. It's in these two populations that lung transplantation may be considered as salvage therapy. Again, it needs to be a very select patient group, patients that have refractory ARDS or patients that have pulmonary fibrosis that is actually considerable. There is no role for lung transplantation in acute COVID-19 infection for several reasons, precluding comorbidities, reasons why this patient may have gotten the infection, may actually prevent lung transplantation from being considered. And also in the acute setting, these patients may have side effects or outcomes or sequelae of their hospitalization, including frailty and other organ failure. Next slide, please. It was clear in March of 2020 that lung transplantation could be utilized in a select group of patients with COVID lung failure. These reports mainly came out of China, and shortly thereafterwards in Europe and North America, we were seeing more lung transplants being performed for this indication. Our International Society for Heart-Lung Transplant, our governing society, convened a task force that subsequently issued guidelines on how to select patients and what sort of patients to consider and what circumstances to consider lung transplantation for COVID-related lung disease. But again, they stated this should be a carefully selected group of patients, and some of the criteria are listed on this slide. So it's clear that lung transplantation is an accepted therapy in a carefully selected group of patients with irreversible lung injury. Next slide, please. The Organ Procurement and Transplant Network, or OPTN, started to collect data on how many lung transplants were being performed for COVID-related lung disease. And this is unpublished data that I'd like to share with you, and I'd like to thank the organizers from UNOS for sharing this with me. This is data from March of 2020 all the way to June of 2021, looking at the number of lung transplants that were performed from COVID, ARDS, and fibrosis. You can look at the heat map on the right-hand side of your screen. For those of you that may not be familiar with the geography in the United States, more transplants were done in the state of Texas and Florida for COVID, ARDS, or lung injury. There were registrations also on the left heat map, I apologize, that also show registrations were high in the states of Texas, and registrations mean listed patients for transplant in Texas, Florida, California, Illinois, and Pennsylvania, followed by Ohio. So they found through this period of time, 168 patients were listed for lung transplant. 142 lung transplants have been performed in the United States during this period of time for COVID, ARDS, and fibrosis. The majority of these patients were male, and there was a majority of Hispanic race that was represented. This is very consistent with some of the epidemiological data that we know about patients that have been infected and with severity of disease. Many of these patients were either on mechanical ventilation and or on ECMO. The data that we have is not very granular in describing which patients were on mechanical ventilation and which patients were on ECMO. That's not the way this data registry works. But many of these patients were maintained on ECMO after transplant, about 84 of them. The incidence of stroke, renal replacement therapy, and graft dysfunction, meaning a type of ARDS after transplant, was present and noted, but the signal could not be appropriate or approximated because of a lot of missing data. And I hope moving forward we'll have more data about this and to give us a better idea of the severity of illness or comorbidities after transplant. But one thing was clear from this initial data: the 30-day or early survival in this patient cohort is comparable to patients with non-COVID diagnosis that receive transplants. So the 30-day survival is comparable. We do not have midterm or long-term survival as yet. Next slide, please. At the Cleveland Clinic, our experience has been similar. We did our first lung transplant in July 28th of 2020. We have transplanted 7 patients to date. 6 of these patients have been external referrals, patients arriving on mechanical ventilation or on ECMO. These patients were extremely ill with lung allocation scores. This is the way we allocate organs based on a score from 0 to 100. If you're pretty sick, your score is going to be 50 and higher. These patients were very ill. The scores ranged from 51 to 88. The wait list time, meaning how long these patients were on the waiting list, was 1 to 3 weeks. Although 3 weeks may seem like a long period of time, these patients were so critically ill that there would be gaps in their care during periods of time where they'd have to go inactive on the list. So it did contribute to some longer wait list times. As I said, these patients were extremely ill. One of these patients was bridged to transplant on VA ECMO, 4 were bridged to transplant on VV ECMO, and 2 of them were on mechanical ventilation alone when they were bridged to transplant. 3 of these patients were on renal replacement therapy before transplantation, and 4 of them subsequently were on renal replacement therapy and remain on renal replacement therapy post-transplant. We had 2 deaths out of our 7 patients. The first death was 4 months after transplant in a patient that was our first transplant that was performed. We learned a lot from that transplant. This patient subsequently ended up dying of multi-organ failure and sepsis. And when I say we learned a lot, we learned about VA ECMO, we learned about RV function, we learned about how patients should be interactive and ambulating, or at least be participating aggressively in physical therapy before we consider them for transplantation or before we list them. Our second death was at 3 months post-transplant. Again, this patient died of multi-organ failure, sepsis, and there were some immunological factors that played into their death. 5 of our patients are alive at 90 days. Our longest survival so far is 9.5 months. In speaking to our surgeons, one of our surgeons being Dr. McCurry, who is moderating this session, and we talked about the intraoperative difficulties and challenges. I think all of our surgeons related, these were hard transplants. These were hard surgeries, but not prohibitive. In the hands of capable surgeons and surgeons at an institution like the Cleveland Clinic, these are doable surgeries. But what they would find intra-op is that these lungs would be extremely boggy and hemorrhagic. There would be a lot of adhesions that were present. And you can see in this image on the right-hand side, this was our first transplant. And look at this explanted lung. It looks like liver. This is actually a lung. It's quite large, quite boggy, very hemorrhagic. And I'm sure Dr. McCurry will comment on the conduct intraoperatively, how difficult it was to physically, in the sense for surgeons to perform this with the N95 masks on and all the other protective devices they had, and the way they communicated in the operating room so that they could talk to each other and continue with the surgery without any barriers. Next slide, please. So what is our protocol at the Cleveland Clinic? It follows some of the ISHLT guidelines that I showed you in the second or third slide when we commenced this lecture. We do not consider these patients during the acute phase. Prior to patients being listed, they must be SARS-CoV-2 negative by PCR nasopharyngeal swab and BAL from each lung. If they are positive, then we consider cell cycle thresholds to determine whether or not there's viable virus present. They need to have normalized inflammatory markers and coagulopathy that has resolved. We use standard criteria, but I would like to tell you that standard criteria also includes patients being hopefully awake to agree to the decision to be transplanted, but we'll talk a little bit about informed consent a bit later. But these patients should be awake enough to participate in some form of rehabilitation so that we can continue to rehabilitate these patients after transplantation and they show that potential before transplant. That is absolutely critical. Otherwise, the other standard criteria of not having malignancy, active, out of control infection, as well as other factors are considered. Next slide. So I hope I've shared with you that lung transplantation is a viable option for COVID-related lung disease. The experience with this is becoming more common and is being done worldwide. These are very ill patients, though. I would ask you to note the numerous complications these patients can have, both pre-transplant and post-transplant, that you've heard about over the last 2 days. These patients need to be considered for transplantation, and if they are an appropriate candidate, they should be considered at centers that are experienced, that have the ability or capability to bridge these patients to transplant, either on ECMO or mechanical ventilation. At minimum, these patients need to be COVID negative at the time of transplant and their inflammatory markers resolved. They need to exhibit evidence of irreversible lung injury. The timing of transplant is a moving target, and we're learning more and more about this. When is the appropriate timing? At the Cleveland Clinic, we like our patients to be awake. We like them to be able to participate in rehabilitation if at all possible. But you need to examine each one of these cases on a case-by-case basis. So lung transplantation is an appropriate, viable therapeutic option for end-stage lung disease due to COVID. But the actual treatment for this is prevention of COVID in the first place. Prevention of infection remains the mainstay and the best strategy to saving lives. I'll stop here and hand it over to my co-debater, Steve.
Thank you very much, Marie. So Steve, Marie has laid down the gauntlet in the argument for offering this. Can you tell us why we shouldn't, or at least why we should certainly think twice about it?
I can certainly try. Thank you very much. I'm really humbled to be a part of this kind of group, and thank you for having me. So let me present the argument against doing lung transplants in the setting of COVID. And most of my arguments revolve around this is a very difficult procedure. This is a very difficult patient population, and it's a very, the time course is very rushed. So it's very important that we transplant the right patients. And that so we do everything right, and if palliative care needs to be involved, and we shouldn't necessarily consider lung transplantation in all patients. Next slide. I have no relevant disclosures or interests. Next slide. Just to double down on what Marie was saying, lung transplantation is a fairly rare operation. It does get done. There's about 4,600 worldwide. They're performed in selected cases. There's demonstrated to be an improvement in quality of life when the right patients are selected. The current median survival rate for all comers, at least in the series that we looked at here, was 6.2 years. Next slide. A lot of this is based on the lung allocation score. This is based on the age, the BMI, what kind of lung disease, the PFTs, whether or not there's pulmonary hypertension, whether or not there's other organ failure, and how far can they walk on a 6-minute walk. The lung transplantation score is unique among the solid organ allocation systems in that the preoperative mortality without lung transplant is considered. Also, the first year after a lung transplant is also considered. These lung allocation scoring system was recalibrated several years ago to design to calibrate to avoid futile transplants. Without a very careful selection process, these lung transplants can do poorly, and it's important that we choose the right patients that are going to both do well with a lung transplant as well as really need one. Next slide. So the common indications for lung transplant are the COPD population, the ILD population, cystic fibrosis, and pulmonary arterial hypertension population. Those are the kind of patients that are slowly decompensating and find that they have a need for lung transplantation. It's a delayed process. It's a long process. These patients live with this disease for a while. And then determine that lung transplantation is their best bet for increased survival, increased quality of life. Lung transplant for ARDS is a very unusual population to transplant. It's a very uncommon strategy. It was uncommon before COVID, and it remains uncommon now to see a patient in severe ARDS, end-stage ARDS, and consider those patients for a lung transplant. Next slide. The reason ARDS is an uncommon indication is because the outcomes are not as good with the ARDS population. It is known to be a rare salvage option in selected cases. The median survival rate in this patient population is 5.3. That's not the COVID population, but the all-comers ARDS population. The 3-year survival rate for this kind of patient is at 78%. Next slide. As Marie was mentioning, the surgical difficulty for COVID is very notable. At least in this, this is a review from Northwestern. They were asked some questions, and based on their expertise and experience, the average time for this operation was about double from a non-COVID transplant, and the transfusion rates were greatly increased. They're getting dozens of units of blood during this transplant. As was noted before, there's a lot of difficulty, there's a lot of adhesions and scarring, and there's also a higher incidence of primary graft dysfunction after the transplant. It was noted by this group as an option of last resort, and that's how I would approach these lung transplants in this difficult population. Next slide. Informed consent is an issue. A lot of these patients that do get lung transplants in the setting of COVID are sedated, they're on ECMO, they're not an ambulatory population. They're very difficult to interact with population just by the nature of the disease. Their mental status is usually excellent, but it can be altered to ensure compliance with both the ECMO machine and also the ventilator. The family dynamics are difficult in the setting of a hospital setting where there's reduced visitation rights for these kinds of patients. We are trying to have a very, very important long-term conversation with these patients within a very compressed time frame. You can see that the median time towards getting very sick, towards getting a transplant, is compressed. It's 70 days after being intubated and 55 days after being on ECMO. There's a lot of thinking about what your life will be with a lung transplant that has to take place during that very short time frame, and that's something that the multidisciplinary team has to walk the patient through while they're very sick. Next slide. The long-term data is lacking. It's lacking here. It's lacking everywhere else. There are tiny studies, case series, anecdotal experiences that do show possibly a higher incidence of primary graft dysfunction. Whether or not they have recurrent COVID in the transplant is something that needs to be considered. And at the Cleveland Clinic and in other places, they do look for active COVID infection in these transplants. And then it'd be a necessary part of the lung transplant evaluation that they'd be COVID free. But those PCR tests do have a certain amount of calibration, a certain amount of gray area. If you still are PCR positive, do you have an active infection or not? And that's not an easy question to answer, even though it might seem like one. This autopsy shown here on 5 lung transplant patients in the setting of COVID shows extensive evidence of injury and fibrosis that resembled end-stage pulmonary fibrosis in the allograft. So these patients can do well after lung transplant, but there are anecdotal and small signals that these COVID transplants do not act like a normal transplant because the real answer is we don't know what the COVID population is going to look like long term. So we don't know what the transplant population after COVID is going to look like in the long term. So these are unanswered questions at this point. Next slide, please. Palliative care is seen, culturally as an option of failure. It's usually, or it can be used as a tool at the very end of a hospital course when a patient has exhausted all options for recovery. Then palliative care gets involved, and then those doctors and that care team is seen as, well, we can't get you better, so let's call palliative care. The options for continuing treatment in that setting are morally and culturally very complicated. We need to make sure that when we're treating these patients when they're quite sick, preparing them for lung transplant, that the palliative care team is involved very early to make sure that all of the options for this patient's disease management are explored, and that doesn't always involve the most aggressive experimental option. Which lung transplants are an excellent option in the right patient at the right time with the right data. Palliative care and medical management and a dignified passing, if that is part of the disease process, is a realistic option and it can be a culturally appropriate, morally appropriate, beautiful option for the right patient that doesn't meet criteria for a lung transplant or doesn't wish to live the lifestyle of somebody who's had a lung transplant. So when we approach these patients at our hospital and the Cleveland Clinic, we need to make sure we have a multidisciplinary discussion between the surgeons, between the intensivists, between the pulmonologists, and also palliative care, so that the patient is presented with all the options to make sure that the patient is getting an informed consent is the primary driver of this process. If they do choose to aggressively pursue salvage options like lung transplants, that's an option that I would say that we're excellent at providing. If that is not within that patient's goals of care, that is an option that needs to be explored as well in terms of palliative care. Next slide. So in summary, the lung donors are very rare. It's a scarce resource. It's an uncommon operation. In the setting of ARDS, it's a very uncommon operation. COVID transplantations are very difficult relative to an already difficult operation. The informed to consent process can be rushed. It can be compressed, but this is normally a long process that involves a deep decision about what it's like to live with a transplant. There's no long-term data on this, and palliative care option needs to be part of the multidisciplinary discussion when we're sorting patients out who might be interested in pursuing a very aggressive option, or they might not, and a balanced opinion needs to be presented to the patient.
Well, thank you, Steve. So it sounds like we might have some middle ground that lung transplant it can be considered, but only in very select patients and very restrictive criteria. I think we have time for maybe just a couple of questions, and then we'll move on to the second half. So, Steve, you come from you're at a very high-performing cardiopulmonary center, does a lot of ECMO for COVID, but does not have a lung transplant program in Florida at the CCF facility. So can you give us a little bit of idea about how you and your team approach these things within your center, when you might consider lung transplant, which population, and how you go about that?
Yeah, one of the wonders of practicing in this environment of a pandemic is that we're all very much on the same team. Our internal providers, we're all on the same team, and our centers statewide and nationwide, we're all very much attacking this problem as a group. So that's something that is important and is a very nice environment to practice medicine. These patients, everything is done as a team effort. Certainly my team is heavily involved, and so are the pulmonologists and the MICU intensivists, as are the lung transplant, as are our cardiothoracic surgeons. So it's a deep decision that involves a lot of thinking on each patient every day. I would say that when we're evaluating these patients for lung transplant, we have our basic criteria of if this patient is going to survive our hospital stay at all. And that is one round. And then if they are stabilized to the point where we as a group determine that they have a non-recoverable state, but remain in a single system organ failure, and they're motivated, and it's the right, and they have a good social support, and they're the right patient, and that they would survive the risks of this transplant, and it's within their goals of care. We as a group, usually led by our cardiothoracic surgeons who have a good network set up, will initiate these transfers to either local centers or up to Ohio. I know University of Florida has a very robust lung transplant center, as do the 3 or 4 others. What is well established is that if you're going to do a lung transplant on a COVID person, it needs to be at a high volume center. So that really narrows our network where we can send these patients. We don't want to send these patients to somewhere where they're not going to get better care. So it's important that when we transfer our patients out, that they're optimized, and B, we have an open line of discussion both amongst ourselves and with the referral network that we have.
Yeah, so Anne-Marie, so wearing your hat as the medical director of the lung transplant program, when do you want to get called from a referring center, and when do you think it's appropriate, and what's the sort of triage process that we go through just for our people on the conference that are not at a lung transplant program?
Thanks, Ken. That's a great question. This has evolved as the pandemic has evolved, and both Ken and I have been involved in this process very intimately because there is the chance that patients can come and will be considered futile and not make it to the point of for a transplant. So when we get called by an outside center, what we want to know, we don't need to know their whole course of what happened with COVID. What we really want to know is what they're doing right now. Where are they physically? Are they working with physical therapy? Are they awake enough to understand some of the implications, as Steve said, of receiving a transplant? Is the family on board? Is there a support system in place? And then also, obviously, if they're COVID positive or negative still. And that's something we routinely find that centers will not check when they're considering referring a patient. That just sometimes skips people's minds. So we ask them to do nasopharyngeal swabs as well as doing BALs. Then there's always the financial considerations that we address through their insurance. But the key aspects are, number one, they need to be COVID negative. Number two, are they participating in rehabilitation? Number three, what does the family support system look like? Because this is still a long journey to go forward with transplant. And then lastly, we go over some of the other medical issues. What is the right heart function looking like? Do they have a blown RV? Is there severe pulmonary hypertension? Are there any other comorbidities, such as renal failure, that may complicate but may not be prohibitive to proceeding with transplantation? Is infection controlled, or do they have an overriding infection that may be a problem? We've had several patients come in with chest tubes and air leaks and abscesses in the chest. We need to know about that because that adds another level of complexity, although not prohibitive, towards moving towards transplant. So again, you have to look at an experienced center when you're actually referring a patient, as Steve mentioned, and these are the steps that an experienced center usually goes through in determining if a patient is appropriate to consider for lung transplantation.
And just to address a couple of points you made there at the end, so you would not consider other system organ failure an absolute contraindication. For example, in particular, the kidneys.
Absolutely. This is a little bit different than what we routinely consider in a transplant that's walking, talking with COPD. This population we know is extremely ill, as you know, Ken, and can have other comorbidities, but are stable and being controlled and can be dealt with even after transplant, such as renal replacement therapy. As you saw with the data that I presented from our own institution, several of our patients were on dialysis before they went into transplant.
Okay, well, great. Well, I think in the interest of time, we'll stop things there and move on to the second half of the session. But thank you both for great presentations. It was really good.
Thank
Chris?
you.
Thanks, everybody. It's absolutely wonderful. So we'll move on to the second half now, and it's my pleasure to introduce my colleague, Sam. Sam's a consultant in intensive care and in liver intensive care at King's College Hospital in London. He's our lead for the ECMO service, and he's my friend and a wonderful colleague. And I'm looking forward to now to hearing his insights on the good, the bad, and the ugly of solid organ transplantation, I presume with a liver flavour to it in the context of COVID-19. Sam.
Great, thanks, Chris, for those kind words, making me blush a little bit with that. So I think, and thanks for the opportunity for participating in this great conference. I think both days have been fantastic so far, and it's been very exciting to be part of it. So I guess it's safe to say that the last 18 months have had a significant impact on delivery of medical services, and transplantation is certainly no different. Next slide, please. I think at the beginning of the pandemic, so if we go right back to March 2020, transplant programs around the world had to make important decisions on how or whether to proceed with life-saving interventions in a highly vulnerable population. With uncertainty regarding the effects of immunosuppression and variability in rates of infection and mortality in different countries and regions around the world, responses at local, regional, and national levels often varied. Next, please. And so you can see some of those early responses from around the world. So you can see that we can. So if you go back sorry, Maria, back one slide. So if you look at the initial early responses, you can see in the UK there was a commitment to supporting emergency liver transplantation for acute liver failure, but there were significant concerns relating to whether there'd be an ability to continue with routine transplantation due to a lack of ICU beds. And a similar stance was seen on the east coast of the US, whereas on the west coast, there was an ability or a desire to continue with all forms of transplantation for liver and kidney, whereas pancreatic transplants were suspended. Next, please. And you can now see here that similar variations were seen around the world, with some countries having to stop transplant activity completely, such as in South Africa, to other centres around the world, varying activity based on clinical need. Next, please. So starting with the impact on just the chronic liver disease population, several studies have now confirmed initial fears that cirrhotics and therefore those patients who have impaired immune regulation would be particularly at risk of having poor outcomes. And if you look at the two sort of graphs on the left-hand side of the slide, you can see this large international study looking at which compared chronic liver disease patients with patients without any liver disease. You can see that mortality was significantly higher in the chronic liver disease patients. And when you look at the bottom graph, where they specifically focus on those patients with chronic liver disease, you can see that although there were comparable rates of hospitalization and invasive ventilation, mortality increased with severity of liver disease as defined by Child-Pugh grade. Similarly, if you look at on the right-hand side, this North American multi-center study, which was matched for age and gender, similarly demonstrated that cirrhotic patients with COVID fared worse than those patients without cirrhosis. Next slide, please. Similar fears also existed with those patients, for those patients who were on the waiting list, and in particular for those post-transplantation. And you can see in this national study from England, which was published after the first wave, the incidence and mortality in both groups was significant and was steep in the early phase of the first wave, plateauing after a few months. When looking specifically at the risk of developing SARS-CoV-2 infection, you can see that it was actually, surprisingly, it was higher in the waitlist patients rather than the transplanted patients. Caveat being that there were relatively modest rates of infection in the liver patients compared to those patients awaiting kidney or bowel transplants. However, if you then look into those patients who did get SARS-CoV-2 infection and developed COVID and were hospitalized, mortality was more than 2.5 times greater in those patients who received solid organ transplantation. Again, those patients, the liver patients, had better outcomes than some of the other groups. One reason may be that these patients may just be a reflection of the burden of immunosuppression, as liver patients often need, in general, lower degrees of immunosuppression compared to other solid organ transplants. Next, please. And if we want to look at specifically just outcomes in liver transplant patients, this is a nice study, international study, with looking at comparing patients. I think there's over 150 patients who received liver transplantations with a comparison cohort of patients with just chronic liver disease. And you can see that hospitalization rates were similar and in both groups, but invasive ventilation and ICU admission was significantly different, with more patients, with transplant patients being more likely to admitted to the ICU and receiving invasive ventilation. That said, despite that, mortality was similar between both groups. And when they did some multivariate analysis, age came out as a significant predictor of mortality in both groups. Next slide, please. So what about the impact of immunosuppression? I think we all know that there are a lot of fears, particularly in the beginning, about whether immunosuppression would lead to worse outcomes. And it actually led to conflicting theories emerging as to whether immunosuppression would lead to more severe disease, or whether the immunomodulatory effects of immunosuppression would actually reduce the harm associated with the inflammatory sort of phases that are associated with COVID. And in this Spanish study, looking at over 100 transplant patients, they actually showed that not only was mortality lower in patients who'd had a transplant compared to the general population, but that immunosuppression was actually relatively safe. The only caveat being that mycophenolate seemed to be associated with more severe infection for those who have been hospitalized with COVID, and particularly those patients with mycophenolate at higher doses. Next slide, please. So clearly, the next question is really about how does this actually impact on the graft itself, and this study that came out of North America, looking at over 120 patients, tried to evaluate the impact of developing COVID on graft function, and looked at liver enzymes at baseline, so pre-COVID, so from historical data at the time of diagnosis, and then peak values during their COVID infection. Interestingly, patterns of liver injury centered around a significant rise in the hepatocellular enzymes, so ALT and AST were significantly more raised than ALP and bilirubin, perhaps converse to previously thought or predicted effects based on SARS-CoV-1 and other hepatotropic viruses. They also went on to look at define whether the severity of liver injury was associated with mortality. And as you can see in the bottom right-hand corner, you can see that the more severe the liver injury, the less likely the patients were to survive. Next slide, please. So just a few final words on using COVID-positive donors. Up until now, societies have generally recommended against using COVID-positive donors, except in sort of urgent circumstances. I think that was for fear of developing or giving recipients COVID infection leading to worse outcomes. But this Italian study was recently published only this month, demonstrated reports on 10 cases where recipients received grafts from COVID-positive donors. And you can see that 8 out of the 10 transplants, were performed after a median time of 46 days, from first testing positive, and 9 out of 10 patients survived after a median follow-up time of 220 days, demonstrating that not only is use of COVID-positive donors feasible, but perhaps could be used safely to increase the donor pool going forward. And I think with that, I will draw that talk to a close. Thank you.
Sam, that's absolutely great. Thank you very much. I'm just sort of mindful of the time, and I don't want to eat into Tasting's portion. So in 20 seconds or less, we know from some recent BLTG data that the number of offers declined by each unit for lack of critical care capacity was increased significantly by COVID last year. Having said that, we still managed to do sort of 250 plus adult and pediatric transplants at King. So are there a couple of key changes that we can make just to make sure that viable organs for transplant aren't going to waste?
Thanks, Chris. I mean, yes, that's an important question. And I think just keeping it short, I think the key to that is basically collaboration and it's essentially sharing out organs between centres where there is appropriate capacity and resource. So one of the things that we did quite well in the UK was that where centres struggled to admit patients where an organ came up, those organs were then were offered to other centres where they could use the organ either for their own patient, or ideally, because the organ benefit scheme in the UK favours patients who are most likely to survive with that particular graft, the patient could in fact follow the patient down to the centre to receive their transplant. And I guess other things that could be considered would be, which has not been considered but has been touted, would be to create sort of super centres where you could perhaps say that you would form smaller centres, larger centres in a smaller number of centres, then allow them to perform more transplants. In essence, ring fencing those beds for transplantation to proceed.
Great, Sam, thank you very much. And I'm really sorry to rush you, and that was absolutely wonderful. So as we move on to the final part of the session, one I've been really looking forward to hearing is about COVID in the pregnant patient, not least because when these cases come to the ITU, they induce, I think, in everybody an additional layer of anxiety and emotion. So it's my pleasure to introduce Dr. Tasting Georg. She's an assistant professor of surgery at the Cleveland Clinic Lerner College of Medicine, and as well as being an obstetrician and gynecologist, she also specialises in infectious diseases, and so I think is uniquely qualified to speak with us today. Tasting, over to you.
Thank you so much for your kind introduction. Thank you for having me. Next slide, please. So I have no relevant disclosures for this meeting. As we all know, pregnancy is an independent risk factor for severe COVID infection. Although the overall risk is very low, pregnancy has been associated with increased risk for hospitalization, increased risk of ICU admission, need for respiratory support, and if the patient has other comorbidities like diabetes or even morbid obesity, there has been increased risk of preterm birth and even preeclampsia. Next slide, please. Why is this so? Pregnant patients have adaptations that they have to go through to actually accept the fetus. So they have increase in respiratory rate, they have increase in plasma volume, and also a lot of immunologic changes. All these changes actually favor the fetus, and they leave the mother vulnerable. There's downregulation of pro-inflammatory cells, and all these changes will always leave the mother vulnerable. Next slide, please. So we can optimize the mother's health, which is better to do pre-pregnancy, and we can also vaccinate the mother. Pregnant patients need to be vaccinated for all infections, especially COVID. When you vaccinate the mother, you protect her and you protect the baby. You protect her, and most likely the baby will get some antibodies transferred. Also, the ethics of MFM tells us that we should never exclude pregnant patients from any investigational medications just because she's pregnant. Next slide, please. The case for vaccination. During the pandemic, I know a lot of meetings were going on talking about how to go about getting some vaccines. Traditionally, pregnant patients have never been included in clinical trials, and this is where the problem is. Women have never been included during pregnancy in clinical trials, and so we have no guidance when it comes to vaccines. And ACOG and SMFM have been advocating for this. We have data, albeit small, that the COVID vaccine is safe in pregnancy, is effective in pregnancy, and we have data that there is some transplacental and some benefits in breast milk. Next slide, please. There's been a lot of misinformation about sterility and infertility associated with the COVID vaccine, and this has been debunked. Pregnant patients and those trying to start their families can get their vaccine. Next slide, please. Pregnant patients who have COVID infection, whether it's mild, it's moderate, or severe, need to be managed like the non-pregnant patient. If they have mild infections, they can be managed as outpatients. They need to be called and they need to be checked upon. We want to make sure they maintain their oxygen saturation at least 95%. If a patient is complaining of persistent shortness of breath, consistent fevers despite antipyretics, or she's unable to complete her sentences, she needs to be seen in the hospital. If in the hospital she has persistent fevers despite antipyretics and she's unable to maintain saturation, she needs to be admitted into the hospital. If she's hypotensive and she continues to have a fever, a multidisciplinary management should be instituted to determine if she needs to be hospitalized or she needs to go even into the ICU. Next slide, please. This is from the Society of Maternal Fetal Medicine, and these are the things you need to consider if a patient needs to go to the ICU or not. Inability to maintain her oxygen saturation at 95% is one of the things you need. Hypotension, evidence of new organ damage. If all this is going on, an ICU consult should be made. And if you have persistence of any of these things, you need to admit her to the ICU. Not necessarily being intubated, but ICU admission to make sure that she's closely monitored and she's closely examined. Also, every medication that is administered to a non-pregnant patient can be given to her. At the Cleveland Clinic, I get phone calls about monoclonal antibodies. I get phone calls about remdesivir. I get phone calls about any medication that the non-pregnant patient can get. And the answer is always yes. The non-pregnant patient can get any medication that the pregnant patient can get any medication that the non-pregnant patient can get. And many times the provider is skeptical whether this is right or wrong. Patients should only be delivered if she's at least 30 to 32 weeks or if the risk-benefit ratios favors delivery. If she's not 30 weeks, we should do everything possible to keep the patient pregnant, unless we think that this might be a post-mortem delivery. And then at that point, we have to justify delivery. Next slide, please. And I'm going to stop here because this algorithm speaks for itself, what I've just talked about. If we think she's greater than 32 weeks, you can deliver, you can consider ECMO. But if she's less than 32 weeks, we have to have a multidisciplinary discussion. And at that point, you decide if she needs to be delivered or not. ECMO is not an indication for delivery. Having severe COVID is not an indication for delivery. Thank you.
Jason, thank you very much. That's absolutely great. I am mindful of time, but perhaps if I could just ask you one question, and that's really just regarding the sort of access to services that that you experienced during the various waves of the COVID pandemic. I know in the UK, access to GP and non-acute hospital specialists has been incredibly difficult. And I was just wondering whether or not antenatal care was similarly affected in the US, and whether or not there was anything additionally that you needed to do during the pandemic to mitigate the effects of the pandemic and really sort of promote mother and baby well-being?
Yes. So at the beginning of the pandemic, we had a lot of missed appointments, and we had to actually have some massive campaign to get our patients back via telemedicine. So one of the things that the COVID pandemic did for us was to bring telemedicine for us. So the patients that had mild COVID, we actually triaged via telemedicine. And of course, the patients that just were not comfortable coming back to the hospital at the beginning of the pandemic, we triaged them via telemedicine.
Super, Tyson, thank you very much. Nick's just appeared in my monitor, which I think means that we're probably running out of time. So I think we can forego the last summary slide for this session, wind it up, say thank you very much to all of our speakers, to Tyson and Sam, to Marie and Steve, and to Ken, our session chair. So thank you very much, everybody.
Thank you.
Thank you.
Thank you, everyone.
Thank you so much. And thank you, Chris, particularly as maybe we should call out that you're just recovering from the disease yourself. So you're looking very well in your sort of smart shirt and tie there.
Yeah, I'm hoping not to need transplantation services anytime soon. So
let's hope not, but you know where you can get one.
Yeah, important to network.
Thank you very much. So we're just giving the panelists a little bit of time to come on, and I can see everyone's pictures appearing. So great. So I've been sitting here quietly in the background in the room with all my colleagues at Cleveland Clinic London. This is where we like to spend our Saturdays with you, and it gives me great pleasure to introduce my co-chair for this session, Jenny Ramsey. We met a couple of times whilst preparing for this session, and Jenny works in intensive care, but also in palliative care. Am I right, Jenny? In CCF, I'm not sure if I can hear you.
Okay. Yeah. How about now?
We got you. Great. Okay. So yeah. Look, so this session is, I guess, is not so much hard science, but it's something that became much more apparent and much more into the foreground during this pandemic, which were the human factors. And I think we've all been aware of the human factors around our intensive care unit and the wider hospital. But certainly the pandemic very much put a lot of stress and was a real challenge. And we've had to rethink and focus on how we look at human factors within critical care. So, Jenny, if you maybe want to introduce our first speakers.
Sure. So here to talk to us about family communication strategies during the pandemic are Dr. Adi Gerblick of Cleveland Clinic in Ohio and Dr. Fadi Hamad from Cleveland Clinic Abu Dhabi. Adi, would you like to start us off? You're muted, Adi. Can't hear you.
Can you hear me?
Yes, yes, you got it.
First, thank you very much for the invitation. I really wanted to commend the organizers as well as the chairman for thinking about the human factor in COVID. We are all intensivists, busy with machines, medication, pathophysiological mechanisms, and it's really heartening to see that this session was included in this symposium. It just says for the general outlook and the cooperative approach to the COVID patients. So as you all know, during the pandemic, we experienced significant limitations in communicating with our families and the POAs. And there were no family visitations in the ICU, which resulted both disengagement of the families from their loved ones, and not only that, also disengagement from the treatment team. I want you to think for a minute, if your loved one, father, mother, wife, whoever is your closest person in life is in the intensive care unit and on a ventilator or hooked up to machines, and you're not able to see them, not able to visit them, not able to communicate them in any sort of way. So next slide, please. So to overcome some of these difficulties, we introduced in our hospital what we call the family-centered multidisciplinary care round in the intensive care unit. And that was centered around the concept that we want a team approach to the care, including the POA. So we would do rounds on a daily basis with the intensivist, the bedside nurse, the APP, the pharmacist, the social worker, and the patient POA on the interested families. This has created a unified platform where all the participants were introduced to each other, following which we showed the camera over to the patient, and the nurse came at the bedside, came at the camera, and presented the case in a protocolized way from head to toe with the medical condition. Then we went over the medications, the laboratory data, the radiological data were reviewed, and then we entertained an open forum discussion between the team members and the consultants and the family members or the POA about the care, the decision-making, the change in medication, and the plan of the day. Next slide, please. So luckily, we started that program before COVID hit. So we had, we thought some of it beforehand, and we approached it in different ways. We wanted to see which modality is more useful for family communication than others. So the one modality that we used that I just talked about was the virtual visit, where we had a workstation on wheels with an EMR, a video camera, and a microphone, and all were Wi-Fi connected. We had a communication software that has gone through several iterations. Then the other sort of communication we had was just a traditional phone conversation with the whole team. And the third one was, which we started before the COVID, was the face-to-face communication with the whole team at the bedside. Each one of these sessions followed with an exit questionnaire where they can express their impression on the performance from each one of those visits. Next slide, please. So here I'm trying to summarize a lot of information. On the left side, you can see one of the intensivists with a wow. And you can see the microphone and the camera on the top of the screen next to a patient room. Sometimes it was difficult to show the patient because you cannot wheel in all the equipment into the room, so most of the ones were done outside of the room, but we could take the camera off and show the patient to the family. And in the middle, you can see the screen, the computer screen that the intensivist has. It is very simple, which is the last iteration that we have. It has the once the intensivist logs into the program, the only thing that the intensivist has to do is on the bottom here to put down the phone number of the POA or the family and click. And by that click, everything happens. The recipient doesn't have to download any software, doesn't have to wait anything, doesn't have to answer any specific questions. It just chimes into the conversation. I want to say that this is a major point because if you are in the ICU, you don't have time for all these machinations to take place. You want immediate connection and ability to communicate. You can also, with this software, bring in multiple participants into the conversation. So if you have a renal consultant, or you have a cardiology consultant, and so forth, or other members of the family, you can include them into the conversation the same way that we are doing now with the webcam. On the right side, you see some of the exit questionnaire criteria. They evolved around the confidence that the families have in the care that we are providing. How much did they were able to contribute to the care? We wanted to know also how do they feel about the ability to participate in the decision making, and how much do they understand of what we're talking to them, and also from a mechanical standpoint, how easy it was to participate in the session. And all of these questions, which were derived from verified questionnaires that are available in the literature, were scored from a 1 to 5 scale, 1 being I strongly disagree, and 5 being I strongly agree, and the rest is in the middle. Next slide, please. So you can see here the summary of the data that we have. On the left-hand side, you can see the face-to-face interaction, and the middle is the virtual, and the right is the phone interaction. And the ordinate is the percentage of responses that we got from the cases. So the percent satisfaction, both for the face-to-face and the virtual, was extremely high. And you can see that there are very little negative reports from those two interactions. On the other hand, if we look at the phone interaction that we had, which was done basically in a similar way, but just devoid of visual communication, you can see that the satisfaction scores fall significantly, and also the the dissatisfaction score increases significantly, which was quite a surprise for us, because we felt that phone conversation is like the standard norm of communication nowadays, and or been for a long time, and patients should be very much more familiar with that. And the virtual is like more involved technically to do, but we did not find that to be the case. Next slide, please. So in conclusion, when we communicated with the visual component, either face-to-face or with the video equipment, the scores were favorably over the phone, both in the feeling of the families and the loved ones about the confidence of care, the understanding of the medical care, the ease of even the ease of participation, and the ability to participate in the decision making. So we feel really that the virtual communication platform that we describe was a major contributor to help the families understand what their loved ones are going through, and alleviated a lot of the anxiety that was part and parcel of being separated from the loved ones when they're in the intensive care unit.
Thank you, Dr. Gerblich. It's such an innovative program. I'm so glad you had this up and running before COVID, before the isolation became so intense. I was wondering if you could share with us the time, the difference in time during rounds with the virtual platform versus traditional rounds, just to give us an idea.
Yeah, so you know, when we started the program, we felt it's a little complex to have the families and the team all together. So we used to schedule the sessions. We found it very cumbersome and not really practical for regular ICU kind of care. So if I'm seeing the case in bed 1, I don't know whether I'm going to finish the round on that case. And some case may take 20 minutes, another case may take 45 minutes. I have no way to know how much time I have to divulge in each specific case. It depends on the clinical condition. So what we went into the current program is that we do it on the round. So families are notified ahead of time to be available for communication between 8 o'clock to 12 o'clock and have their iPhone ready or the computer ready. And whenever we are ready, we're just clicking in and they are chiming in. So in that sense, there was no scheduling issues. You didn't have another mechanism to communicate with the families. And most of the time it worked well. I think the fact that you do a multidisciplinary round means that you need to spend more time. You're not just talking to the nurse, you're talking to the APP, you're talking to the pharmacist, you're talking to the consultant. You try to be as inclusive as possible with all the aspects of the care. But based on the results that we are seeing, I mean, if you look at the literature about the satisfaction of the care in the intensive care unit and compare it to the data that we have, this is significantly better.
Well, we thank you so much for sharing with us, Dr. Gerblich. Dr. Hamad, hi.
Hey.
Hi. Can you share with us family communication in Abu Dhabi? How in the heck did you guys survive?
Thank you, Jen, and thank you, Nick, again for the amazing conference so far. And happy to share this integral part. I think part of any care, as Adi mentioned, is really the human communication part that was a major part of our effort on top of the actual medical treatment that we were providing for the patients. For those who don't know me, my name is Fadi Hamid. I'm currently at Cleveland Clinic Abu Dhabi. I'm the medical director of the Medical and Surgical Cardiac Unit and a proud alumni of the Cleveland Clinic Foundation back a few years ago. Next slide, please. So I will just, maybe tackle it in a similar way that Adi did, but maybe put it in a more for challenges, actions, and effects, because we come from a different maybe environment here in the Middle East. And then the simple way I can start with that, just having the pandemic, there has a lot of dramatic changes to our policy in the hospital. One simple policy that I can tell you, before the pandemic, we have an open visitation hour, 24/7. We felt as a intensivist and doctors, the patient and their family have the right to be involved and aware and see their patients anytime they want in 24/7. So starting with that limitation during the pandemic and going to those isolation unit by itself and limitation of that visitation structure was by itself a big change to the hospital and to the whole enterprise. Another issue we have in here is the extended family members, and knowing the family dynamics and the family members present for each patient, it's always kind of a cumbersome to avoid, direct interactions and update, because as we know, it's a tense time for the family, and then all those family members really want an update despite signing a POA or next of kin. There's always been challenges for those extended family member situation. And then, living in a metropolitan city with a lot of expats, that was another challenge that we faced in here. We had patients living 1,000, 10,000, 15,000 kilometers or miles away from their beloved ones. So communication, reaching even family member at some points has been cumbersome in order to be able to provide updates for those family members of the expat who lives in the country and then have been admitted to our ICU. Next slide, please. So again, some of the action definitely would resemble what Adi mentioned, right? So I think the virtual option with tablets has been a tremendous, and just going from a small iPhone to an Android phone, or to not advertising for any company in here, social networking things has been very effective, right? These have been very helpful for the awake, active patients, even in their acute care step-down units or in their ICU, where we could directly do a face-to-face interaction with them. For those who are in mechanically ventilated, that approach was a bit more difficult because exactly what Adi mentioned, going to the room, the limitation of access with the equipment, and even some family members did not want to have the direct interaction with their beloved one being on mechanical ventilation virtually. That would add more stress to them. One very successful strategy we had, I think two strategies were that we maybe did a different approach than what Adi mentioned. We would focus the 8 to 12 a.m. into patient care only. We would go as a multidisciplinary team, go into that unit appropriately, have the full plan of care running on every single patient. Remember, with at one point we had like 60 patients in our ICU with done an ECMO. So we had to be effective, efficient, and at the same time providing the care for them. But then we had a dedicated 2 hours in the afternoon, and that's where we sit as a team. And we break that a list into certain physicians, nurses, APP in the team, in which they help and do direct phone call. And then when I talk about a phone call, you remember, again, I'm trying to make it simple, but it's more complicated. We're talking about time zone differences. We're talking about language barrier. We're talking about the ability to reach those family internationally, and even reach a third party to reach the fourth party to reach that family member. So that 2 hours included maybe a 30 minutes of preparation that I speak Arabic, then I go and take those 15 patients. Other patients speak the other language. So all that has been really added to more time need for those patients. And then the third one, which I felt it was very effective, we were able through our contact center to have a direct access to the bedside nurse through our nice kind of interactive, let's call it paging system in here that we have. You can call directly to the contact center, and from there they can connect you directly to the bedside nurse. At any time, a quick update or a quick change in the patient's status can be directly notified and inform that family member. Or if the family member at 1 in the morning was able to reach somebody in a different country and with the time zone, they could reach us to update through that bedside nurse. Next slide, please. I think one aspect that I maybe want to get Adi's opinion also, and maybe the whole, quorum in here is, the care of the dying patient has been very traumatic, not just for the family, but for the caregiver we had. It has been a very stressful situation in there. Again, inability to go into that unit to see your beloved ones during their death. Cannot access the unit because of all the restriction. Informing a family abroad about the update and the patient's death, and even decision making sometimes where we could not find anybody. We had very struggle situation, right? Put somebody on ECMO or not. Somebody on ECMO had who had a massive bleed to go for craniodium or not, with no family members around to be able to take a decisions, sometimes with forming a quick committee at 3 in the morning to do an appropriate care for the patients, versus also going to the approach of the palliative approach, right? All those challenges with the family communication has been difficult because first, yes, we had the face-to-face approach. Yes, we have the tablet, virtual approach, but then we have the phone call approach, but then we had no family member, present approach that we have to deal with that in a difficult situation. Somebody who's 30 years old in order to progress and proceed with certain decisions. Next slide, please. So in summary, I think, if I want to take one thing out of the whole equation from the pandemic, on top of all the challenges that we had as a medical doctors to provide the medical care, I think family communication was one of the very difficult challenges we faced during the pandemic, mainly in those who's critically ill. And again, despite all the possible methods, dealing with emotions and feeling among the COVID patients and their family was a major stress, and really, affected a lot of the performance of certain caregivers because they were put under a lot of stress for those patients. Thank you.
Thank you so much, Adi. That certainly you were able to describe perfectly how challenging that situation was, and it sounds like your group truly made communication with families a priority. 2 hours a day, and then the work just to divide who says what and who says what to whom, and the bedside nurse. Absolutely amazing. Thank you so much. Nick?
Thanks, Adi. And I think in our discussions, you described that maybe this has brought about some cultural changes in the Gulf around discussions of end of life.
Definitely, I can tell you one approach that we had different is the acceptance of the palliative approach and the involvement in their family about accepting the concept of a terminal end stages. I think the hallmark of the media giving all this, let's say, unfortunately, the negative data about the high mortality and of death, mainly with the high numbers initially around the world, has changed the concept of accepting that modality of death, and then. We heard a lot in the US that a lot of people did the opposite. They actually converted their DNR, DNI to go ahead and proceed with everything, compared to us, where the acceptance of palliative approach and do not resuscitate and what we call allow natural death was an advantage.
Mm-hmm. No, I mean, it's fascinating, and we had some real challenges around some of the end-of-life decisions here. We could talk about this all day, I think, but there's a lot to learn. I think we better move on in the interest of time. Thank you very much, guys, for your contributions. So the next session is about leading a successful clinical team, and it's difficult to know what success looks like in the course of a pandemic, I think. So in this session, unfortunately, Dominic Spray, who is from my hospital, St George's in London, is joining us at Cleveland Clinic London in January. He's had to drop out today, but he gave us a great talk about how they tripled the size of their ICU yesterday, which clearly involved a lot of leadership. So we're missing his talk, but that may enable us to catch up a little bit of time, I think. So I'm going to introduce Dr. Naren Alapan, who is from Cleveland Clinic, Ohio, and who's going to talk about leading the team there.
Sure. Can you hear me?
Yeah.
Yeah. Thank you, Nick and Jenny, for giving me this opportunity to talk about leading a successful clinical team. So I'm one of the directors of Regional Hospital in Fairview in Ohio. Next slide, please. So, as we all know, it's an understatement that the COVID-19 pandemic has been the major disruption of healthcare in the recent times. So in order for the team to cope up with the dramatic sudden changes, we expect our team to be agile and resilient to all the challenges. And during these times, this is where we want our organization and our leaders to infuse confidence, security, and optimism during the face of uncertainties. And I tried hard to come up with 3 top strategies which helped us in leading a successful clinical team here. And these included effective communication, optimizing failure and being inclusive, and being as a leader, being a servant leader. So next slide, please. So during the periods of uncertainties, almost daily challenges on various fronts with COVID pandemic, it is extremely important that the strategic vision and the tactics needed to be communicated to our teams at every level possible. And it was really helpful to have frequent communications within and between the teams. So what we practiced here was a multiple level of structured, frequent platforms of interactions at various levels in our organization. For example, we had a weekly Respiratory Institute town hall meeting headed by the chair of the RI, which was open to the entire staff of the Respiratory Institute, included all the APPs, RTs, infectious disease, and allied departments. These meetings were extremely useful in bringing everybody up to date, and it was a great open forum of questions that the questions can be directed to respective leaders directly. We also had multiple sessions of RI program leadership meetings for leaders of various service lines from main campus and regions we actively participated and frequently came up with changes and strategies of how to tackle this pandemic. Trickling down, the daily operational management of ICU bed capacity was a challenge, and all across the main campus and different regional ICUs, we used to have a daily 15-minute of COVID check-in capacity meetings, which was extremely useful and brought everybody up to speed on resource availability, not only from the ICU bed capacity, but also about the nursing staffing, and also down to even availability of ventilators and etc. Even at the level of regional levels, we had multiple weekly huddles and daily ICU huddles, which helped us trickle down all the informations that we gathered up to every one of the team at the ground level. One of the things that we also utilized was leveraging the informatics to provide visual summaries of ICU capacities of all the ICUs across here in Ohio in the health system. And these were extremely useful. One of the pictures that you see in the bottom of the screen is a snapshot of main campus and all the regional ICUs, with the red squares are the patients with COVID and how many of them are in ventilators. So on a blink of eye, every staff has this information available to them, that where are the resources available and how can we optimize on the resources all across the region. Not only about sharing of the resource availabilities. One of the things that we also did was we did share frequent COVID outcomes, not only as an entire enterprise, but also for individual ICUs. That was extremely useful to give positive feedbacks on how the individual ICUs were doing. So I think one of the most important things in leading a successful clinical team is effective communication all across in multiple platforms. Next slide, please. The second one which I chose was to optimize failure and to be inclusive. As leaders, it is important that we create a psychological safe environment where the ideas and the suggestions of the team members are welcomed. It is important that we let the team perform some controlled experimental models of delivery of patient care and coordination of work. Some of the examples of such interventions has led to novel methods of patient care delivery, like what you're seeing in the picture of medication pumps, ventilators, and even dialysis machines placed outside the patient rooms, which provided a sense of safety among the caregivers during the patient care. On a similar note, it also paved path to being innovative and creating products like the intubation box, where you can see one of my colleagues is intubating using an intubation box for safer intubation. So some of the implementations that we tried worked great. Some of them did not work. But what is more important is that we learned from failing fast and to revise and try to do other innovative strategies again so that we can do things better. One of the other things that really included to promote engagement among the team members was to be inclusive and the creation of team of teams. We developed task force from the level of the enterprise as well as in the regional levels. So, for example, in Fairview Hospital, when the COVID pandemic started, and we figured out that this cannot be tackled as one single person, obviously. So we included each and every staff members and formed teams, starting from a team to champion on PPE, education, and simulations, a team to work on ICU issues, and a team just to work on backup staffing, and a team just to provide us with updating research, which was like on daily basis. So this promoted highly engagement among the staff, and it was really useful. Next slide, please. So not the least, we were fortunate to have leaders who carried the qualities of the servant leadership here. Our leaders had always kept well-being of the team as a top of the priority, and we had creation of wellness officers at different levels, at the level of institute and regional levels, which helped the team to cope up with the stress of this pandemic. We know that our team members are tired, and checking in with them about their personal well-being is the culture here than checking about work-related issues. So we really cared about the well-being of the entire staff here. At last, in the culture that we are all in this together infused confidence in our team and actually transformed to even daily tactics of in the hospital. For example, in Fairview Hospital, we have 4 service lines every day, and we would form a group messaging thread on the staffs who are on service, and basically share the burden of work during the day so that we all can get to go home together. So there are other strategies which really is important, but I think these 3 are the top 3 lists which really helped us in leading successful clinical team over here. That is all I have to share.
Naren, thanks. That's great, and it sounds like you did really well at this, and I think it's really valuable for dig down and dissect and understand what you did that made this work. One question that just occurs to me: we hear a little bit in the US, maybe with the preponderance of unvaccinated people now coming to ICUs. Has it become a little bit more difficult to lead the teams and keep the teams going a bit, would you say, as this kind of persists?
Yeah, Nick, I think the challenge is that this is an ongoing pandemic struggle that everybody is getting to a point of being tired. But I think providing a sense of duty and responsibilities and engaging our staff in different levels will be really useful in this long haul. We are fortunate to have some additional physician support and services. As I said, like our leaders have been like really exceptionally supportive in providing us all supports. This is a challenge as this has been going on for a long time.
Yes. Okay. Well, listen. Thank you very much for your insights. Keep going over there. So I'm going to hand over to you, Jenny.
Okay, sure. Thanks, Naren. So excited to welcome my colleague, Dr. Ajit Mogakar, to talk to us about the human factors in creating a virtual ICU. Ajit?
Yeah. Thank you, Jenny, and thank you, Nick, and all the organizers for this opportunity. Really appreciate it. It's been an amazing conference. You know, this is a pretty broad topic, and I know it's not just one person's work. You know, there's the whole entire village that, you know, helped us to create an ICU which was safe for everyone. So essentially, this talk is going to be talking about how we created an ICU which we thought would be a safe place for you know, for everyone to work. I want to thank Dr. Mireles for providing me with a lot of the pictures that you will see in these slides. So thank you, Eduardo, for that. Next slide, please. Okay, so I want to give you a brief overview of how busy and how crowded our ICU is. You know, we have 64 beds. We have about 73 patients daily, so we board patients outside our ICU. We have some of the sickest patients in our ICU. And there was a day when, you know, one of our, you know, there's a very famous basketball player here, Kevin Love, who wanted to buy food for all of us in the ICU. And he asked us, okay, so how many, you know, how many orders should I place for you guys? And then we went through the process of counting how many people actually work in the ICU in a 24-hour period. And our number came up to 205 healthcare workers that are in the ICU providing care to these 64 patients. And you can see they fall into all these different groups. So it gives you an idea of how busy and how crowded our ICU is. Next slide, please. And you know, this is just to give you some pictures of, you know, how our ICUs, you know, the things that we have done in the ICU over the year of 2020. Next slide, please. And it's a very crowded slide, but next slide, please. So, you know, when the COVID pandemic came, you know, the governor of Ohio put out some guidelines out there. And one of the guidelines that was to limit capacity to meet social distancing guidelines. So, you know, some of the guidelines placed out there was to decrease the capacity at 50% of the fire code, and, you know, try to use and leverage virtual technology. We've talked a lot about that so far. So these were some of the guiding principles. So next slide, please. So some of the general principles that we used for our MICU was to minimize risk to the vulnerable, make sure that our caregivers are safe, you know, mitigate the impact on non-COVID patients, maintain flexibility to redeploy in case of surge, rethink the physical footprint of our ICU, and then integrate technology and virtual platforms to see how it impacts, you know, the human factors in all of this. Next slide, please. So, you know, we start our day with a morning huddle, and you can see this is the pre-COVID morning huddle. There's a room where everybody is cramped in, and if I show this picture to you now in the COVID pandemic, it would be impossible to run a huddle with so many people in there. And this huddle is absolutely vital for us. If you can go to the next slide, please. It's very vital because, you know, it reviews the operation of 7 clinical teams, 70 plus patients, focusing on quality research and outcomes in about roughly 12 to 15 minutes. And, you know, it's a very important check-in for everyone to see what is going on in the ICU. So one of the first things we had to do was to see how we can move this huddle from a physical space to a virtual platform. And we went through, many prototypes of how to do this, but at the end, we used Microsoft Teams as our virtual platform to do this virtually. This is an example of where transitioning from a physical space to a virtual space actually turned out to be very successful. And it actually improved our huddle process significantly. There was very quick buy-in. We have about 40 to 50 people in the huddle who log in virtually, and we go through all of this information, and the advantage of having this virtually now is we can actually capture data and look at trends of what our census looks like, what our vent capacity is, how many lines we have. So there's a lot of things that get captured in this platform. Next slide, please. So the virtual huddle was an example of how things was very successful. I'm going to show you an example of team rounding where we are all huddled by the bedside and trying to see how we can decrease the number of people that are at the bedside, which wasn't that successful, and some of the challenges that I'm gonna highlight. Next slide, please. So some of the things, if you look at the picture in the middle, we created some workstations on wheels where we rewired them for us to be able to conduct rounds virtually. What that meant was there was only one person at the bedside, and the rest of the team, the APPs, the residents, and the fellows joined the staff and the nurse virtually at the bedside. So traditionally, we have about 7 to 8 people in a team, like including the pharmacist and all our respiratory therapists, the nurse at the bedside, about 7 to 8 people. So to go from 7 to 8 to 1 person or 2 people was what we thought was we wanted to do, and we came up with this platform. Next slide, please. And there was mixed results. So what we quickly realized is there's a lot of ambient noise in our ICUs. The communication was a huge problem. When you don't have the team in front of you, it's hard to look at their facial expressions, trying to understand, what are they trying to communicate. There was a lot of information, like especially patient-related information, that wasn't communicated that well. So we tried to improve our technology. We got bigger speakers, better cameras. We went through all of these different things, but really none of it really worked to everybody's satisfaction. So at the end after multiple trials, we actually had to let go of it, and we had to have our teams back at the bedside. Next slide, please. So we went back to the bedside with proper PPEs, and that was a huge relief for everyone. I think people were a lot happier that way. Next slide, please. And so this is the last slide. What we learned was, decreasing human print in the ICU was a big challenge. We were successful in some ways, but in some other ways, it remained a challenge, especially in this complex information that we are trying to convey to others. I think it is virtual platforms are challenging from that point of view. I think that's my last slide. Again, thank you everyone for this opportunity.
Thank you so much, Ajit. It is so true that the very culture of the ICU is so team-based, and to separate the team, how do we function? I also want to say that I personally appreciate you trying with the virtual rounding, because before vaccines, it was, the thinking of safety, it was important. So thank you very much.
Yeah.
I'd like to introduce Dr. Meyer, Joel Meyer, who works at St. Thomas's Hospital right now. He's going to talk to us about more about virtual ICU care during the pandemic. Joel?
Very much. Can you hear me okay? Can anybody confirm?
Yeah, we can hear you.
Yes, yes.
Yeah, brilliant. So thank you so much for the opportunity to speak here, and it's been a real pleasure to hear from and meet future colleagues across the Cleveland Clinic campuses. It's really nice to have these unique short talks from everybody. I'm going to do a slightly different take on virtual ICU care. If you could click the slide, please. So in the UK, there was really no substantial virtual technology in ICUs, and that includes tele-ICU, it just didn't have it. And the real driver in the pandemic response to get up and running with virtual technology was visiting restrictions. And you know, we have all kind of remember instances the first time we had a patient dying in front of us and we weren't able to connect physically the family with that dying person, and it was heartbreaking. So could you click, please? There are some other drivers of virtual tech, aren't there, in the COVID pandemic in terms of infection control and personnel shortages to bring staff to bedside in COVID positive wards. But for us, and I think in the whole UK, it was really visiting restrictions. So if you could click forward, I'm going to tell you that in St Thomas's, on the 13th of March, the visiting restrictions came in, and by then we had 5 intubated patients in ICU. And when the first one reached end of life, intubated, I saw a nurse trying to do a video call on her own phone via WhatsApp with a plasticated cover on her own phone, and realized we needed to do something. So together with Professor Louise Rose, who's a professor of nursing at King's College, we thought we better do something quick. And within a couple of weeks, we were beta testing this platform called a Touchaway, which can host patient lists on the left-hand side there. Each patient can have attributed to it through a secure email link the family members which are attributed to that patient. And then from then, it's just one quick click to create a video call, which then sets up a staff-hosted virtual visit for unconscious, intubated, or awake patients in the ICU. Now, we weren't satisfied just to do this for St Thomas's alone, which was important, but we felt this could be a wider solution. So if you could click ahead, please. What we did amazingly within just 2 short weeks is gather together industry, academic, and charity partners, raise some significant amount of money from Gatsby and the True Colours Trust, which are philanthropic organisations here in the UK, and partnering up with Google and BT. And it was quite astonishing what happened in pandemic conditions in terms of being able to harness people's efforts and innovations and move things forward. It was astonishing. So within 6 weeks, we had delivered over 1,000 case-protected, infection-proof tablets to all those hospitals that you can see on the UK map there, about 150 institutions, into the ICUs ready to use. And video calls started happening. And towards the end of the second wave, we reached our 100,000 video call mark, and we've reached 115,000 now. The top left graph shows you quite clearly the video calling activity through this platform mirrors the 2 waves of the pandemic and then into the third here in the UK. And that world map just shows you the location of some of the family members we've been able to connect with our ICU patients in the UK. If you could click forward. So together with Professor Louise Rose and I, this was a project called Lifelines, and it wasn't really just about a tech solution. We wanted to make sure that it was supported with evaluation and research, because the sort of medium-term aim was to see how virtual visiting, and this is really about connecting family with bedside rather than family clinician updates per se, although that was a secondary use, how we could implement this as routine. So here are our sort of research questions, and we've answered some of them, which I'll just give you some very brief data on, and we've got some more to answer. The real kind of key is number 5, which is how do we implement virtual care, virtual visiting as a routine option going forward. But if you could click forward, I'll start by just showing you the UK experience of using not only this platform, but any virtual visiting platform. So our nationwide survey of 117 out of 217 hospitals responded. We found that 97% of ICUs did institute some sort of virtual visiting, and about half of them used a dedicated family liaison team of some kind. Now, it was about connecting families with the bedside, as I mentioned, but the overwhelming secondary benefits which people reported were ability to use connection for physio and rehab motivation, to address patient psychological distress. 68% reported an improvement in staff morale, which of course has been such a crucial factor in the violation that we've had in what were previously visiting norms. Delirium's been addressed. We've had language and communication solutions, including signing and circumventing difficult language barriers. And the ability to involve family in care has been really partially restored. Of course, whenever you do one of these things, especially in a hurry, there were lots of barriers identified too. So there was difficulty using the tech. There was a lack of staff time to do video calls, certainly, and there were infrastructure issues with Wi-Fi and connectivity, but it was a big deployment, and it was great to have such a response to the survey. We did ask about the indications for virtual visiting, and this was curious that 23% of ICUs actually considered unconscious patients to be a contraindication to virtual visiting, and this reflects, I think, just variable adoption by different sites. In the UK, we can act in patients' best interests, and unless we think to the contrary, then doing a virtual visit is usually in their best interest, supporting the family and wider loved ones. But I bet that's different in different countries, but interesting to discuss. And then 7% of sites considered end-of-life care to be a contraindication to doing a virtual visit via this platform when the patient was unconscious, which is really curious given that it was the primary aim of the solution to address that problem. If you could click forward, I'll just briefly show you that there's also qualitative data being gathered now from 36 staff members using virtual visiting technology from 14 different ICUs. And there are 3 broad themes around restoring the family unit, improving family involvement in care, and enabling sense making for the families about what we're even doing to their patients in terms of organ support, prognosis, and comfort. And then clicking forward, we've also got some qualitative semi-structured interview data from quite a few family members now. I think this is 54 family members that have really answered questions about facilitators and barriers to both the setup of a virtual visit and the conduct of that virtual visit. By that I mean the starting of it, the etiquette, the hosting by the staff, the position of the tablet, very much the nitty-gritty of how you deliver an optimal virtual visit, and the closure of the call as well, which can be very distressing. So with this information in mind, if you could click forward, please. We really are now thinking about how to implement virtual visiting as routine, and we've got the information we need now to hopefully deliver it optimally, to bring the family into the bedside, but also the patient into the home, you know, to meet the family, to meet newborns, to meet pets they haven't seen for a long time. We're very mindful of digital divide, and by that I mean both the access to software, hardware, and connectivity that varies across our boroughs in London and across the nation. But it's the way things are moving, and we really, I think, astonishingly managed to transform ICU visiting through this new strategy, and I'm really interested now to work out how we hybridize it with in-person visiting, which is now going to be returning. But I think these two strategies are complementary, depending on members who can't travel, can't visit, don't want to visit, or are far away. So I think there's just one more slide image to show that we've now connected our patients into the ICU, and I'm happy to receive any questions. Thank you very much.
This is also exciting, Dr. Meyer. I love that you thought to reach out for philanthropy at this time, and it sounds like you had an enormous response. And then what you did with it, studying it along the way, is amazing. Can you tell us a little bit more about the family liaisons? And you mentioned that some of these visits were conducted by family liaisons, which might take some burden off of the bedside caregivers. Just curious.
Yeah, sure. There's some evidence about family liaison teams prior to the pandemic, but in the UK there are ostensibly none. And then we realized we needed manpower to deliver these calls because they are time consuming and require expertise. So in our particular hospital, we had 9 final year medical students whose lives have been transformed by doing this, actually, and are now doctors around the country. But the range of staff members involved was from speech and language therapists to redeployed staff. For example, genetics counselors didn't have much to do at the start of the pandemic. They joined, they had the basic family communication skills to do that. And then in the second wave, we had a much wider range of volunteers, psychologists, redeployed healthcare assistants, all sorts. In fact, we had the chief executive coming in to do a call on Christmas Day because it was just such an important thing. And I think of all the harrowing stuff we've had to go through, this has, in our hospital and beyond, been a really good news story to be able to do some connection. It's not been perfect.
Absolutely. And I imagine the medical students and the speech and language I mean, everyone who held the iPad probably were very moved by what they were seeing and probably affected and touched. Thank you so much, Dr. Meyer.
It's a pleasure. Thank you for having me.
Thanks a lot, Joel. So we'll move on to Susan Wren, who is from Cleveland Clinic, Ohio. And also we have Sean Cross on this session, which is about resilience and burnout. I'm not quite sure if we can get Sean Cross on video, but if not, I think we can get him on sound. Anyway, Susan, I think you're first to go.
Actually, we're going to tag team, so I'm going to turn it over to Sean and just say that it's been a pleasure to listen to the presentations and to appreciate the impact on all of our healthcare providers. We hear that at least 30% of healthcare providers in the US are thinking about getting out of healthcare. 2/3 of people who are currently active have had mental health issues related to their work in the pandemic. And so to take the time to focus a little bit on our well-being of our caregivers and supportive well-being of our caregivers is really important. So Sean, please take it away.
Yeah, hi, thanks very much, everyone. Susan, you can hear me okay?
Yes.
That's fantastic. And thanks to Nick and George as well. I'm really sorry I'm having tech issues to get the webcam sorted, and after dozens, if not hundreds of these events over the last year, today the tech gods have decided that I've got the perfect face for radio. So I would like to be able to do this double act with Susan after being very privileged to have several conversations with her looking at this really important topic. And we've been hearing lots over the last hour, and I'm sure lots more over the last day or two, around the impact that the whole pandemic has had on our workforce. And we're going to prime some of the discussion in the last session just now around the impact of mental health. But I just want to tell you a little bit about some of the programs that have been going on both locally in my NHS Foundation Trust at King's College and also a very large survey that's underway around staff, healthcare staff, mental health across the whole of the UK. I just put this slide up to really reinforce that we've been hearing little bits of some of this so far in the talks, but there really is a need to have a proper coordinated, structured approach to trying to help our workforce go through something like this. The idea, the rather old-fashioned idea of having an EAP and just telling our workforce that they need to be a bit more resilient and then go and see a counsellor if they're struggling, just doesn't hold water anymore. And the evidence is now overwhelming that we need to have a very fulsome and structured approach. And so in a very simple tiered way, what we rolled out at King's College Hospital, I think is a very good example of this. And after running it for during first wave and just into second, it actually won a national award in the UK as well. And that's sort of thinking about all the kind of primary prevention stuff, so all the really basic stuff of offerings to staff, making sure that we reinforce to them that they're valued, that they go away on time, that they're able to have space where they can decompress a little bit, all the sort of basic stuff that we've been hearing about. But then the sort of tier 2 stuff is all about doing lots and lots of targeted support to reinforce what we were hearing about a short while ago around the importance of teams. And of course, our hospitals have been impacted not just by ICUs, where rapid team formation has probably been the norm for the last few years, but the whole hospital has been turned upside down. And the way in which teams when which people have been redeployed has eviscerated decent team formation. And so targeting team leaders, matrons, senior doctors to be able to know that simply creating teams is actually going to be really important for the workforce was something that we rolled out multiple times. And then finally, just identifying those people who are going to have problems or who start having problems, and then being able to kind of get access to people like occupational psychologists. We ran this and we brought hundreds of people through Tier 3 and thousands of people through Tier 2 and Tier 1 interventions. Next slide, please. And we ran it across the first wave, and if anyone is interested, if anyone on the call is interested in how we implemented this and some of the data, then I'm very happy to share it with you. But we have reams and reams of data about the value, again, of coming back to the real importance of feeling that you're rooted in your team and rooted in the community in the hospital. In the interest of time, I'm just going to pass on to Susan for the next bit.
Thanks, Sean. How do we know how people are doing? We happen to have annual surveys of clinician well-being, and our first survey of this particular type went out in July of 2019, and the second in October, November of 2020. So this was after we had been through the spring and summer waves of COVID. And this is a snapshot of our physician well-being. We found actually that burnout dropped from 2019 to 2020, and professional fulfillment increased, which might seem paradoxical since everybody was working so hard and so many things had changed. But what we heard from individuals was that they had revisited the meaning that they went into medicine. Having said that, and let's go to the next slide, please, we may well have different results if we were to survey today. After vaccines came out, after it seemed like we were almost in the clear, there was a great sense of relief. And as Delta has come forward, there is a lot more going on right now. And many of you have probably seen this graph of community phases of a disaster. I would submit that we may have surveyed in that honeymoon period after the first wave, and that we're now kind of back into the disillusionment. This particular model is predicated on a single event, whereas I think we are feeling like we're in a cycle right now. So I suspect that we will go through these events and this cycle multiple times during the course of the pandemic. And it's a great opportunity for us to visit some of the things that Sean covered that have supported our healthcare workers thus far, and to refine them into what will work in the future. Next slide, please. I'm back to you, Sean, I believe.
And I think just to reinforce that now, I just want to talk a little bit about a national survey that is underway in the UK called NHS Check. You can go to the website nhscheck.org. There's a very large consortium led by one of my colleagues, Simon Wesley and Neil Greenberg, who's written a lot around this concept of moral injury, which I'm just going to talk about very briefly. We will be getting reams of data coming out, but an initial publication from a few months ago, but from 4,500 staff, showing significantly increased levels of anxiety, depression, PTSD, and some alcohol and substance misuse as well. So I think this is a real warning sign, clarion call for all healthcare organizations to ensure that we don't end up having the view that this is over, as Susan was just saying. One of the most pernicious components of a lot of this is this concept of moral injury. I hope most of you will have heard of it. It comes out in lots of different ways, but the idea that there is distress felt by a healthcare professional due to a violation of one's moral code, and this isn't just about, I would like to be able to offer this, care to a certain patient, but I don't have PPE, although that was part of it, although I don't have, enough beds or enough equipment, but that was part of it. It also comes out in the stuff that Joel was talking about in the previous section, and just not being able to do the thing that you would normally do if you were a nurse wanting to look after your patient. And the reason this is important is that if someone is experiencing moral injury, we know that there is a significant increase in the likelihood of developing these things we call common mental disorders, an increase in anxiety and depression. And we think that, you know, almost 2/3, you know, around 60% of people surveyed initially had evidence of common mental disorders. So this is not a small proportion of our workforce at all, and definitely increased rates as well if you're young, skewed towards female and skewed towards nursing staff as well. Consultants and senior doctors are often escape some of this, not all of it, but some of it. Those people who feel as though they have less agency over the care that they offer, often caught up in this. And so it's definitely something that will be part of the literature for some considerable time. Back to you, Susan.
Thanks, Sean. In the next slide, I've captured an image from an article that was in The Atlantic in August last month. And that's something that we'll discuss. I'm not sure whether this is unique to the United States, but we are certainly beginning in the Delta era to begin to see health caregivers feeling some antagonism rather than a therapeutic partnership with patients and their family. And there have been healthcare workers who don't want to take care of patients who aren't vaccinated. There have been increasing altercations with patients and family members who are insisting on particular modes of therapy. Ivermectin is a big topic for us right now. And so the additional stress, just the emotional concerns that that individual nurses, doctors, and other caregivers have are accentuated through this process and the energy that is expended to deal with it. And Sean, I'm curious, what are you seeing in your area?
There's definitely, I think, as we were talking about earlier in the week, there's definitely less of a politicization around unvaccinated versus vaccinated patients. There's still, there's a component here, but I don't think it has been quite weaponized in the way that it has in other parts of the world, particularly over in the States. And of course, that introduces a whole different dynamic in terms of clinician doctor relationship. I think to a large extent, there's also, it is coming out in some ways around the way in which huge proportions of the rest of the country have normalized everything. So for example, arguments going on around mask wearing on public transport, for example, when, you know 3 months ago, 80% of people were wearing masks. Now it's less than 20%. And so there, I think the chronicity to this thing is going to continue, and it's going to be quite draining, I think, for lots of people to deal with. And of course, healthcare professionals will end up dealing with much of this, because throughout this has been a crisis of the acute care pathway.
Absolutely, and I think that the line from the Atlantic article may capture part of that, and you know, we don't want to lose hope. Hope is something that can certainly help us through through a variety of things, and so the question is, how can we build that better? Next slide, please. You know, one thing that occurred to Sean and me as we were talking about the session is that really we don't want to focus on the individual as not being resilient enough, or not being well enough, or not being able to handle it. It is, how can we help the individual in the face of local and national and international events that we can't control? So we'd like to conclude by talking about some of the things that we can continue to do and look forward to doing to support our healthcare workers. Next slide, please.
Yeah, and so it's just finishing up with some thoughts and some ideas that people have. It's not just around creating space within hospitals and these things that have sprung up across the UK, and I'm sure in the States as well, around well-being hubs. For example, our boardroom at King's has been a well-being hub for the last year and a half, and looks as though it's never going to go back to being a boardroom. But there's also something about going back to that tier 1, tier 2, tier 3 evidence-based model that presented at the beginning. There is something about trying to ensure that we now link the array of evidence that there is out there around what you should be able to do to create a well-supported, thriving workforce, and ensure that we try and bring that into our hospital environments, because there are many organizations that do this better than hospitals, I think. And the challenge for all of us is not just to see well-being as that rather sort of fluffy thing, a sort of nice to have on the outside, on the edge of your core business, but to actually try and understand the way in which a lot of the evidence for organizational restructure, things like everything from hours to team building to the amount of CPD and managerial support and health and access to decent food and making sure sleep is kind of discussed. All of these things, integrating them into what an institution thinks it should offer its workforce is going to be key, because large numbers of our workforce are going to come through this damaged already, more of them to be, and it's not just about asking them individually to be more resilient and be better. Institutions have a huge responsibility here.
Sean, I feel like I need to wrap this session up. I'm afraid. Do you two guys want to make just a final point, because we're running a little late? I'm sorry.
Susan, over to you. I think that's fine.
Thank you. I think that paying attention to the whole person, as well as also paying great attention to helping our healthcare workers disconnect and making sure that they are able to get away and restore themselves is going to be key to getting through this. Thank you so much for the opportunity to chat.
Thank you so much. I'm really sorry we have to just hurry on a little. I think we've tried to get so many people to be involved in this today. So we'll probably should leave the session there. A lot of things to think about, some really profound issues that we need to deal with now and going forward. And I'm just going to hand over briefly to my colleague, Georg.
It was really fascinating listening to this, and thank you so much all for spending your Saturday with us today. I have to unfortunately leave Nick and Luigi later on for the concluding remarks, and I have to rush and get to the airport, and there are train cancellations, so I do apologize that I'm leaving slightly early. I will try and listen into the last session on my phone. Again, thanks so much. I think it was brilliant bringing us all together, getting to know each other, and I hope there is really a bright future ahead in our collaboration, and I hope that all the delegates who have dialed in had really a brilliant time. So I leave it there and hand over to Nick again. Thank you.
We'll say a few more words about Georg just at the end of the conference, but Georg is very much the architect of all this and has done all the work to organize it. I can't claim really much credit about that at all. So bon voyage, Georg, and good luck at the airport. And the final session, thank you very much for staying as we move on into Saturday. Our final session is a variety of topics, but it's really about the aftermath of COVID. And the two chairs for this session, thank you very much, are Michelle Beale from Cleveland Clinic Foundation in Ohio, and Joel Mayer, who you would have met in the previous session, my colleague from St. Thomas's, who will join us in January.
Thank you, Nick. And I'm going to just start off, even though Michelle is the official chair, she's speaking in the first section, so I'm going to start off. And I know that we are a little behind, but it's certainly the last session, but certainly not the least. We are covering quite a lot of important information here. And also we have gender equity on the panel, which is fantastic. And we will start off also by just noting that it's my co-chair Michelle's birthday, so happy birthday. And the first session is from Michelle. She's going to talk to us with her great interest in critical illness outcomes and ICU survivorship about this condition that we've come to term long COVID. Over to you, Michelle.
Can you hear me well? Okay,
yes, we can.
Great. Okay, great. So the first session, so thank you everyone thank you, Joe, for the introduction, and good morning and good evening, everyone. It is a pleasure to be here. Thank you for the organizers to invite me for this outstanding conference. It's my pleasure, for Kristen and I, Dr. England and I, to be here talking about post-COVID. I'm gonna lead, to Dr. England, who I'm gonna introduce, and then she will start our talk. Dr. England completed her training in infectious diseases at Northwestern University in Chicago. She has been on staff at Cleveland Clinic in the infectious disease department for the past 19 years and is currently a vice chairwoman for the department. Over the past 8 months, she has developed a multidisciplinary recovery center at the Cleveland Clinic for the evaluation and treatment of patients with post-acute sequelae of SARS-CoV-2 infection, or PASC, otherwise referred to as long COVID. Dr. Kristen England is my pleasure to introduce you. She has been my colleague in this work with long COVID, and it's all yours.
Thank you, everybody, and thank you for hanging in here this afternoon. So long COVID, PASC, it's got so many different names. This disease entity, I think, was unanticipated and underappreciated for a long time. So let's go to the next slide. So Dr. Carfy initially talked about this back in August of 2020 and started to compare some of the symptoms that patients are seeing post-COVID. Post-COVID is generally deemed as 28 days post the initial diagnosis of COVID. And as you can see, the comparator between the acute symptoms and the post-COVID symptoms are somewhat similar, but as I listed on the left, other things that we're starting to see that Dr. Carfy's group did not see initially are especially the difficulty with thinking and concentration, sometimes referred to as brain fog. And we're also hearing more about patients with heart palpitations and then leading to POTS syndrome. So as we continue to learn more about this and see more patients with it, we're learning more about the severe impact that this is going to have in the long term. Next slide. So we are definitely seeing it all across the world. And what is the impact of this? The MMWR coming from our CDC most recently noted that 1/3 of participants reported that they were having symptoms 2 months afterwards. And coming from the BBC, a study looking at 37% of people who had had COVID experienced at least one symptom, and 15% had 3 or more symptoms after 12 weeks. Next slide. When we look at the numbers just as of Friday or last Monday, if I just assume 10% of patients, not even the 30% that we're starting to see, worldwide, we're talking about nearly 23 million people experiencing long COVID symptoms. And here in the US, over 4 million. And I think this number highly underestimates what you guys are seeing in the UK, 750,000. So this has a tremendous impact. Next slide. Across England, the National Health Service has recognized this and opened nearly 40 long COVID clinics. In the next slide, please. And here in the Cleveland area, next slide, we have opened up the Recover Clinic with the help of Michelle and all of my friends. Next slide, please. And we opened up the center back in February 10th, and since then we have seen we've seen over 1,000 patients thus far. Keep going with the next slide. We initially started with our post-COVID patients that were clearly diagnosed by PCR because we did not want to get our data confused with patients who might be having symptoms of chronic fatigue from other reasons. So we really limited down to those with clearly defined long COVID based upon their PCR. We also limited it to Cleveland Clinic adult patients, but thankfully we were able to offer to patients one single entry point. Next slide. And from that single entry point, again, we've been able to see over 1,000 patients. Next slide, please. We were able to then see patients in a centralized location and do an extensive evaluation on these patients. And then depending upon what we found on, say, echoes and PFTs and a full physical therapy and occupational therapy evaluation, along with some blood work that we all deemed was necessary, we're then able to identify champions in each of these different specialties, so at least 18 specialties, where we can then refer our patients to. So there's been a lot of buy-in from all across the enterprise that they really are embracing this as a long-term need for our patients. Next slide, please. So each of these specialties has also worked very hard on developing their own testing strategies and treatment strategies. And I know Michelle is going to speak to this specifically from the pulmonary standpoint. Next slide. So our first 924 patients we looked at are about 73% female, predominantly Caucasian here. The mean age is about 50. With our youngest being 18 and our oldest being 87, but that 18 is by my cutoff. We have certainly had people reaching out to us from the pediatric population with post-COVID patients, 12, 15. So this is not something that our teenagers and children are immune from. We're finding that patients have a larger BMI, and a study coming out of our endocrinology group has also indicated that having a higher BMI puts you at risk for developing long COVID. Not all patients were hospitalized. As a matter of fact, a minority of patients were hospitalized. So those folks who are not even ill enough to go into the hospital are still experiencing symptoms for many, many months to come. Predominantly, we're seeing fatigue, but also shortness of breath or dyspnea on exertion, that brain fog that I mentioned, many different variety of symptoms. They're not all depressed, they're not all anxious, but we're also not seeing the PTSD that we anticipated. The symptoms that the patients are representing to us are also seen in the scales that we're developing. So it's not just subjective, it's objective as well. And when we use tools like the PROMIS fatigue, we find that our patients are in the 10th percentile of energy for those in the United States. So they truly are fatigued, and they truly are finding cognitive dysfunction. Next slide. So my last slide, just want to let you know that everyone's journey with this is unique. There's no clear single definition of long COVID, nor is there a single cure. We have found through the Recover Clinic that it truly takes a team to support these patients, utilizing all of our support specialists, but also physical therapy, the pulmonary rehab, all of our rehab, including integrative medicine, functional medicine, and then certainly counseling. That's my last slide. Over to you, Michelle, and thank you.
Thank you, Kristen. Can you hear me well? Okay, great. So thank you for your presentation, Dr. England. That was fantastic. We have been collaborating together. So I'm Michelle Beal. I am pulmonary and critical care physician at Cleveland Clinic in Cleveland, Ohio. I am also the director of the Post-ICU Recovery Clinic that was started in December 2019. And again, it's my pleasure to be here today talking about what strategies have we been using to evaluate and treat COVID-19 survivors. Thank you everyone for joining. Next slide, please. So for those who survived COVID-19, many reports have emerged and have identified persistent symptoms beyond the acute phase of illness. So we know so far that they are common. They happen irrespective of the severity of the symptoms in the acute phase. And that is a wide range of symptoms that patients can have. The underlying biological mechanisms that have been proposed, different underlying mechanisms, but the pathophysiology so far is unknown. Next slide, please. This is a table summarizing symptomatology of these patients, and we here summarizing physical impairments, mental health, pulmonary, cardiac, and neurologic. Dr. England has gone through those, and I'm going to skip this. Next slide, please. And again here, symptomatology. I think this figure exemplifies the multi-organ system involvement that occurs in patients with long COVID. There are several systems involved: CNS, psychological, psychiatric, cardiovascular, pulmonary, heme, renal, and GI, and others not mentioned here, such as rheumatological, dermatological, and ENT, as well as intensive syndrome that affects patients, COVID patients who have been in the ICU, so COVID ICU survivors, and this topic is going to be detailed in the next presentation by Dr. White and Dr. Slack. These manifestations that these patients are having, they are significant, they have been significantly impairing patients' quality of life. We are seeing them in our clinics, and they come either with a couple of those systems involved, with many of those. They have been causing for several patients impairment and disability to the point of not returning to work after 6 or 9 months after they had COVID, and not necessarily just the ones hospitalized, but some people who have not been hospitalized. Next slide, please. This is one example of one of the studies that had come out with exemplified pulmonary impairments on these patients. So several retrospective studies, but this is one of the prospective ones. This was done in Wuhan, China, and they evaluated 80 patients who were hospitalized with COVID and followed them up with the 3, 6, 9, and 12 months following their pulmonary function test, functional status, and chest imaging. So this nicely shows the trajectory of this. Next slide, please. So in the far left, you can see they found a significant reduction in the LCO, which was the most impaired pulmonary function test result. There was a temporal improvement in the DLCO and FVC. There is also in the center figure, you can see a temporal improvement in exercise capacity observed in most patients. However, persistent physiological and radiological abnormalities remain in some patients even after 12 months. There was a multivariate regression done and showed increased odds of impaired DLCO associated with female sex. And also radiological abnormalities were associated with a peak high-res CT pneumonia scores during hospitalization. In the far right figure, it's observed that patients with reduced DLCO, FVC, and TLC were more often seen with those who had abnormal CT than those with normal. Next slide, please. This other study briefly shows that not only patients have been affected, but also family members have been affected, profoundly affected by COVID. As you can see, they follow patients and families 3 and 6 months. Social functioning and psychological function have been affecting families as well. Next slide, please. So recognition of this syndrome is key when you're thinking about evaluation and management. This is the first step to recognize that patients are having long COVID symptoms. Empathic listening is fundamental, as well as acknowledging the patient's symptoms. Comprehensive and multidisciplinary approach is vital, as well as a routine follow-up, establishing a rapport and involving patients' support systems. Aiming a holistic approach to these patients, several large institutions started to get put together post-COVID clinics, aiming at getting these patients in and evaluating them. So dedicated post-COVID clinics usually utilize a multidisciplinary approach for evaluating and managing these patients. The development of these clinics have also provided a huge opportunity to perform research in order to be able to understand the trajectory of COVID survivors and inform clinicians how to monitor their health and provide early intervention that may provide benefit. And unfortunately, at present, there are no specific treatments or rehab guidance for these patients. Next slide, please. At Cleveland Clinic, we have 3 different specialty clinics that have provided care, dedicated care for COVID survivors. They have different care models, but they all collaborate between them. And I'll go over in detail in the next slide. Next, please. So the post-ICU recovery clinic, or PERC, it is directed by me, and we have 3 other staff, Dr. Weiss, Dr. Sarin, and Dr. Bishop. We founded the clinic just before actually COVID hit in December 2019, and Dr. Weiss will go over a little bit more detail about this clinic and what we have been seeing. The recovery clinic is directed by Dr. England, and she talked about it in our prior presentation, and I'll focus here in the post-COVID pulmonary clinic, who was officially established in January 21 2021 is operated by Dr. Taliersi, one of my colleagues, and we have providers at main campus, east, west, and south. So we have about 15 providers or clinicians, pulmonary critical care physicians seeing these patients throughout our institution in Cleveland, and patients can choose where they go. Next, please. So this is how we get these patients to us. They either they are self-referred, or they come with internal or external referrals. They come to us and we do pulmonary function tests, 6-minute walk, and chest X-ray. This is the minimum. We see them, and after that we evaluate them, and we often order several other tests such as echo, CT chest, VQ scan, and cardiopulmonary function, cardiopulmonary exercise test as indicated. After that, we refer these patients often to other pulmonary subspecialties such as the PH clinic, the CTAP clinic, lung transplant clinic, and other specialties that have been involved with COVID patients. Next slide, please. So this is one of the, this is a diagram that shows like the workflow that we have been doing for these patients who come to our post-COVID pulmonary clinic with tests. And then we have tried between our group to standardize what we are doing for these patients. And this is here for your reference. I'm not going to go over in detail. Next slide, please. Next slide, please. We have created management care paths as well. When you see these patients and the ones who have abnormal CAT scan and or pulmonary function test, we are most of the time finding them that they are falling in one of these three categories. Either they have a CT chest with a pattern consistent with organized pneumonia, or they have a pattern findings consistent with pulmonary fibrosis, or they have a CT that has some improvement in their findings, either ground glass or others, or near resolution. Usually they have improvement of symptoms, and they may have normal PFTs or low normal. And this is what we have been doing for each one of those three categories. Organized pneumonia have been doing steroids, 0.5 milligrams per kilogram over a period of time, and then taper, and you follow these patients closely. Pulmonary fibrosis, we are following them closely, and then if they are getting their pulmonary function test and CT worse, we are considering antifibrotics, although not standard of care at all yet. And if they have been improving, we also follow them closely. Next slide, please. For patients who have normal pulmonary function tests and normal chest X-ray or significantly improved CTs, and they still have symptoms like dyspnea or cough, we also developed guidelines, or for us within our group, what you're going to do with this patient. So, for example, cough, we have been treating and giving a trial of LABA-ICS or just ICS, following them closely in 1 or 2 months, and see if they have improvement. We continue. If they don't have improvement, we stop that and we try other medications. And if they have dyspnea, we have been doing sometimes further investigation with VQ scan, echo, and with a cardiac evaluation. Next slide, please. This is just a continuation of the prior slide, showing what we have been doing for these different pathways. So far we have seen more than 200 patients since January in different locations and different clinicians. We have had bi-monthly meetings and with case presentations and care paths, and we are now in the point of creating a database so we can see what we have been seeing and what's benefiting, what's not. And I think the ability to be able to talk as a group, present cases, and discuss management is giving us providers more comfort with conditions that formerly did not have any clinical pathways. Next slide, please. And this is just like the pulmonary care path. There is several other care paths from different specialties that have been heavily involved in the care of COVID patients. And there is definitely a huge collaboration between all of us, which has been fundamental for the care of these patients. Next slide, please. I wanted to summarize my presentation in saying what I have learned from seeing these post-COVID patients. So empathic listening is key to recognize patients' impairments. We need always to place patients at the center and ask what matters to them in their path to recovery, and base our interventions and evaluation and research on that. Research is imperative if you want to move forward. Support is needed, not only to patients and families, but to healthcare providers. Many of us are exhausted and burned out. We need to take care of each other and look for help. Dr. Ramsey and Dr. Bora will discuss this more in the next session. Teamwork and collaboration are vital. This definitely takes a village. Our hope, not only patients, but all of us, is that ultimately we'll see the light at the end of the tunnel. Thank you very much.
Thank you very much, Michelle and Kristen. It's been a huge privilege to have you both presenting here, and actually the combined experience you've already got in these overlapping conditions is phenomenal. It really is a multifaceted, let's call it a syndrome, a condition, and I can't leave Michelle to take over without asking one question, which is, clearly there's a relationship between vaccination and long COVID, and certainly in the UK, I don't think there's been enough said and enough public understanding and enough public consciousness done about long COVID. We talked about death and hospitalization. You only have about 20 seconds each, I'm afraid, but do you have any tips about how to publicly communicate long COVID succinctly? And it's a challenge, I think, but I'll be fascinated to hear what you make of it. Kristen, maybe, if you don't mind, or Michelle?
No, I agree. I think people tend to hear about patients being fatigued and short of breath, and they tend to, even within the medical field, tend to not take it as a real syndrome. So the more data that gets out there about the actual true complications that are out there, and the what these patients are going through, I think the more we get this information out, it will help people to understand that, even though I might survive, easily getting COVID without a vaccine, that might linger on for several months afterwards. So there really is some impairment, and hopefully this will inspire patients to want to get vaccinated.
I agree with Kristen, and I think when I talk with patients who have not been vaccinated yet, I try to hear them and not confront them, because I think if you confront, that's not how they're going to listen to us, and then try to expose the data. A lot of times they just don't know. We think that they know, and they don't want, but what they know is so many fake news, as we all know, that they don't know what's the data out there. So I think this is crucial. And in terms of long COVID, I think there is a lot of education that we need to do, not only to the community, but our colleagues as well. I have some of my colleagues coming, is this really true that they are having this brain fog? I say, yes, this is true. It's happening, because I have friends and colleagues who have had COVID and had felt that they had difficult decision making, word finding. So yes, it is true, and we have already a lot of data coming out as well with pulmonary impairment and so forth. And thank you.
Thank you so much. And Michelle, I'm going to let you now introduce the next session. Yes. Many thanks.
Yeah, so it's my pleasure to introduce my colleague, Dr. Joshua Vai. He's a staff physician in the Department of Pulmonary and Critical Care at the Cleveland Clinic in Cleveland, Ohio. He joined us in January 2020 after completing his Pulmonary and Critical Care Fellowship at the University of Pennsylvania and residency at the University of California, San Francisco Medical Center. His areas of interest include implementation science and ICU survivorship. He's an active staff member of the Post-ICU Recovery Clinic and has a vested interest in improving care pathways for ICU survivors. So my pleasure to also introduce Dr. Andrew Slack. They're both gonna speak in this next session. Andrew Slack is an intensivist at Guy's and St. Thomas NHS Foundation Trust, London, and Cleveland Clinic, London. He has an interest in post-ICU recovery for the last 7 years, co-leading a multidisciplinary outpatient post-ICU clinic. Thank you very much for both of you.
Thanks, Michelle, and I'd like to thank the organizers of the conference for the privilege to speak today. I'll get the opportunity to introduce the concept of post-intensive care syndrome and some of the aspects that are important to uncover during a visit in a post-ICU recovery clinic. Next slide, please. Brief outline for our reference. Dr. Slack will help cover the interspersed. We're going to go back and forth a few times, and I think that exemplifies the amount of collaboration needed in the post-ICU space to come up with an adequate care plan to overcome post-intensive care syndrome. Next slide, please. A patient's journey with critical illness begins before they arrive in the intensive care unit. And thankfully, advances in critical care medicine have resulted in a growing population of ICU survivors, and their journey with critical illness extends well into the post-ICU space. This burden of critical illness as depicted in this slide often lasts well beyond a patient's stay in the intensive care unit. Patients frequently develop new functional impairments that reduce their quality of life. The burden of critical illness manifests itself in the post-ICU space as post-intensive care syndrome, as well as many other aspects Dr. Slack will talk about in the coming slides. Next slide, please. Post-intensive care syndrome is defined as a constellation of functional impairment after an episode of critical illness with new or worsening function in one or more of the following domains: cognitive health, mental health, physical health. Before discussing post-intensive care syndrome in more detail, it's pivotal to note that addressing post-intensive care syndrome starts in the intensive care unit. So the slides advanced a little early there, and this slide serves as a reminder that one of the best ways to mitigate the development or severity of post-intensive care syndrome is utilization of the ABCDEF bundle. It's been shown to improve survival, reduce duration of mechanical ventilation, ICU length of stay, increase days free of delirium or coma, and increase the likelihood that an ICU survivor returns home functionally independent. Next slide, please. Here we have a conceptual model of post-intensive care syndrome, which notably can extend beyond ICU survivors and affect the mental health of family members of critically ill patients. Overall, at 1 year after critical illness, over half of patients experience new enduring impairment in either mental health, cognitive impairment, or physical impairment. And greater than 20% experience impairment in 2 or more domains. So within the mental health domain, at the 1 year mark, PTSD remains common up to 7% of patients. That's much higher in ARDS survivors. They develop PTSD at rates of nearly 40%. Anxiety and depression, as you can see, are still common at the 1 year mark after an episode of critical illness. Cognitive impairment is profound, with about a quarter of survivors having cognitive impairment similar to mild Alzheimer's dementia at 1 year after an episode of critical illness. And physical impairment through ICU-acquired weakness, that's created through muscle wasting, most notable in sepsis and ARDS, can lead to impairments in ADLs and IADLs that decrease physical function, and in the end, reduce an ICU survivor's quality of life. It's notable that family members are also impacted by their loved ones staying in the ICU. They often have anxiety, depression, complicated grief, have new financial strain, and also can develop post-traumatic stress disorder from the time their loved one spent in the ICU. So you might be asking yourself, which of my patients are most at risk for post-intensive care syndrome? We'll discuss that on the next slide, please. The Society of Critical Care Medicine Conference on Prediction and Identification of Long-Term Impairments After Critical Illness exemplifies
Do I step in?
Yes, if he's not coming back quickly.
So I think Josh was about to tell us about the sort of high risk elements to developing PICS. Oh, you're back, Josh. We lost you for a second.
Including duration of delirium, sedation, especially benzodiazepines, sepsis, shock, hypoxia, ARDS, the need for invasive mechanical ventilation. Next slide, please. Here's a nice conceptual diagram. Next slide, please. Here we have a conceptual diagram of many of the factors that contribute to post-intensive care syndrome. We're on the slide before. And in the slide before, for reference, there'll be a conceptual diagram of factors that contribute to post-intensive care syndrome and post-intensive care syndrome family that drive a reduced quality of life in this patient population. Turning the focus back to COVID-19 ICU survivors, most would consider this patient population at high risk for many of the risk factors we previously discussed. Next slide, please. The burden of critical illness in COVID-19 ICU survivors is likely shifted to the right. These patients often experience a prolonged ICU stay with prolonged length of mechanical ventilation. They have high sedation requirements, especially early on in their ICU course. They experience a high incidence of delirium, which we know is a risk factor for developing neurocognitive impairment after critical illness. And they often need support with neuromuscular blockade and glucocorticoids that can contribute in some fashion to ICU-acquired weakness. Next slide, please. You might be asking, what's the difference between post-intensive care syndrome and post-sepsis syndrome and long COVID? Truth be told, there's a significant amount of overlap, and it's often difficult to tell aspects of these syndromes apart. I think what's important is that we become familiar with the long-term impairments of COVID survivors, COVID-19 ICU survivors, and all ICU survivors, because if anything, the pandemic has shown us and exemplified that the burden of critical illness extends well into the post-ICU space. And we have more cases of acute respiratory distress syndrome now than at any time in recent past, and it's important that we come up with care pathways to improve the challenges, help survivors overcome the challenges that they face. So I'll turn the stage over to Dr. Slack, and I was going to speak to some other challenges ICU survivors face in addition to post-intensive care syndrome.
Yes, the next slide, please. So this isn't all about psychological, cognitive, and physical issues. These are really important, but they can all lend themselves to increasing the risk of readmission in the first 6 months. And by targeting the physical, cognitive, and psychological issues that these patients have to deal with can be really important in impacting and reducing readmission risks. Next slide, please. And also return to work. And you can see here that a high proportion of patients, up to 63 to 68%, are still not back at work at between 1 to 3 years. And if they have returned to work, they might have returned to work in a different capacity or a lower paid job than that which they held previously. Next slide, please. So why do we follow these patients up? Next slide. So there's plenty of guidance in the UK, and I'm not familiar with the US or other healthcare models, but we've had standards for quite some time, and yet it's been difficult to establish and meet these guidelines. Although a recent study that we've done, surveying all the units, shows that there has been a greater uptake, but there isn't a sustainable funding model for a lot of these programs. Next slide, please. So yes, we've got some recommendations about who we should be following up, and you can see that patients who've been in the ICU for more than 4 days seem to be at increased risk of morbidity, and the problems tend to emerge once they've been home after discharge. That's when they really do come out, although there is an opportunity within the ICU and on the ward to pick up some of these problems, but they really only truly develop once they're home. Next slide, please. Whoever's doing the slide changing, if they could be a little bit more prompt, that'd be fabulous. So this is a little schematic about some of the various problems that a lot of patients have to deal with, and they're very similar to the ones that we've seen on the post-COVID and long COVID slides, and basically follow along the physical and cognitive and psychological issues. Next slide, please. This is just to give a sense that actually we need to understand who these patients are. They'll often come and present with different trajectories. So some will have a lot of comorbidities going into the ICU. With COVID, we've seen a lot of healthy young people or people in their middle age come in and be really hit hard with a new problem. And so they've left there. Some of them left eventually getting preserved function back to how they were prior to COVID, and or their ICU stay for another particular issue, or they've noticed that they've actually got a significant functional decline, and obviously some have died or have been left with severe disability. Next slide, please. So the whole process of trying to support our patients is really important, and there are various sort of timeframes in their journey out of the ICU which are really heightened anxiety and really start to identify the problems that they're going to face. So the discharge from ICU to the ward or the floor is just a massive emotional burden, not only for the patient but also for the family, and really starts to highlight to the patient what are the burdens that they're about to face because they've been supported so well in the ICU. Next slide, please. And then getting home is like being dropped in the ocean. You're all on your own. You've got limited support. You may not be digitally well connected or necessarily intellectually robust enough to utilize the healthcare that serves your local population. And with the current situation of the community services being overburdened and general practitioners, you really are sometimes left alone to try to navigate what is a really difficult period of your life, while worrying about the stress of when can you get back to work, how you might do that, and all at the same time there may well be things that crop up that end up with you being readmitted to hospital. So this is where the post-ICU clinic can be really helpful. Next slide, please. Next slide. So this just gives you a sense of the sort of things that could be done during the patient journey. And so we've got information giving, ICU diaries in the inpatient phase, and goal setting and group rehab interventions as they move to the sort of outpatient and home phase with peer support groups for family and others. But the clinic intervention really can be very helpful. Next slide, please. Next slide. So who are you going to need to do this? And we've talked about the multidisciplinary team which is required to deliver the clinic model, and I've listed a whole host of people there, and if you're lucky enough you will get all of them, and how you manage that team in a consultation is the next challenge, because you can overburden a patient who cognitively is struggling and fatigue is an issue. So if you take a long history and then you ask the neuropsychiatrist to do a cognitive test, after an hour, that's perhaps not the best time to do it. So you may well have to be thoughtful about how you deliver your service. Next slide, please. I've certainly found, I think, the clinical psychologist and the occupational therapist are two key therapists to really understand the cognitive and functional needs of a patient returning home, just with the activities of daily living and the return to work and return to driving. And then the clinical psychologist is really there as a keystone to providing support for the carers and for the patient once they've left. Next slide, please. So we did a survey showing about inpatient follow-up, and you can see from here that the majority of follow-up in the inpatient environment is led by the nurse or the physiotherapist, with a smaller proportion of those others they're labelled. But ultimately, I think this slide tells us that there is more that we could be doing in the inpatient environment. Next slide, please. This is again a sense of who's delivering these outpatient clinics in the UK. Nurses again and intensivists are up there with physiotherapy support, but then you just see this massive drop off on key allied health professionals that really should be involved in these clinics. So the psychologist, the occupational therapist, and the dietitian, pharmacist, and speech and language therapist, and psychiatry and social worker. I mean, social worker, how we don't have that robustly implemented is staggering, but it's a reality, sadly. Next slide, please. I think that just depicts what I've just been saying, just how valuable these individuals are, but there's just insufficient resource to utilize them. Next slide. Next slide. So obviously we proposed that the clinic model was a great idea, and why wouldn't you do this for everybody? And then obviously that was before COVID, and we struggled really hard to win the argument, but we did in our institution. But I think COVID's really just unleashed it, and now I hope that the COVID model is going to enable others to actually start focusing on the non-COVID population that in the past, the present and the future really do need the same service that this COVID group are receiving at the moment. Next slide, please. Josh, I think you wanted to talk about the enablers and barriers to these sorts of clinics. Obviously frozen. I'll continue in the interest of time. So obviously you need interprofessional teamwork, some defined operational processes, motivated clinicians, which I think we all are, and you have creative problem solving, because the number of barriers that are put up in our way are quite phenomenal. And you can see that lack of funding, lack of space, identifying appropriate patients and patient and family attendances can be really difficult to try to reach out. The patients that need it most are often the ones most difficult to reach, because they'll be the lower socioeconomic class and digitally excluded, and it makes it very difficult. Next slide, please. This is just some of the various options for delivering your clinic: one-to-one, panel, carousel, and group models. Next slide, please. And whether you use virtual or in person, and we're now primarily virtual, and that's working well. And I think we've seen from previous talks today how virtual works very well for patients, and they get you can get a lot out of it, but you do probably need a bit of a hybrid model. Next slide, please. Yeah, this is just to show the virtual platform that we use, which has been very, very helpful. Next slide, please. And as you can see that you can utilize staff who've been shielding from COVID for other reasons. That's certainly how we managed to use it, which was excellent. And it also allows flexibility with working, and there's a unique opportunity to see patients in their own home environment and understand what the balance barriers and challenges are for them. Only the clinic yesterday, I saw a patient who was surrounded by mold in the house, and you know, really struggling to cope with their housing situation. Next slide, please. I don't know if we've got time to do this, but I think we may need to stop because we're probably running over. But this was stuff that Josh shared with us about how we can develop a clinic at Cleveland Clinic London, utilizing the experience at his institution, using their Epic recruitment dashboard. Maybe you want to just a few minutes to chat about that, Josh.
Sure, thanks, and sorry I had a little connectivity issue there before. As Andy talked about, there's many known barriers and facilitators to the successful implementation of an ICU recovery clinic. And one of the barriers we've been trying to overcome is patient and family member attendance. And we've operationalized that to try to improve our identification of patients that would thought to be of benefit from a visit in the post-ICU recovery clinic. And we've used creative problem solving with our IT colleagues to create a dashboard that's tracking patients throughout their hospitalization that have risk factors that we previously discussed for the development of post-intensive care syndrome and the other, large life hurdles that ICU survivors are challenged with that Andy went over with us. And we're hopeful that our IT utilization and creation of a dashboard is going to improve our patient recruitment to the ICU recovery clinic. Next slide, please. And when patients get to the ICU recovery clinic, it's only once that they're there and that barrier is overcome that we can use some of the many screening tools available to evaluate the enduring impairments that occur amongst ICU survivors. So here is a list, although not completely 100% complete, of all the available screening tools available. In the coming slides, you'll see some that we use in our ICU recovery clinic and that we're trying to more easily integrate into our workflow. Next slide, please. Here's a sample. of the way that we start the functional reconciliation of ICU survivors. And like Andy mentioned, it's over the care continuum, and patients' journey with critical illness. For some, it never ends. Some people live with enduring impairments from their episode of critical illness for their entire life. So coming up with a way to continue a functional reconciliation of an ICU survivor over time is important. And at the Cleveland Clinic in Ohio, we're blessed with a team of very hardworking, motivated clinicians, and we pride ourselves on interdisciplinary teamwork, and we're continuing to refine our operational processes. And having a standardized note template, as you see here, is one of the ways that we're moving forward to try to make the workflow for clinicians and patients easier in the post-ICU recovery clinic. Next slide, please. On the left side here, you'll see some of those screening tools that we use to assess for functional impairment, mental health impairment, and neurocognitive impairment, as well as many social determinants of health that are all too important for an ICU survivor. And one thing that we haven't touched on is the concept of social isolation, and social isolation is a big risk factor for development of future frailty, and can reduce one's quality of life, and actually in certain populations can increase the incidence of hospital readmission. So as our ICU survivorship clinic grows over time, we're looking for ways to overcome the patient's impairments by looking for a structured way to get them more integrated back in society. And on the right, we can kind of see a summary statement with some common diagnoses as well as common referrals placed out of our clinic to come up with a care plan moving forward. And we've started to see our ICU survivors back for follow-up visits to ensure they can get to their subspecialist referrals if they're found to have impairments that we think they would benefit from. And a copy of every visit is coordinated with the primary care physician to kind of help in the interim between visits in the ICU recovery clinic. And I'll turn it back over to Dr. Slack, and he'll kind of finish off the presentation for us.
We may need to stop there, Josh. I think we've shown our enthusiasm, commitment to this subject, and I think we've well overrun our time. I don't know what Michelle thinks. We could go on.
Yeah, can you hear me? I think this is a
Yes.
great presentation. If Andy or George want to say a last statement, and then we can move to Dr. Boer and Dr. Ramsey.
Did you say a final statement? A final statement from me would be that I hope that COVID is going to be beneficial for all those non-COVID ICU patients out there. We've learned a lot from the COVID disease, recognize the holistic and multi-professional working that we need, but there are many barriers which still seem to be put in the way of delivering this kind of service, whether it's in the UK or the US or anywhere else in the world. But thank you very much for the opportunity, and sorry we went over so long. It's because we love this topic so much.
I agree, me too. So wonderful. So I'm gonna go to the next and last session. So I would like to introduce my my colleague, Dr. Jennifer Ramsey. She joined the RI in Cleveland Clinic in 2010. She is trained in pulmonary and critical care and became boarded in palliative medicine in 2012. And she has now shifted her practice with 2 hats of critical care medicine and palliative medicine. She was named the inaugural Respiratory Institute Wellness Officer and recently became the vice chair or the vice chairwoman of critical care medicine. I would like also to introduce Dr. Filipa Bora. She has been a consultant at Imperial NHS Healthcare Trust since 2009. She has she's appointed as a cardiac anesthetist originally, and 10 years ago she set up the new cardiac ICU. She has been the lead clinician for anesthesia and critical care, cardiac critical care at the Hammersmith Hospital, Imperial NHS. Welcome both, and it's all yours. Thank you very much.
Can I say something? Sorry. Do you think it would be better if I went first and Jenny went second? The way that we've.
Yes.
Is that possible?
Yes. Dr. Boer will go first, and then Dr. Ramsey. Yes, perfect. Thank you.
Okay, so thank you very much for inviting me. You're pleased to know that I'm actually frightened of George, so I did limit my slides to 8. Obviously, everybody else is braver than me. PTSD and staff sickness. I obviously have only been able to look into the sickness side of things in my own trust. And I found it pretty disturbing, actually. A lot of what I'm going to cover here has already been covered, sort of, in the resilience talks from Susan and Sean. But what I have to say, I think, chimes with what they said as well. So obviously, we've all felt like this in COVID. Do we have PTSD? I don't know. I think probably we all do, for the reasons I'll go into. But this isn't just frontline workers, is it? It's difficult to unpick how much worse what we have been through is than the rest of the population. The rest of the population is accessing mental health services and counselling and reporting much higher anxiety levels, etc. So what is PTSD? Could I have the next slide, please? So when you look around this sort of basket of symptoms for post-traumatic stress, we've all felt anxious. We've all had sleep disturbance. I think I recognize a lot of this in what I've been through, and I've certainly witnessed in my colleagues. I've seen very calm colleagues react to very small provocation with insanely over-the-top emotional reactions. And I think that's, I've seen that quite a lot. And we've all, I've certainly had sleep disturbances and some pretty grim dreams, to be honest. But the point about PTSD is that following a traumatic event, and we think of this usually in terms of military personnel or being involved in a violent crime or witnessing a rape or being involved in something like that, and not really so much as healthcare workers. It gets better over time in the majority of cases as the traumatic incident recedes. But there is a proportion of people that then go on to develop. They have a much, much higher incidence of depression, everything from depression to all sorts of mental health diseases, but also ultimately ending up in self-harm and suicide. So it does need to be taken seriously, incredibly seriously. And obviously at its worst form, it's debilitating to a point where you cannot function in your home or professional life. I have seen people who have been certainly on that on the cusp of that and have had to have periods of time off work. So I think it is a real thing. Can I have the next slide, please? So this is sort of a repeat of what Sean said. I think this is a really useful way to look at it for COVID. It gives us a framework that we can apply to COVID, because this is the meta-analysis from the British Journal of Psychiatry in 2018. And they're looking at all the papers relating to occupational moral injury. And by that they mean being part of something that violates your deeply held moral values or beliefs. And I think we can, I can think of so many examples where both as human beings and as professionals, the sort of standards that we're used to expect have just literally been thrown under the bus. You know, we could be talking about staffing levels, you know, the fact that what we consider to be safe standards for both nurse and doctor and AHP patient ratios have been massively stretched, and we're in a position where the standard of care that we expect from ourselves and our colleagues just simply isn't possible to deliver because of the pressures. we've seen a lot of iatrogenic complications in the UK to do with just not having enough properly qualified people and a lot of redeployed staff. We've seen a lot of line sepsis, even some pressure areas that certainly wouldn't have happened in normal times with normal staffing levels. And the sort of stress that comes when you're thinking, I mean, in the NHS, it's almost been sometimes feels like a tap that one can't switch off. And you're sort of driving to work thinking, what are we going to find there today? And that is very traumatic. And even if it's not true, the possibility in your mind that there might be some sort of triage going on, some sort of rationing, it all adds to a violation of your deeply held moral views, to be honest. So I think it is quite a useful way of looking at it. Although, as I said, we normally what we're thinking about with PTSD is the military. Can I have the next slide, please? So this was there, as Sean alluded to, there are a lot of studies, mainly done by professional institutions, professional bodies, or big healthcare institutions, pointing to the fact that people are reporting much higher levels of mental health issues and alcohol issues and sleeping disturbances. Also, that the returns from these surveys are much higher as well, and I'm sure those two things are related. When you look at them, though, up to now, a lot of them haven't really had enough granularity. They've surveyed all doctors, all nurses, and not particularly focused on specific groups and being granular enough, I think. There are surveys that contradict each other when looking at the level of or the types of mental health conditions in the general population as opposed to frontline workers. So I think lots more needs to be done to try and unpick that. So in my experience at work, nurses and doctors don't go into work and say, I've got PTSD. So I was thinking about how do we look at some surrogate markers which might point to people, colleagues and frontline workers suffering from some of the effects of post-traumatic stress, but not actually saying so. Can I have the next slide, please? And this I find extremely disturbing. So this is Imperial Critical Care nursing staff. The little blue bars you can see are, this is sickness reported for reasons of anxiety, stress, depression, any psychological issue. I've been working, I got these figures. The nurses keep fantastic data, I must say, and they've got a fantastic statistician working with them. So this is, in the little blue bars are 2019. And you can see they're just bobbing along the bottom there. They don't really, the gray bars are 2020, and the sickness for reasons of mental health don't really start going up until July. So they remain low throughout the first wave. We came off our surge rotas at the end of May, I think. So they're pretty low until afterwards. And I think this chimes with what Susan was saying about the kind of trench mentality, aren't we all heroes, we're doing something great. And then afterwards, the sort of downer and, you know, exhaustion and really feeling that this wave had taken its toll. So the grey ones go up and throughout 2020, and then the dark blue ones are 2021. And so it stays at the same level as the end of 2020 until, again, the end of the wave, and then it starts going up. And that's a pattern that's repeated, as I'll show you. Could I have the next slide, please? It's pretty awful, isn't it? I'm finding it very disturbing. So here we have the levels of sickness for all the kind of self-reported reasons. So diarrhea, gastro upset, back pain, migraine, everything that you don't need to visit a doctor for. The green line is 2019, and the blue line is 2020. And you can see they're exactly the same, that after the wave, sickness for all reasons goes up. And the yellow line is 2021. So it's a significant difference. It's a fourfold increase in staff sickness. Could I have the next slide, please? I think this rather repeats what I've said, so could I have the next one, please? So this is medical sickness at the Hammersmith, and it's a much lower scale. If I put this on the nursing, on the same scale as the nursing graph, it would just look like a wiggly line at the bottom. But essentially, pre-COVID times are the first 3 months or 4 months, October to January 2020. And that's, so the orange line is the junior doctors. Could I go back to that slide, please? The orange line is the junior doctors, and the green line is the consultants. And there is a sort of pattern with the consultants. There's almost no absence at all during the waves, and then it goes back to normal levels. The juniors are a bit more variable, but the important thing with both groups is that their post-second wave and post-second wave rates of sickness are the same as pre-pandemic. So the doctors, which we can discuss if you like, maybe afterwards, after I've finished, if anybody has a question, I've got a few theories, are off sick a lot less, which is interesting, and it will be interesting to know why. And the next slide, please. So the other thing one can look at is staff turnover. So there's 3 main units within Imperial, and each one of these is a different unit. But what to take away from this is between April 19 to now, each unit has around about a 12% increase in its baseline turnover. So I think this is a real problem, and I would be surprised if this was not a pattern that we were seeing in large trusts in London or in the UK or altogether. I think what's being done about well-being and cognitive behavioural therapy, which is proven to work, but I'm going to let Jenny talk about all this, is really, really interesting and really good. Our trust did have quite a comprehensive well-being programme, and certainly in the second wave, access to CBT and counselling. What I have not managed to find, and it's probably too early to find, what would be interesting to know is the impact of those things on mental health. I suspect you could compare the 2 waves, because a lot of it was put in place. Well, we certainly got better at it as we went through. The feedback from the after action reviews in our trust are that they liked the well-being was well received, and especially the cognitive behavioural therapy was extremely well received. But what the nurses said repetitively was that what would make them feel less stressed would be better staffing levels and, in other words, better qualified staffing levels, and to be working more within the kind of framework and patterns and patient ratios that they were used to, and that's what gave them the most stress. And the second thing that gave them the most anxiety was the difficulty in communication with the relatives and families, which also resonates with what was said earlier, that it's just an incredibly stressful thing for all the members of staff. So I think lots more work needs to be done into, and I'm sure it is being done, into trying to drill down on exactly which interventions are going to help. And obviously we don't have data, a baseline from before the pandemic with all this in place, which is a shame. But yeah, it would be interesting to know what other trusts in the UK have experienced. And I was quite disturbed to see how the effect on the staff, even with quite a well-developed well-being program. So that's all I've got to say.
Okay, well, thank you for inviting me to be part of this, Dr. Bora. That's fascinating, and I agree with you. It is really something that we have to pay attention to. It is scary, and thank you for giving us such personal insights into what you're seeing. One of the best things about this conference to me is, I guess the psychologist would say, normalization of what we are all going through. That this same, your feelings are what we are seeing and what Abu Dhabi is seeing. We're seeing it all over the globe as healthcare providers, and it's helpful somehow. It helps. So I promised Michelle, I am actually going to read my section. Whoever is still on the phone, you guys are real troopers. So thank you for inviting me, and thanks for staying until the very last session. I'd like to talk to you today about some support efforts we've done since this pandemic started and some lessons that we've learned along the way. Next slide, please. So to start talking about this, about support efforts and the lessons we've learned, I actually ask for you to go back with me to the very beginning. The time, do you remember the panic and the real fear that we were feeling? Would we have enough PPE? And some of us didn't. Will I survive? Will I bring this virus home and kill someone that I love? Will one of my colleagues die? Will I have to take care of one of my colleagues in the ICU? How will we manage that? Do you remember the need for that decontamination ritual when we left work? This ritual that was going to somehow protect our families from what we were doing every day. And do you remember that off feeling that the whole world, kind of like the apocalyptic feeling that the whole world was weird and it was just off? The things that we could never have predicted were happening, and the things that we didn't really understand, but that impacted us on the most basic level. And in that moment, when we weren't sure what was about to happen, we knew we needed to help, but we weren't really sure how to help. So we just started taking action and doing things and hoped that it would be enough. Next slide, please. So one of the things we did is that we formed neighborhood groups. We grouped our physicians based on their home zip codes, because in those early days, the grocery stores had not started delivering food or have the order online and pick up. And so if your home fell quarantine for 2 weeks, you could really be in some serious trouble. So these neighborhood groups were able to bring each other food easily within, they were in close proximity to each other's homes. So, and we put them, they worked. We used them to deliver groceries, food, Tylenol, McDonald's for the kids. We dropped off toys and puzzles and books for kids to keep the kids entertained while their sick parents could rest. Next slide, please. We formed a peer support. Next slide, please. Thanks. We formed a peer support task force group, which I'm hearing some feedback. I'm not sure what's going on.
I hear that, to make sure everyone is muted.
Thank you. We formed a peer support task force group. It was 58 members from all disciplines, multidisciplinary, inpatient and outpatient. And the purpose of this group was to have peer support peers. So to virtually walk through COVID together and to provide listening and understanding as only peers can do. Psychologists in-serviced our group in how we could share some coping skills with our peers and also how to help introduce some psychological support. The groups called colleagues daily, called families to check on them, delivered groceries at the hotels if somebody was isolated and quarantined at a hotel. And also connected our colleagues to the neighborhood groups if the colleague wanted to be to activate that. Next slide, please. And from this peer support task force group, we recognized that one of our groups, the respiratory therapist, actually really needed some special attention and a special pick-me-up. So we threw a pancake breakfast to show appreciation and support, thinking that this pancake breakfast would help our respiratory therapist. And what we learned is that it actually helped us. We needed to be together, we needed to have fun and make pancakes. And we realized how much we needed it, actually this was a really important lesson, as you'll see as I go on. Next slide, please. At the enterprise level, people were also very busy creating support and resources, both on the practical levels and the emotional support levels. The Office of Caregiver Experience supplied caregivers who were sick with COVID and their families with hot meals or groceries delivered to their doorstep, and then also hotel rooms, both for sick colleagues and also people who, frontline caregivers who didn't want to risk bringing COVID home to their families. And our employee assistance program, the psychological side of us, and the Department of Psychiatry created this amazing array of ways to access emotional support. So they expedited face-to-face office visits. They created virtual visits. They had these boost phone calls. You could call in for 15, 30 minutes and just, you know, release, vent, get some boost to you. And then there was also an emotional support hotline that was available 24 hours a day. Next slide, please. And then the schools started closing, and all of the working parents struggled to find, you know, ways to take care of kids and keep taking care of patients, keep coming to work every day. So the Cleveland Clinic contracted with a nanny service and had some services through that nanny service. And then we in the RI, the Respiratory Institute, we looked for community resources. And every week there was a section in our town hall meeting where a respiratory therapist and I would share the community resources and the resources that the Cleveland Clinic were offering with our group to hopefully help people. And then also offer to independently and privately liaise with people who might need direct connections to meet their family's needs. Next slide, please. And over time, we learned to structure the wellness efforts better. We kept the multidisciplinary peer support task force group, which is a powerhouse group. And then we also added some structure to physician wellness by creating physician wellness champion groups for each department within the Respiratory Institute. Next slide, please. One of the main things I think that I learned personally is we shifted where to build the programs for wellness. At the start, I think the focus was on building new resources and new programs for people. But as everybody on this call knows, it is really hard to get critical care folk away from the bedside when at work and away from their team, leaving their work for somebody else to do. And rightfully so, it is very hard and probably wrong to ask people to give up some of their personal time that they could be spending with their family to go to something to get well. So now our tactic is, how do we weave this thread of wellness, of team support, of emotional support throughout the already established work routines and rituals, so that paying attention to our emotional and physical health becomes part of our culture and just part of our daily lives at work. Next slide, please. So some examples of interlacing wellness into the regularly scheduled programs, if you will, occur at department staff meetings, at leadership meetings, and at town hall meetings. We take a moment at these meetings to share our smiles. So we ask everybody to send in pictures of cute kids, cute pets, running marathons and getting a ribbon, Dr. Beal. Or we take time to celebrate our notable disconnects. So when you disconnect from work and you go home or you go somewhere, you know, share your vacation pictures, share your Saturday at the zoo with the kids pictures, so that we can all celebrate disconnecting from work and share and celebrate the importance of disconnecting from work. Recently, Dr. Dweck has added an empowerment segment into our town hall meetings and our leadership meetings. With a special guest each week, a colleague will share how they keep themselves empowered and strong, how they keep their families strong or their teams empowered and teams together and strong, or how they are able to keep their heart in the game, how they're able to keep caring when they're so tired and worn thin. Next slide, please. And because we had so much fun at that pancake breakfast, and because we all need boost in spirit, please do not think that leaders do not need wellness or boost in spirit or rest and refreshes. We are now doing regularly scheduled events that we call random acts. So random acts of kindness, random acts of joy, random acts of fun. We've had an ice cream event, and we're planning another pancake breakfast because it was so fun, and a chocolate fountain event. And then personally, I can't wait for the Halloween random act event, where the teams, the ICU team's leadership will dress up in costume and go pass out candy at the bedside. And there will be a costume contest that the ICU people, the people working, can vote on. Next slide, please. And last, I'd like to close by speaking personally to everyone at this conference, if I may, because we all do share what Dr. Bora said. We are all in this together, and we are all doing our best. We're all tired, and we're all in various stages of grief and trauma and healing and recovering. And truly, we must find some way to take a breath every day, to find a moment every day of peace and quiet, and to find joy and goodness that is still in life. Because to make all of this worth it, we have to remember the joy and goodness that we have in life. We are in a marathon. And so some ideas for this. I'd like to share a colleague's idea of how to take a breath every day. This came from one of those empowerment sections that we have at the town hall and leadership meetings. And Dr. Karan Saran shared his template for choosing these are the inclusion criteria of this taking a breath every day. It has to be daily, it has to be simple, it has to be meaningful, and it can't take a lot of time, and it does take commitment to do it every day. He chose to commit to pulling his kids in the little red wagon around the neighborhood every day. And I think it's just a great example for us to think about how might we include something like this daily ritual of a breath, of peace, of quiet, of recovering our joy every day. Next slide, please. And finally, on this personal note, I'd like to touch on compassion and kindness for others and for ourselves. We may notice in others shorter fuses, as Dr. Bora mentioned. We may experience sharp tones. We may actually get bitten with words, hopefully not actual teeth. We might see our colleagues fall apart in tears, and we might see our colleagues just sort of flaccid with fatigue and just can't do it at that moment. In these moments, compassion, kindness, and grace are life-altering and healing and bonding. And as we give others our forgiveness and grace, we can pray to God that when we have those same moments, that we get the same in return as we show our own wear and tear. And just as important is compassion for ourselves. And let me just say that again, that we must have compassion for ourselves. We are such type A people. We are all perfectionists and high performers, and our limitations can be frustrating and even painful to us. But we are all human, and we are imperfect as humans, and we are built as humans to make mistakes, and we are built to get tired and need rest, and we are built with a limit. And when we get in touch with our limitations, I'd like to invite you to please reframe how we label those moments so that we can relabel them from moments of mistakes or failure to moments of being human, moments to forgive ourselves as we would a friend. And we can take this even further and realize and recognize and even rejoice in the fact that this humanness is what connects us all. It is exactly what connects us all. And then as critical care people, as such team-based people, we know that this connection to each other is exactly how we have survived this pandemic so far. And it is exactly what will help us to survive whatever it is to come our way in the future. So thank you very much.
Well, Philippa and Jennifer, you have closed this day with staggeringly powerful insights about the impact, really the wholesome impact of this recent couple of years. And I think sent a global message just there at the end, which has been really sent shockwaves through me, and I think the rest of the audience here as well. I do think that you've highlighted what the real crux is for critical care going forward in the next 5 to 10 years. And for that, I thank you. I need to resist the temptation to ask you questions because of the time having expired. But I'd just like to finish by thanking Michelle, Kristen, my new colleagues in Cleveland, Ohio, as well as Josh, Philippa, who I look forward to working with, and Andy, who I know well. It's been a pleasure to chair this session together with Michelle, and I think we need to adjourn it now. So over to Nick. Thanks very much.
Joe, thank you so much. Thank you very much, Michelle, and thank you very much, Jenny. That was a beautiful sentiment to end this meeting on. I don't want to really speak for too long. I just want to say a few thanks. First of all, I really must say a thanks to Maria, who has selflessly, metronomically tapped the slides forward. And if there was a delay, it was only because of the networks, not because of Maria, that's for sure. She's just come to us from Abu Dhabi, and we kind of made her work all Friday and all Saturday. And I'm going to say to you, Maria, this is the most difficult it's going to get. It's going to get easier. But thank you very much for helping us. We couldn't have done it without you. I really must thank Luigi and for Georg, who's left us to go back to Austria. I think he has family there. But I really must thank, they're the architects of this conference. They put a lot of work in. They've done a lot of liaising with Abu Dhabi and Cleveland to make all this hang together. And I know it was always going to be a challenge with timing to get so many speakers in. But I think having so many people to have such a, if you like, a big family event has been so valuable. I want to thank the audience, those who remain at this time on a Saturday. I want to thank all the speakers, some of whom we have quite a few in our offices, and I want to thank you for really hanging on and for contributing so much. And I think really what's been valuable about this is to really leverage the sort of the reach of the Cleveland Clinic, which reaches into Arabia, Asia, Europe, and the US. I think it's a unique organization in that way, and we've heard across the last 2 days lots of different stories, lots of different thoughts and experiences from our different cultures, with a lot of themes that run together. And I think what we're really seeing here is the birth. And what we wanted to do with this was really announce our birth and say to our siblings who are a little bit older than us that we're here. We have a lot of people with very valuable skills, knowledge, and ideas. And we want to join with you, and we want to join with Abu Dhabi, and we want to all develop together. And I think this is This event has hopefully launched a lot of relationships, a lot of ideas, and a lot of thoughts, and hopefully which will come to maturity in the future. And I think I'd just like to leave it on that note, and we hope to all see you in person one day, over here or over there. And thank you very much, and good night.
Thank you.